Good morning, guys. Can you all hear me? Can you all see me? Quick feedback. Can we start? Quick feedback. Good morning, guys. Good morning, good morning, good morning. Chalo, let's get started with the marathon. Today we'll try to keep it crisp. I know exam is just a week later from here. So we'll try to keep it as much crisp as possible, to the point. We'll revise all your previous year topics so that we can just complete it in a jiffy. All right. Good morning, guys. Good morning, good morning, good morning. Chalo, let's get started. The first topic is again your exam spotters. We'll start with a very basic one. Drains से शुरू करते हैं. So there are two varieties of drains that you have: open drain and the closed drain. Now, when I say what is the difference between an open drain and a closed drain? Imagine if this is the cavity, any cavity that is present, and you put a drain, and you leave it like this. If you have a drain like this is called as an open drain. What is a closed drain? Again, there is a cavity. There's a cavity, you put a drain inside the cavity, but this drain will have some collecting component. It will have some collecting component. This is called as a closed system drain. That's the only difference, right? डायग्राम देख के पता चल जाएगा, जहां पे कोई कनेक्टिंग बैग नहीं है, कोई कलेक्टिंग यूनिट नहीं है, उसको आप ओपन ड्रेन बोलोगे. जहां पे आपके लिए कनेक्टिंग या कलेक्टिंग बैग है, उसको आप क्लोज सिस्टम ड्रेन बोलोगे. ऑलराइट, ठीक है. नाउ examples of open drain याद रख लेना. there are corrugated drains which are going to be latex. Latex जो होगा rubber का होगा, yellow in color, orange in color. Silicon drains will be your transparent ones, and Penrose drain will be like a rubber tube. We'll show you in a bit. Closed system drains are divided into two components: active and passive. If you're exerting pressure, if there's a negative pressure, active drains are those drains where you require negative pressure. आप sucking pressure exert कर रहे हो. Passive drains, they drain due to capillary gradient. Capillary gradient basically means difference in pressure. Capillary gradient basically means difference in pressure. Capillary gradient basically means difference in pressure, high pressure to low pressure. Active drain के examples क्या हैं? You have Romovac drain, Jackson Pratt, Topaz and Atmos. These are two new drains that I've introduced here. T-tube, which is Kerr's tube, Intercostal drain, Foley's catheter, Ryle's tube and Robinson's are your passive drains. Now let's do a quick spotter. The image number 1 that you can see here, this is what we call it as Topaz. It is a negative suction drain used in thorax. It is a negative suction drain used in thorax. Another image, this is again a spotter. This is called as Topaz. This is what we call as Atmos. Atmos is also a negative suction drain. There is also a negative suction drain used in thorax. It's also negative suction drain used in thorax. Now this, I hope everybody will be able to know. This is spotter number 3. There is a bag. This bag has this V-shaped configuration at the bottom where you have water column. Rest of it is there, and then you have tubing with fenestration. This is your ICD bag and ICD drain. That is your intercostal drain. If they ask you what is the size of the ICD preferred in children, remember in children we prefer an 18 French ICD, and in adult we prefer a 28 French ICD. Image number 4, it is easy to remember. This is your silicon corrugated drain. Image number 5 is, you can see same drain. See, again, this is an open drain. No? There is no collecting unit here. See, the above three, all of them have collecting units. So all of them are a closed drain systems. These two are active. This is passive. Right. Now, silicon drain is, corrugated drain is an open drain. This is, again, see, you can see this is orange in color. So it is latex. So this is your latex corrugated drain. This is your latex corrugated drain. If you see a rubber tube like this is your Penrose drain. This is your Penrose drain. Now the negative suction drain starts from here. This is what we call it as the Romovac drain. This is your Romovac drain. This is your Jackson. This a bulb is there, and then you have a tubing and a fenestrated end. This is your Jackson Pratt. This is your Jackson Pratt drain. This is your nasogastric tube, which is also called as the Riles tube. They'll ask you what is the length of the Riles tube. The answer is 100 centimeters. What is the rule that you follow to adequately insert the nasogastric tube? We all know it is called as the next rule. Sabko next rule pata hai na? What is the next rule? What is the next rule? Next rule kya hai? The next rule is you take the Riles tube, measure from the nose to the tip of the earlobe, from the tip of the earlobe to Xiphus sternum. Jitna length banega utna insert karna hai. That is what we call it as the next rule. This image number 10, again, everybody knows it. It is what we call it as T-tube, or also called as the Kher tube. Also called as a Kher's tube. Now, this is because it is transparent. I'll call it as silicon. And this is latex. So, it is a latex-based T-tube. So, silicon-based T-tube is here. And latex-based T-tube is here. Right? This is your Robinson's. This is your Robinson's bag. We call it as a Robinson's drain. This is put in abdomen. It's an abdominal drain. This is an abdominal drain. There's a abdominal drain. Okay. So this is the basic. This slide you have to remember for the exam. ठीक है. इसमें से ये पता होना चाहिए कि कौन सा active है, कौन सा passive है ना? Which of the following is having a closed system and open system drain? I've explained it to you very clearly. अगर कोई opening collection के लिए नहीं है, this will be an open system drain. If you have a collecting unit, this is called as a closed system drain. इतना ही difference है. Then you know whether it is an active or a passive drain based upon the negative pressure. If the pressure is exerted, it is going to be active. Otherwise, it is going to be a capillary gradient pressure. Otherwise, it is going to be a capillary gradient pressure. ठीक है. That is slide number 1. Now, बेटा सब आएगा pigtail, T-tube सब पता चला, कोई टेंशन नहीं है. ठीक है. Now, additionally, if they want to ask you, they'll ask you T-tube removal time. T-tube removal time. है ना? Then they can ask you Romovac removal post mastectomy. Then they can ask you Romovac removal post thyroidectomy. Post thyroidectomy. The 3 points that they can ask you. Quickly tell me. T-tube removal बताइए. Very good बेटा. T-tube removal is 10 to 14 days. Absolutely correct. Very good. कौन था वो? Sanvi. Very good बेटा. Okay, Romovac removal period time. Post mastectomy कब निकालोगे? Remember, after 5 days. After 5 days. ठीक है. Post thyroidectomy after 24 hours. After 24 hours, right? So this is your drain removal period. Extra agar they want to ask you. Now, if they want to step up a little bit, they can ask you the Foley's catheter, color codes and all. पहले color code देख लेते हैं. Mnemonic है, Gori is very beautiful. G stands for green. Green is 14 French. Next is O. O is orange. It is a 16 French. Then R stands for red. Red is 18 French. Y stands for yellow. Yellow is 20 French. V stands for violet, which is a 22 French. And B stands for blue, which is a 24 French. Right? So this is the color code of the cannula. Now, one question that they can ask you in the exam is, what does French stands for? It is the outer diameter of the tube. This is the outer diameter of tube. French stands for the outer diameter of the tube. It is the outer diameter of the tube. Okay. Now, these are the spotters. Standard, everybody knows it. This is your Foley's catheter. This will be your plain Foley's catheter. This is your three-ways Foley's. Three-ways Foley's catheter is for basically bladder irrigation. Now, Foley's catheter can be kept only for 2 weeks. We can't keep it more than 2 weeks. So, if you want to catheterize a patient for more than 2 weeks, if the catheterization requirement, if the requirement is more than 2 weeks, then we will use silicon-based catheter. This is your silicon-based Foley's catheter. It is a silicon-based Foley's catheter. Now, this is what we call it as pigtail. This is your pigtail catheter. And this is your DJ stent. DJ is your double J. DJ is your double J stent. Now, what I've changed is, you can see in pigtail, the curve will be present only in one end. DJ mein curves are present in both ends. Both ends you have this twist. This is going to be double J stent. DJ stent is used for ureteric surgeries. Okay? Pigtail is used to drain any collection. Now, if you see a Foley's catheter with a curved tip, it is a curved tip. This is called as a Cordais Foley's catheter. It is Cordais Foley's catheter. Whenever you have a urethral obstruction, example like BPH. So, catheterization in patient with BPH. Catheterization for a patient in BPH, I'll be using Cordais Foley's catheter. As simple as that. Right? So, this is with respect to Foley's catheter. Now, one additional question that they can ask you is that if you're, okay, first of all, what do we use to inflate the Foley's balloon? In order to inflate Foley's balloon, what are you going to use? We are going to use distilled water. I'm not going to use air because it will float. I'm not going to use any crystalloids because it will crystallize and cause, when you're trying to deflate the balloon, it won't happen, right? So to inflate the balloon, I will be using distilled water. If you are unable to deflate, then what will you do? It is USG guided puncture. It is the USG guided puncture of the Foley's catheter. Right. Now, when you look at a three-way Foley's catheter, what are the three different components that you have? In a three-way Foley's catheter, you have three tubes which are present. In a three-way Foley's catheter, you have three tubes that are present. This is the tube number 1. This is the tube number 2. And this will be a tube number 3. One that is going to have the color code is the balloon inflating channel. With the color code, whichever is there, that is for balloon inflating. The wider one, the largest, the biggest of all, when you look at the diameter, the biggest of all is urine collection. And the smaller one is going to be for irrigation. So, big channel The big channel is for urine collection and the smaller channel is for irrigation, right? So these are the bouncers that they can ask you in Foley's catheter. Correct. Okay. Now you know the Foley's catheters, color code, all that. Now you'll go with cannulas. Now the cannulas are easy to remember. We have a small mnemonic. The color code of the cannula, the core of the earth is made up of lava. Lava is orange in color, it is 14 gauge. Soil is grey in color, 16 gauge. Tree is your green color, 18 gauge. You have pink flowers, 20 gauge. Blue sky, 22 gauge. Yellow sun, 24/7, 24 gauge. And the violet universe is your 26 gauge, right? So this is the whole color code of the cannulas. So we have 14 gauge. The color is going to be orange. We have the orange colored 14 gauge. The flow rate is 240 ml per minute. Then you have gray 16 gauge at a flow rate of 180 ml per minute. Then you have green. Green is 18 gauge at a flow rate of 90 ml per minute. Then you have pink. Pink is 20 gauge at a flow between 60 to 65 ml per minute. Then you have blue sky. Blue is 22 gauge with a flow rate of 30 to 35 ml per minute. Then you have yellow sun, which is a 24 gauge at a flow rate of 20 ml per minute. And the last one is violet, 26 gauge at a flow rate of 12 ml per minute. At a flow rate of 12 ml per minute. ठीक है? Clear? So this is all your color codes and their flow rates that you have to remember. This is the mnemonic that you remember with respect to the color codes. Sorted? Chal. Now again, few important spotters. This might be a bouncer for you. What is the image number 1? Kya hai beta ye? What tube that is you see? There's a flower shaped structure here and there is one collecting channel. That's it. What is this? This is what we call it as the Malacot catheter. It's a Malacot catheter. Okay. Image number 2, you see there's a long tube is present. There are fenestrations at the end and there are 2 channels here. This is your nasojejunal tube. Now, nasojejunal tube is used for feeding. It is basically a feeding tube. Now, this could be another bouncer. You can see there's a shorter tube. There is balloon at one end and then you say stopper at another end. Then you have 3 channels which are present. Channel 1, channel 2, channel 3. Right? So, what are these? Very good, beta. What are these? This is your PEG tube. That is percutaneous endoscopic gastrostomy. It is percutaneous endoscopic gastrostomy. Is a percutaneous endoscopic gastrostomy. That is your PEG tube. Then you have this balloon tamponade tube. These are your balloon tamponade tube. In the balloon tamponade tube, I have given you 3 examples. One is your Sangaskin-Blakemore. Sangaskin-Blakemore. Second is your Minnesota. And third one is your Linton. What is the difference is, this will have 2 balloons. Sangaskin-Blakemore will have 2 balloons. Minnesota will also have 2 balloons. Sangaskin-Blakemore have 2 balloons. Linton will have a single balloon. Sangaskin-Blakemore will have 3 channel. Minnesota will have 4 channel. Linton will have 3 channel. That's the difference between Sangaskin-Blakemore tube, the Minnesota as well as your Linton tube. Now, in the Sangaskin Blakemore tube, another question that they can ask you is, when you're inflating the balloons, what are you going to use the inflation for? The two balloons, one is your esophageal balloon. Esophageal balloon, for esophageal balloon, you will use air to inflate at a pressure of 40 millimeters of mercury. At a pressure of 40 millimeters of mercury. Then you have gastric balloon. Then you have gastric balloon. Again, here I will be using air, but this time I will be using 300 cc of air. So these are the quantities that you will be using for inflating these balloons. Clear hai? ठीक है. So all these bouncers also we have covered it. If they want to make your exam difficult, they'll ask you one of these 4 tubes. As simple as that. ठीक है. चलो. Now we go with minimal invasive surgery, that is your laparoscopic. What they can ask you. First spotter is right in front of you. Now this is a port and trocar. Now port is going to be solid, hollow structure, and trocar is going to be solid. So you can see here, the solid one is going to be trocar. And the hollow one is what we call it as port. So the trocar and the port together you put it, and then you remove the trocar. The hollow, that is the port, is created through which you can put the instruments. As simple as that. Most of the trocars that we will use will be sharp, so they have probability of injuring the structure. To avoid this, we have a blunt trocar, an atraumatic trocar. This is what we call it as an atraumatic trocar and port system. And this is given a fancy name. This is what we call it as the Hansen's port. This is your Hansen's port. You can see here, this is blunt. It's a blunt tip trocar. It is a blunt tip trocar. It's a blunt tip trocar. Another image that you can see here, this is what we call it as Sills. Sills is your single incision. Now this is your exam question. What is this? This is your Veress needle. This is your Veress needle. Now first question is, what is the Veress needle used for? It is used to create pneumoperitoneum. Second question, what is the angle between the Veress needle and skin? The angle between the Veress needle and skin at the entry point is 90 degrees. What is the angle between the Veress needle and body? The angle between the Veress needle and the body is at 45 degrees. It is at the 45 degrees. While entry, the needle is pointed towards. During the entry, needle is pointed towards. Now, the needle is pointed. Is it towards the Ziffy sternum or towards the pelvis? Remember, always it is going to be pointing towards the pelvis. So it is used to create pneumoperitoneum. The angle between the needle and the skin is 90 degrees. The angle between the needle and the body is 45 degrees. The needle is pointed towards the pelvis. It is pointed towards the pelvis. If there is an accidental injury, if there is an accidental injury due to Veress needle, the answer is keep the needle in situ. Keep needle in situ and convert to open. And convert to open surgery, that is exploratory laparotomy. This is the objective of Veress needle. All of them are important from the exam perspective. Okay? Now, if there is a previous laparotomy scar, if there is a previous laparotomy scar, now because of the previous laparotomy scar, this is the previous laparotomy scar which is present here. In a previous laparotomy scar, there's a lot of fibrosis here, so I cannot put the Veress needle in the umbilicus. So what are the sites you can put? Number 1, you can put a Li Huang site. Number 2 is your Palmer's point, and number 3 is your Jane's point. The 3 sites where you can put it. Remember, the Palmer's point is what to remember. Whenever there is a previous laparotomy scar, I will put the Veress needle. I will insert Veress needle in Palmer's point. I will insert Veress needle at Palmer's point. At Palmer's point. What is the Palmer's point? It is going to be, it is in the left subcostal. It is left subcostal along mid-clavicular line. It's exactly 2 centimeters below subcostal line. This is your Palmer's point. So whenever there is 2 to 3 centimeters, 2 finger breadth is what we take it. So this is with respect to all the important laparoscopic images that you need to know. Now ergonomics is important. Now there are 3 angles that I've determined. This is the first one that you see. This is your camera port. The camera port is also called as the optical axis, also referred to as the optical axis. Then you see there are 2 working ports. This is working port 1 and this is working port 2. This is working port 1 and working port 2. Now I've named them as 3 different angles. This is angle number 1, this is angle number 2 and this is angle number 3. Right, let's try to decode what are them. The angle number 1 that you can see here, it is the angle between 2 working ports. The angle between 2 working ports is what we call it as the manipulating angle. Is what we call it as the manipulating angle. The second angle, it is the angle between working port and camera port. Angle between working and camera port. Angle between the working and the camera port. So this is what we call it as the azimuth angle. This is what we call it as the azimuth angle. The third one is the angle between port and body. The angle between the port and body is what we call it as elevating angle. Is what we call it as the elevating angle. How much should be these angles? Remember, the manipulating angle ideally should be 60 degrees. Azimuth angle is 30 degrees. Elevating angle is also 60 degrees. Okay. This was a previous exam question also, so pay a little bit of attention to these angles. What is manipulating angle? What is an azimuth angle? What is an elevating angle? Okay. Chalo. Now, few questions from the exam. What is the most common gas used to create pneumoperitoneum? Quick feedback. Most common gas used to create pneumoperitoneum. Most common gas used to create pneumoperitoneum. I hope everybody knows it. It is going to be carbon dioxide. How much is an initial flow rate for carbon dioxide when you're creating pneumoperitoneum? It is 1 to 4 liters per minute. The maximum flow rate that I can keep is 20 liters per minute. How much should be an intra-abdominal pressure? It should be maintained between 12 to 15 millimeters of mercury, which is also called as grade 2 hypertension of the abdomen. Accidental injury while inserting a port, it is to keep the port in situ. Keep port in situ and convert to open. Convert to open surgery. Keep the port in situ and convert to open surgery is what you're going to do. So all these are your previous exam questions that they've asked you from minimal access surgery. Okay. Sorted. Good. Can you move on? Sure. Next is your energy devices. Let's have a quick component of energy device. Identify the energy devices. The first is your monopolar cautery. It is a monopolar cautery. The second one is your bipolar cautery. This is what we call it as the harmonic scalpel. This is your thunderbeat. Both of them will be same, thunderbeat or Ligasure. They work on the same principle. This is your QSAW. That is a Cavitron ultrasound aspirator. QSAW is a Cavitron ultrasound aspirator. Now, when you look at the energy, it works on electrical energy. Bipolar also works on the electrical energy. Harmonic works on the vibrating energy. Thunderbeat is combined energy source. When I say combined energy, it will combine both vibrating and electrical. QSAW is also combined energy device. It is also a combined energy device. So one advantage QSAW also have is it uses water jet to cut through, right? And then it aspirates the tissues also. So it's more advanced. Now, monopolar has the ability to cut as well as coagulate. It cannot seal. Bipolar cannot cut. It can only coagulate. It cannot seal. Harmonic can cut, coagulate and seal. Ligasure can cut, coagulate and seal. QSAW can cut, coagulate and seal. Remember, the maximum size of the vessel that all these devices can seal is going to be 7 millimeters. The maximum size of a vessel that these energy devices can seal is going to be 7 millimeters. But it's not very confusing. Monopolar में single pole दिखेगा. Bipolar में you can see there are two tips which are present, easy to identify. देखो harmonic और thunderbeat में ना, when you look at harmonic will have no buttons. Thunderbeat will have a button. Harmonic will just have a clip. You just close it, open, close it, open. Whereas thunderbeat में क्या है या फिर Ligasure में you get buttons. QSAW में you will see a curved tip aspirator. It's like a pen. It's a curved tip aspirator. You cannot miss across it. ठीक है? Okay. So now, what is the frequency of the harmonic device? The frequency is between 20,000 to 50,000 hertz, right? Which is safest energy device in a patient with pacemaker? That is a harmonic scalpel. Now, why harmonic device is the safest? Because rest all of them use electrical energies, and electrical energies interferes with the pacemaker setting, right? Say Ligasure and Thunderbeat are basically two different brand names, but they work on the same principle. Okay? How do you identify the cut current? Remember, in cut current, what will you have? You will have low voltage with high frequency. Coagulating current will have high voltage. They'll have high voltage with low frequency. They will have high voltage with low frequency. If I have to plot a graph, this is the voltage and this is the frequency. Voltage, frequency. If you are talking about a cut current, you will see the current running like this. High frequency but low voltage. On the other hand, if I have to plot a graph for coagulating current, again voltage, we take this as frequency. You will notice the current running like this, high voltage but low frequency. The repetition cycles are less. This is your coagulating current where you have high voltage but low frequency. But a QSAW is a Cavitron ultrasound aspirator. It works on a combined energy principle, but it has got an aspirator. It flows a water jet. So jet is so fast and so strong that it cuts through the tissue, and it has got an aspirator. It can aspirate all the tissue also, right? So you will not have any bloody field. It will keep the field absolutely dry because it will suck everything out. Now, what is this phenomena? This was asked in our NEET PG exam. What is this phenomena in the image that I'm showing you? You have a port, you have an instrument, and that is conducting the electrical energy. Usually a port will never conduct. This phenomena is what we call it as capacitance. This is what we call it as capacitance coupling. This occurs due to loss in insulation between instrument between the instrument and port. More common in older instruments. How can you prevent capacitance coupling? In order to prevent capacitance coupling, use plastic ports. Rather than using metallic ports, use plastic ports. Plastic will not conduct the electrical impulses. Okay? So that's the objective. It's called as capacitance couplings. It is seen in older instruments where they have wear and tear. So why will there have a loss of insulation? When you use it a lot of times, no, the insulation will actually break, give away, all that can happen, right? It is more common in older instruments, and to prevent, simply use a plastic port. As simple as that. Okay? So this is your capacitance coupling. So this is with respect to your energy devices. So far, any doubts, quick feedback? So far, any doubts, quick feedback, कोई सवाल, कोई शक, anything that you want to ask? Can you move on? Sure. Now going into suture materials and knotting. Okay. The first one is your catgut suture material. Catgut is a natural. It is absorbable. It is monofilament, and it gets absorbed in 7 to 10 days. It gets absorbed in 7 to 10 days, and it has got high tissue reaction. It has got high tissue reaction. It has got high tissue reaction. Chromic catgut is also natural. It is also absorbable. It is also monofilament. The absorbable period of the chromic catgut is 90 days. It is a 90 days. Vicryl is synthetic. It is synthetic. It is absorbable. It is polyfilament. It is polyfilament. It is going to absorb in 60 to 90 days. This is also referred to as polygalactin, also known as polygalactin, also known as polygalactin. Yes, catgut is derived from the submucosa of the sheep's intestine. Submucosa of sheep's intestine. It is the submucosa of the sheep's intestine. Monocryl is also synthetic. It is also absorbable. It is monofilament, that is the monocryl. It is going to get absorbed in 90 to 120 days. And this is also called as polyglycoprone. Also referred to as a polyglycoprone. PDS is polydexon. It is also synthetic. This is absorbable. This is going to be monofilament. And PDS has got absorbed period of 180 days. Dexon is also synthetic. This is also absorbable. Dexon is also going to be monofilament, and Dexon gets absorbed in 60 to 90 days. Silk is natural. It is non-absorbable. It is polyfilament, and it has no absorbable period. Linen is natural. It is also non-absorbable. It is also polyfilament. Nothing spectacular. Cotton is natural, non-absorbable. Polyfilament, again, nothing. Proline is going to be synthetic. It is also non-absorbable. It is monofilament. It is also called as polypropylene, also referred as polypropylene. Polyester is also synthetic. It is non-absorbable. It is non-absorbable. It is also monofilament. Nylon is synthetic, ethylene is synthetic, steel is synthetic. All of them are going to be non-absorbable and all of them are going to be monofilament. All of them are going to be monofilament. There is nothing specific names that you have to remember in context to that. Okay. So this is the entire summary of your suture materials in a one single go. Do a quick recap and that should be more than enough. Okay. So this is your suture materials, knotting. Suture materials, their names, their absorbable periods and all that. Okay. Important ones. Now the suturing rule, which is an exam question. Now, when I say suturing rule, what is the length of the suture material required? The length is measured as 4 times. It is 4 times the length of the wound. It is 4 times the length of the wound is the suture material required. What is the distance between two sutures? It should be twice the depth of the wound. It is twice the depth of the wound. The angle between the needle and the skin is 90 degrees. Suture memory is your elastic recoil. It is nothing but elastic recoil. Now remember high memory. High memory indicates unstable knots. It indicates unstable knots. Low memory indicates stable knot. Low memory indicates stable knots. So this is about the suturing rule. Now suture removal period. Now the earliest suture removal that you have to do on the face, because they have good vascularity, that is going to be 3 to 5 days. Scalps and arm is 7 to 10 days. From trunk to hand and feet is going to be 10 to 14 days. These are 10 to 14 days. The longest that you're going to keep is palms and soles, that is a 14 to 21 days. 14 to 21 days is your palms and soles. That is a suture removal period. Now, based upon the suturing techniques, this is a simple interrupted suture. One bite here, one bite here. So, one bite on one side, another one on another side, and you just knot it off. This is what we call it as simple interrupted. If you start from one end and continuously run, it is your simple continuous. Now, you can see the two mattress sutures which are there. Right? How do you identify which of the following is vertical, which of the following is horizontal? Now look at the wound. This is the wound line that you have. And look at the suturing line. The suturing line is running like this. So the suturing line is running perpendicular to that of the wound. If it is running perpendicular to that of the wound, then it is going to be your vertical mattress. This is what we call it as the vertical mattress sutures. Come back here. In this, you can see this is the wound line. And this is how the suture line is running. This is how the suture line is running. So it is running parallel to that of the wound side. If it is running parallel to that of the wound side, this is what we call it as the horizontal. This is what we call it as the horizontal mattress sutures. It is your horizontal mattress sutures. Now, if a suture runs in the dermo-epidermal junction, not coming onto the surface of the skin, this is what we call it as subcuticular sutures. This is what we call it as the subcuticular sutures. So, all four of them are important. Remember the difference between vertical and horizontal mattress. That is your exam question. Okay. Next is your knotting techniques. We have knotting technique number 1, this is number 2, this is number 3, this is number 4. What is knotting technique number 1? This is what we call it as half hitch. This is what we call it as half hitch, which is a single loop. Now this is what we call it as the granny's knot. This is what we call it as the granny's knot. This is what we call it as the reef or a square knot. This is what we call it as a reef or a square knot. And the last one that you have is your surgeon's knot. This is what we call it as the surgeon's knot. Now, how do you know the difference? The confusing one is your granny's versus reef knot. Now, in order to identify this, I would ask you to see the green loop. Now, this is the green loop that you have. Now, imagine and observe the red thread. You see, one red thread is going under the green loop. It is passing under the green loop. This red thread is passing over the green loop. So, one thread is going under, another one is going over. Come back on the other side, you'll find similar. This is the red loop that is present here. This is the red loop that you have. Now, see the green thread. One green thread is going over the red loop. Another green thread is going under the red loop. So, if one thread is going above the loop and one is going below, one above and one below, this is what we call it as the reef or a, granny's knot. This is what one above, one below is what we call it as the granny's knot. Reef knot or a square knot, you see this is the green loop that you can see. You'll see here either both the threads are going to be under the loop. Both of them going under the loop. This is again the red loop that you have. Both the threads are going over the loop. Either both the threads are going under or both the threads are going over. This is what we call it as the reef knot or a square knot. Surgeon's knot, on the other hand, you can see there is one loop here. Now, so two loops on bottom, one loop on top. And when you observe, it will also have the same square, that is reef knot or a square knot. So you can say there's green loop here, red threads are going under. So both the threads are going under. You come back here also, this is the red loop here. You see both the threads are going over. So either both the threads are going under the loop or over the loop. If they follow the same direction, it is a reef or a square knot. It's a reef or a square knot, and this is what we call it as the surgeon's knot. So half hitch, granny's knot, reef and a square knot, and then your surgeon's knot. This is all in all with respect to your suturing techniques. So far, any doubts? Quick feedback. ठीक है? Can you move on? So talk about the wounds and the ulcers, again very important. If you have any questions, quick feedback, anything else you want me to repeat? कोई सवाल, कोई शक, कोई problem? ठीक है, चलो. Now, wounds और ulcer का देख लेते हैं. The first one is collagen synthesis. Now, collagen synthesis के लिए कौन-कौन सा amino acids लगते हैं? That's the first question. That is your proline and lysine. They convert into hydroxyproline and hydroxylysine. The conversion of proline and lysine into hydroxyproline and hydroxylysine, this process is what we call as hydroxylation. This is what we call it as hydroxylation. Achha. Now, what are the cofactors required for hydroxylation? Remember, it requires vitamin C. It requires iron. And it requires alpha ketogluteric acid. Now, this alpha ketogluteric acid is again a examples of suture material. इतनी पूरी गंगा बता दी यार. This is all your suture material. ठीक है. Now, that is why whenever the deficiency of vitamin C or iron, it will have poor wound healing. Now, collagen with respect to that of the granulation tissue. In granulation tissue, which collagen is going to be predominant? Remember, you will find type 3 collagen to be predominant. In an early scar, again, you will have type 3 collagen as predominant. In an initial scar, you have both type 1 and type 3 collagen. This time the ratio is going to be 1:1. In a final scar, you will again have type 1 and type 3, but this time the ratio is going to be 4:1. So in the final scar, you will have more of type 1 collagen when compared to CBD. बेटा CBD में हमेशा absorbable sutures, नॉन absorbable डालोगे तो स्ट्रक्चर बन जाएगा, ठीक है. So final scar में type 1 collagen is predominant over type 3 collagen. Now scar strength, it is always compared to the strength of normal skin. Compared to strength of normal skin. Always compared to the strength of the normal skin. At 1 week, the scar strength is at 3%. At 3 weeks, it is at 20%. The maximum scar strength is going to be at 80%, right? So when I say the maximum strength, is going to be 80%. 100% is not possible. Once it is injured, it will remain injured. Okay. So what is the difference between a hypertrophic scar and a keloid? So this is the comparative table between the hypertrophic scar and keloid. Hypertrophic scar और keloid के बीच में फर्क क्या है? Now, in the hypertrophic scar, remember it is limited to the wound site, whereas keloid involve the normal surrounding skin. Here there is because of excessive amount of fibroblast. Keloids is because of defective fibroblast. The growth of the hypertrophic scar stops within 6 months, whereas keloids continue to grow even beyond 6 months. The type 3 collagen is more than type 1 in hypertrophic scar, ratio is 6:1, and that ratio becomes exuberantly high in keloids, that is 20:1, right? So the difference between hypertrophic scar and keloids. Then you have pressure sore, bed sore, also called as decubitus ulcer. The criteria for pressure sore is the pressure exerted should be more than the capillary occlusive pressure. It should be more than the capillary occlusive pressure. The pressure exerted should be more than the capillary occlusive pressure. It is going to be capillary occlusive pressure. See, it is a capillary occlusive pressure, and the capillary occlusive pressure is at 30 millimeters of mercury. The currently, what is the limit of the capillary occlusive pressure? It is going to be 30 millimeters of mercury. The most common site for pressure ulcer is going to be ischium, then greater trochanter, then it is sacrum. Clear? It is going to be ischium, greater trochanter, followed by sacrum. How do you describe it? Grade 1, there is non-blanching erythema. Grade 2, there is partial thickness skin loss. Grade 3, there is full thickness skin loss. Grade 4, there is involvement of underlying structure. And there is something called as unstageable. If an ulcer is covered by slough or necrosis, the true depth of the ulcer cannot be assessed. Now remember, for grade 1 and grade 2, it is conservative management. In conservative management, see, we'll give water bed, air bed, all that. But the frequent change in position. So if a patient is bedridden, the change in position should be every second hourly. And if a patient is wheelchair bound, every 10 minutes the patient has to change the position. Every 10 minutes the patient has to change the position. If it is grade 3 onwards, you have to do cleaning and debridement. Put a vac dressing. Now the VAC is what we call it as the negative pressure wound closure system. It is called as a negative pressure wound closure system. It is a negative pressure wound closure system. VAC is what we call as the negative pressure wound closure system, right? This is the image of the VAC. In our previous exam, they asked you how much is the pressure in the VAC. Remember, the pressure that we keep in the VAC is minus 125 millimeters of mercury, right? Okay. Is it a continuous or an intermittent pressure? This is an intermittent pressure. This is your intermittent pressure. It increases the formation of granulation tissue. And the advantage is you have to change dressing after 5 days. So daily dressing is not required. If you put a VAC, you can change it once in 5 days. You can change it one in 5 days. Okay? So this is with respect to the management of your pressure. Every single thing that I've written is an exam question. Capillary occlusive pressure, most common site, conservative management में bedridden patient का क्या protocol है, wheelchair वाला का क्या है, VAC की image दी हुई है, and they have asked you all these pointers. All these are your previous exam questions. Clear है? ठीक है? All right. Chalo. Now, we talk about the wound classification. Now, surgical wound classification, the class 1 wounds are what we call it as the clean wounds. Remember, clean, the criteria for clean is very simple. It should be elective surgery, no entry into natural cavity, non-emergency. Class 2 is clean contaminated wounds where you're entering into natural cavity. In your exam, I want you to remember the class 2 which is contaminated. In contaminated, I just want you to remember these 2 points. Number 1 is your open cardiac massage. Open cardiac massage. Another one is gross spillage from the GI tract. All these are going to be contaminated. Remember, dirty wounds are going to be one which is going to be pus or with fecal matter. That's it. So our exam will concentrate on class 3, that is contaminated. All your re-explorations, example like open cardiac massage or gross spillage during the surgery will become contaminated wounds. Then is your Southampton wound grading system. Remember, according to Southampton wound grading system, according to the Southampton wound grading system, grade 0 is normal, grade 1 is erythema. There is only erythema. The grade 2 is going to be erythema with other signs of inflammation. Grade 3 is clear or hemoserous discharge. Grade 4 is pus. Grade 5 is severe wound infection or hematoma requiring aspiration. The sub pointers are not important. Just remember the main one. I'm just going to highlight it. Grade 0 is a normal healing wound. Grade 1, there is only erythema. Grade 2 is erythema with other signs of inflammation. Grade 3 is going to be hemoserous discharge. Grade 4 is going to be your purulent discharge. Grade 5, remember, it is severe wound infection or hematoma requiring aspiration. Whatever I have marked, just remember this. The sub pointers are not important. Just remember this, it is more than enough. Clear? ठीक है? Grading important है बेटा. Pressure ulcers की grading important है. चलो. Next is your spotters. Again, very famous or favorite question for your FMG in the recent exams. Spotter number 1. What is this? This is your sebaceous cyst. How are you able to tell you it is a sebaceous cyst? In the sebaceous cyst, you have this black dot on top. This is what we call it as punctum. If there is presence of punctum, it is a sebaceous cyst. Another one, skin over the swelling. Skin over the swelling is not pinchable. Is not pinchable. The image number 2, this is your lipoma, which is called as the universal tumor. It is a universal tumor. it is benign. And one of the characteristic feature, it will have slip sign positive. You try to palpate, it will slip away. This is what we call slip sign positive. See, there is no punctum. It is a uniform swelling that you are able to see. Okay? And that is a lipoma. Image number 3, you can see a baby with a swelling at the angle of the eye. This is what we call it as the angular dermoid. This is your angular dermoid. It occurs where the two bones are fusing. It's in the junction of the fusion line of the bone. It's a congenital swelling. It is the congenital swelling arising at the junction of bony fusion, or simple word, suture line. Image number 4, you cannot mistake it. This is your cystic hygroma. The most common site for the cystic hygroma is going to be the posterior triangle of the neck. It is the posterior triangle of the neck. The most common site is the posterior triangle of the neck. It is because of sequestration of jugular sac. The management can be done with sclerotherapy. And remember, it has got positive transillumination. It has got a positive transillumination. This is image number 5. It is your omphalocele. As you can see, it is covered with membrane. There is presence of membrane. If the bowels are exposed, that will be called as gastrocesis. This is your omphalocele where you have membrane. This is what we call it as the sebaceous horn. So when there is a chronic calcified sebaceous cyst, it will have this calcification projecting out, and that is what we call it as the sebaceous horn. Okay. Image number 7. This is your venous ulcer. How am I able to tell you it's a venous ulcer? Number 1, you can see it is in the gaiters area. It is in the gaiters area. It is a shallow ulcer. It is a shallow ulcer. It has got surrounding pigmentation. It has got surrounding pigmentation. It has got a sloping edge. It is going to have sloping edge, and this has pale, scanty, unhealthy granulation tissue. Unhealthy granulation tissue. Pale, scanty, unhealthy granulation tissue. So, gaiters area, shallow ulcer, surrounding pigmentation, sloping edge, pale, scanty, unhealthy granulation tissue, right? So, this is a venous ulcer. So, when you look at this, this is a healing ulcer. How do you know it's a healing ulcer? You will have a sloping edge. You can see the edge when you observe it, it is moving inwards. The sloping edge is a characteristic of a healing ulcer. It's a characteristic of a healing ulcer. Gastrocesis has a better prognosis over omphalocele because omphalocele is also associated with other congenital deformities. है ना? चलो. Question number 10. I hope nobody will mistake this. This is a trophic ulcer. They will have punched out edge. They're deep ulcers. And they have punched out edge. Level 1, there's an undermined edge. You can see this is going under. There's a deeper tissue damage. There's an undermined edge. Undermined edge is seen in TB ulcers, tubercular ulcer, and necrotizing fasciitis. And the necrotizing fasciitis. Now this is where you can see raised and everted edge. This is the squamous cell carcinoma of the skin. It is squamous cell carcinoma of skin. This is raised and beaded. Raised and beaded. This is your basal cell carcinoma of the skin. This is your basal cell carcinoma of the skin. Okay. Chalo. Everybody knows this two images. This is your gastrocesis. Any doubts? Chat box. Any questions? But trophic ulcers and arterial ulcers, both of them will have punched out edge. ठीक है. Gastrocesis. And this is your myelomeningocele. It's a neural tube defect. This is an NTD, that is a neural tube defect. How to differentiate punched out and raised and everted? But raised and everted, you can see there's an exuberant growth and you will see the edge coming out like this. This is a raised and everted. Punched out, you can see it is deep. You'll see there is no eversion of the ulcer. This the edge is here and there's a lot of depth from the ulcer. So it's like straight edge. It's a straight edge that is going to be punched out. Raised and everted, you can see it is everting. It is coming out. It comes up and then it goes. So it grows over the skin surface. Okay. That all occurs because of exuberant growth from the edge. And see, edge is the metabolically most active site of the ulcer, right? Now, okay, we have covered most of the ulcers. Just for the sake of understanding, no, ulcer के तीन parts होते हैं, no. This is the normal skin. This is the normal surrounding skin, right? This is the edge of the ulcer. This is the floor of the ulcer. On which it rests is the base of the ulcer. Right? So we say this is the normal surrounding skin. It is the normal skin. This is what we call it as margin. This is what we call it as edge, floor, and base. Margin is the junction between, it is a junction between normal skin and ulcer. Edge is between margin and floor. Floor is the most dependent most dependent site of ulcer. Base is the site on which ulcer rests. Right. Now, edge is metabolically the most active site. Edge is metabolically it is the most active site. Edge is metabolically the most active site. So whenever you're taking a biopsy from an ulcer, always take the biopsy from the edge. Always take the biopsy from the edge. Okay. So now coming on to the nutrition, again few important pickup points, spotters and buzzwords we'll try to understand. The first one is your nasogastric tube. We have already seen this, nothing spectacular about it. It is a nasogastric tube, also called as the Ryle's tube. The second one also we have seen, this is your nasojejunal tube. This is your nasojejunal tube. And the third one is your peg tube. It is your peg tube. Now, in the parenteral nutrition, what are the sites that you can give, from where you can give? In a parenteral nutrition, we can give with the short axis, that is your peripheral vein. That is your peripheral vein. Then we can give with PICC, that is peripherally introduced central catheter. Peripherally introduced central catheter. Then you have central lines. Now your central lines are going to be subclavian vein axis, internal jugular vein, external jugular vein, and femoral vein. Now subclavian vein axis has a special form, which is a hidden form, which is here. This subclavian vein axis, your central venous catheter, we are putting in a hidden form. This is what we call it as the Hickman's line. Hickman's line is also a variant of subclavian vein axis, but rather than going directly to subclavian, you create a subcutaneous tunnel. You create a subcutaneous tunnel, and inside the subcutaneous tunnel, you advance your catheter and then goes into subclavian vein and then enters here. This form is what we call it as Hickman's line. This is what we call it as the Hickman's line. What is the current indication for a total parenteral nutrition? The current indication is short bowel syndrome. When I say what is a short bowel syndrome, if the length of the small bowel is less than 200 centimeters. Second is high output enterocutaneous fistula. High output is more than 500 ml of output in 24 hours. Initial phase of your acute pancreatitis, acute inflammatory bowel disease, and prolonged ileus. The definition of prolonged ileus is if ileus goes beyond 72 hours. If the ileus goes beyond 72 hours is what we call it as prolonged ileus. Now, we look at the composition of the total parenteral nutrition and the energy that they deliver. Remember, in the composition, you have to remember what is the total volume that you can give in a TPN, that is around 1 to 2 liters. Now, when you have carbohydrates, which is the maximum composition or 40 to 50%, it delivers 3.5 kilocalories per gram. Fat, which is 30 to 40%, delivers 9 kilocalories per gram. That is the highest energy. And proteins provide you 10 to 20% of the total volume, but 4 kilocalories per gram. The vitamin and minerals are present, but they are negligible in terms of quantity and they do not contribute to energy, any energy component that they have, right? Now, one question that is asked in recent INI exam also is about the refeeding syndrome, right? Can anybody tell me what is a refeeding syndrome? Quick feedback. Refeeding syndrome. Quick feedback. Quick feedback. Okay. So refeeding syndrome, patient has been starving for now, right? Patient has been starving. This starved patient, I suddenly give TPN. Now TPN has the maximum quantity of carbohydrates. So there is sudden surge of carbohydrates. That means there's sudden increase in sugar. That sudden increase in sugar will cause excessive increase or excessive release of insulin. So it'll be sudden insulin spike. Now we all know what does insulin does. Now the first thing insulin is going to do, it will shift all the potassium back into the cell. So it will be associated with hypokalemia. It will be associated with hypokalemia. What else it will draw is, it will also cause hypophosphatemia. And hypomagnesemia. Hypomagnesemia. It will also be associated with thiamine deficiency. It will also be associated with thiamine deficiency, right? If it is going to be later, it is got sodium and water retention also. But if they ask you which is the most important, or I can say the hallmark for your refeeding syndrome, it is the hypophosphatemia. Hypophosphatemia is the hallmark. It is the hallmark. Hypophosphatemia is the hallmark. It is the hallmark for refeeding syndrome. This was your this year's INI question also. Okay? Clear? So this is all in all with respect to nutrition as well. So far, any doubts? Quick feedback. Okay? Chal. We'll go to trauma and shock. Chalo. So talk about trauma and shock. In the trauma, we'll talk about the surveys that we have. We have standard 3 surveys that we have: the primary survey, the secondary survey, and the tertiary survey. Let's have a pre-decided or a predefined goal for all of them so that we'll understand them better. Now, what is the goal for the primary survey? The goal for the primary survey is to rule out any immediate life-threatening injury. To rule out any immediate life-threatening injury. To rule out any immediate life-threatening injury. Secondary survey is to rule out any potentially life-threatening injury. It is to rule out any potentially life-threatening injury. Tertiary is a detailed examination. It is a detailed head to toe examination. It is a detailed head to toe examination. Right? Now, in trauma and shock, remember the current protocols that is to be followed is what we call it as the XABCD protocol. It is not ABCDE. X is given preference. What is X? X stands for to control the exsanguinating hemorrhage. So the highest priority in the primary survey is not airway now. It is to control the bleeding first. So control the exsanguinating hemorrhage and then look for airway is the point number 1 to be remembered. So in the current guidelines, remember it is control exsanguinating hemorrhage and then move for airway with cervical spine stabilization. That's the most important aspect to be remembered. Now, triage is done on the basis of outcome when compared to severity. The highest is given to red and least is given to black color. Criteria to intubate. When I say criteria to intubate, I have now created the criteria to intubate for both of them. What is the criteria to intubate in trauma and what is the criteria to intubate in burns? Criteria to intubate in both trauma as well as burns. Now, in trauma, if the patient is unconscious, GCS of less than or equal to 8, presence of inspiratory stridor, severe wheeze and voice distress, you are going to intubate. For burns, facial burns, hoarseness of voice, inspiratory stridor or severe wheeze, you're going to secure the airway. What is the extent of emergency tracheostomy incision? It is going to be below the cricoid cartilage, to suprasternal notch. See, in emergency tracheostomy, it is going to be a vertical midline incision. In emergency tracheostomy, it is going to be the vertical midline incision. It is going to be a vertical midline incision. Right? What is the definition of massive hemothorax? See, massive hemothorax, we say if there is loss of blood of more than or equal to 1000 ml in penetrating injury. Or more than or equal to 1500 ml of blood in blunt trauma, or if more than or equal to 200 ml per hour for next 3 hours consecutively. This is the definition of massive hemothorax. What is the dose of the tranexamic acid? Now, current dosage of the tranexamic acid in trauma, you have to give 1 gram stat and then 1 gram in next 24 hours. Right? So this is the current dose. Total of 2 grams of tranexamic acid has to be given. 1 gram start, another 1 gram in the next 24 hours. Right? So this is with respect to okay. Yeah, I also didn't see that coming, beta. It's okay. Life pairs you up. No, the one that you hate the most is one that you get always. So it's okay. कोई नहीं, we'll cover the radiology so that you can tell madam कि madam हमारा radiology already covered है. And you give ma'am the answers before she gives you the answers. No, that's how you tell you are your my student. Chalo, these are the criteria to intubate. Everybody is clear. Move on. Chalo. Now, trauma images, image number 1 that you are able to see is what we call it as the needle cricothyroidotomy. So, in a needle cricothyroidotomy, we use a 14 gauge needle inserted between cricoid and thyroid cartilage. Inserted between thyroid and cricoid cartilage, and we connect to high flow oxygen. It is a bridging maneuver before you actually do a tracheostomy. Clear? Sure. Image number 2, patient had blunt trauma thorax, and this is what they have presented to you. What is this? Now, when you look at this image, you see the entire lung is collapsed. The trachea is deviated onto the opposite side. So all this area is now filled up with air, right? So this is your pneumothorax. This is going to be your pneumothorax. So in pneumothorax, what do you have? Say, do not say it is a tension or open pneumothorax until the history is given. It is a pneumothorax, right? In the pneumothorax, you'll see lung collapsed, absent bronchovascular marking, and trachea deviated to the opposite side. Trachea deviated to the opposite side. Image number 3, you can see fracture 1, fracture 2, fracture 3, fracture 4, and there are one more fracture sites here. There's one more here, one more here, right? There's one more fracture site here. So this is your flail chest. Now, what is the definition of flail chest? When more than or equal to two continuous ribs fracture at more than or equal to two different site on the same rib. Two different site on the same rib is what we call it as flail chest, right? So more than or equal to two continuous rib fracture at more than or equal to two different sites on the same rib is what we call it as flail chest. Now, when you do an ultrasound in a pneumothorax, so the USG findings in pneumothorax. Now, USG finding on pneumothorax, number 1 is going to be absent seashore sign, presence of barcode sign, and the stratosphere sign. And the stratosphere sign. Image number 5, everybody should be able to know post-trauma. You can see this is your extradural hemorrhage, EDH. Now, EDH, you can see it is the collection of blood. It is a collection of blood between dura and skull bone. Between the dura and the skull bone. The most common source of bleeding is going to be your middle meningeal. It is your middle meningeal artery. It is your middle meningeal artery. The characteristic feature that you will see is going to be present of lucid interval. It is your presence of the lucid interval. The most common source is your middle meningeal artery. Presence is going to be lucid interval. Investigation of choice, as you can see, is your NCCT, and you see biconvex opacity. We have the biconvex opacity. The management is going to be craniotomy. Please do not answer it as burr hole surgery. The answer is going to be craniotomy. That is your EDH. Another one that you have is your subdural hemorrhage. That is your SDH. In a subdural hemorrhage, you see this is the entire hemorrhage line that you have, right? So subdural hemorrhage is basically collection of blood. It is a collection of blood between dura and arachnoid membrane. Dura and arachnoid membrane. The most common source is going to be the cortical bridging veins. Investigation of choice here is also NCCT. You see it is concavo convex opacity. On one side is concave, another one is convex. It is also called as crescent opacity. Small HDH, you don't need to do anything. Large HDH, you have to go with craniotomy. Image number 7, this is what we call it as log roll technique. This is done for examination of the back. For examination of back in a patient of trauma. Minimum people required to do a log roll technique is 4. The 8th one is your GCS, Glasgow Coma Scale. I've given you the objective, but these are the questions that they ask you. Total GCS is how much? 15 by 15. Maximum GCS is how much? 15 by 15. Minimum GCS is 3 by 15. Risk for coma is less than or equal to 8 by 15. Indication for intubation is also less than or equal to 8 by 15. GCSP score is your pupillary assessment score. So in a GCSP, you have pupil assessment score. So in a pupil assessment score, bilateral pupil reactive. Bilateral pupil reactive to light, a score of 0 is given. Unilateral pupil reactive, score of -1. Bilateral pupil non-reactive. Bilateral pupil non-reactive, score of -2 is given. So when you look at the GCSP score, in the GCSP, you have eye, verbal, motor and pupillary score. So maximum score is going to be 4. This is V5, M6 and P is going to be 0. So when you look at the maximum GCSP score, it will still remain as 15 by 15. The minimum GCSP score, when you look at it, E, V, M and P, E is going to be minimum is 1, verbal is 1, motor is 1 and -2 will be a pupillary. Now if you add up the entire score, if you add -2 here, so the minimum score possible will become 1 by 15. The minimum score for GCSP is going to be 1 by 15. Okay? All right. That was your image number 8. So image number 9. This image number 9 is your subarachnoid hemorrhage. You can see bleed in the ventricles. Remember, it can be secondary to ruptured Berry's aneurysm. Secondary to ruptured Berry's aneurysm. Now, if a patient, this is the 10th one that we have. If a patient has post-traumatic coma, right? Post-trauma, patient came with coma, that is the GCS of the patient was less than 8 by 50. NCCT appeared to be normal. NCCT appeared to be normal. Then you get an MRI done. On the MRI, this is the image. You can see these black dots. These are your punctate hemorrhage, right? So presence of punctate hemorrhage. Presence of punctate hemorrhage between white and the gray matter. Between white and gray matter. This is what we call it as diffuse axonal injury. This is what we call as diffuse axonal injury. This is associated with poor prognosis. So GCS is less than 8, NCCT appears to be normal. On MRI, you see patient is going to have punctate hemorrhage. In fact, the patient lands up with coma here. We call it as post-traumatic coma. And on a CT, it appears to be normal. You're like, are post-trauma, how can a patient have GCS which is dropping, but CT appears to be normal? In that case, it is going to be a diffuse axonal injury. In your trauma, they cannot go beyond this. Whatever they'll ask you, it is going to be from this particular page. That is going to be pretty sure. Trauma के लिए ये एक page revise कर लेना, इसके beyond वो नहीं जाएंगे. Don't worry about it. ठीक है? Clear है? One second. ठीक है. Can we move on? ठीक है. So this is all in all with respect to trauma that you're supposed to know. देखो trauma में एक additional component जो है that is going to be for solid organ injury. Your splenic injury के grades important है, liver injury के important है, recent INI CET. Recent INI CET they've asked you about the colonic grades also. ठीक है, एक बार quickly देख लेना. I don't want to go into greater details. I've given you this. Revise the splenic grade, liver as well as colonic grades of injury. उनका जो management protocols are, they're pretty similar, so you just need to go across this tables once. Now, in a damage control surgery, remember damage control surgery का जो indication है, number one is physical or the physiological exhaustion. Physiological exhaustion if the patient has hypothermia, acidosis and coagulopathy. These three put together is what we call as lethal triad of trauma. This is what we call as the lethal triad of trauma. This is a lethal triad of trauma. Second, if the patient has undergone a massive hemorrhage, the definition of massive hemorrhage is if it requires more than 10 units of blood transfusion to make the patient stable, these patients should also be taken for damage control surgery. Now, if the patient is having severe trauma, now the definition of severe trauma is polytrauma with multivisceral organ injuries, then again you take the patient for damage control surgery. If you're anticipating long operative time, where the patient tolerance is a problem, then again damage control surgery. If there is already contamination is occurred, that is bowel contamination or sepsis, again damage control surgery. If the patient is hemodynamically unstable and with persistent hypotension despite resuscitation, again you take the patient for damage control surgery. The stages of damage control surgery I've given you here in the image, but I'll quickly recap it. The stage 1 is going to be patient selection. Stage 2, it is going to be primary exploration. Stage 3 is your ICU care, which will last for 24 to 48 hours. Stage 4 is your secondary exploration. And stage 5 is your definitive abdominal closure. Definitive abdominal closure. It is a definitive abdominal closure. Okay? Now, the goal for the primary exploration, it is to control hemorrhage and prevent contamination. It is to control hemorrhage and prevent any further contamination. The goal for secondary exploration, the goal for the secondary exploration, it is to correct the anatomy. It is to correct the anatomy. So this is with respect to damage control surgery. Again, very, very important from the exam perspective. They can ask you the questions straight away from here also. Okay? Chalo. Going into the vascular component, again important one, we say acute arterial occlusion. In an acute arterial occlusion, you have a patient presenting to you with 6P presentation. I've given you all 6Ps here. What are the 6Ps that you have? It is going to have pain, paresthesia, paralysis, pallor, poikilothermia, and pulselessness. The investigation choice for acute arterial occlusion is going to be duplex scan. Duplex scan is an ultrasound B mode with a Doppler study. Management for a viable limb. Management for a viable limb in acute arterial occlusion is going to be embolectomy. It is embolectomy with prophylactic fasciotomy. So embolectomy with fasciotomy. Embolectomy is done with Fogarty's catheter, and you do a 4-compartment fasciotomy. That is going to be for acute arterial occlusion if you have a viable limb. Now, another $1 million question is, how do you differentiate between dry gangrene versus wet gangrene? How do you differentiate between dry versus wet gangrene? Now, the differentiating factor between the dry and the wet gangrene is the dry gangrene usually occurs because of vascular compromise. So, there will be dry there'll be blackened tissue, there'll be a clear line of demarcation. It's a slow progression. Wet gangrene is because of infection, so they'll have swollen, moist and blisters. It will have a foul smell, there'll be no clear boundary, and it will have rapid progression, right? Next is your chronic arterial occlusion. In chronic arterial occlusion, I want you to have a comparative data. The comparative data between the Burgess disease and the atherosclerosis, right? Now, in the Burgess disease, the age of presentation would be age less than 40 years. Atherosclerosis will have age above 50 years. The risk factor for Burgess is going to be smoking, whereas for atherosclerosis, it is obesity. Most common limb, remember, all four limbs are equally involved. They're equally involved. Atherosclerosis, it is the lower limb, which is going to be far, far more common when compared to the upper limb. Far, far more common when compared to the upper limb. The size of the vessels in Burgess involved is small to medium. For atherosclerosis, it is large to medium. It is large to medium. Pattern here, it is going to be skip lesions in Burgess. Atherosclerosis is going to be a continuous lesion. It is a continuous lesion. Now, the progression of the Burgess disease is going to be towards the heart, that is distal to proximal. It is distal to proximal. Atherosclerosis will be proximal to distal. It is proximal to distal. Atherosclerosis is going to be proximal to distal. See? So that's the difference between Burgess and atherosclerosis. In Burgess, remember, you have the triad. What is the triad of Burgess? Any idea? Triad of Burgess. Number one, they have Raynaud's phenomena. Number two, intermittent claudication. Intermittent claudication. Number three, there is migratory. There is migratory, superficial thrombophlebitis. Raynaud's phenomena, intermittent claudication, and migratory superficial thrombophlebitis. Migratory superficial thrombophlebitis, right? So all these are the triad of your Burgess disease. Absolutely correct. Okay? Chalo. Raynaud's phenomena's color change, I hope everybody remembers it. What is the color change? The first is going to be white, that is going to be pallor. Then you have congestion, blue. Eventually resolution, that is going to be red. Okay? That's the objective. Now, Boyd's classification for intermittent claudication, all these are your quick recaps. The Boyd's classification for intermittent claudication is your FMGE exam question only. So, do revise it one. Grade 1, pain appears, disappears in walking. Grade 2, patient continues to walk with pain. Grade 3, patient has to take rest due to pain. Grade 4 is rest pain. Fontaine staging of limb ischemia, also equally important. In the Fontaine staging of limb ischemia, it is for chronic arterial occlusions. You will say stage 1 is asymptomatic, stage 1, 2 is mild intermittent claudication, 2B is moderate to severe, 3 rest pain, 4 is going to be gangrene. Now, what is the normal ABPI index? That is ankle brachial pressure index. It is a systolic blood pressure at the level of ankle with respect to systolic blood pressure at the level of the brachial artery. The normal ABPI index is between 1 to 1.3. Intermittent claudication less than 0.9, rest pain is less than 0.5, critical limb ischemia less than 0.3, and calcified blood vessel more than 1.3. For a calcified blood vessel, it is more than 1.3. It is more than 1.3. Okay? So this is with respect to chronic arterial occlusion. How do you manage them? If there is an ioto-iliac occlusion, the patient is going to have bilateral intermittent claudication with involvement of gluteus, thigh and calf. And here you would do ioto bifemoral bypass. Ioto, we do a ioto bifemoral bypass. If it is an iliac occlusion, it will have unilateral intermittent claudication, gluteal sparing is there, the thigh and the calf is involved. Here we do iliofemoral bypass. Here we'll do a iliofemoral bypass. Femoropopliteal occlusion, there will be unilateral, gluteal sparing, thigh sparing, only calf is involved. Here we do an iliopopliteal bypass. We do a iliopopliteal bypass. Leydig syndrome is seen in males. It is seen in males and it is with iliac occlusion. Now, Leydig syndrome is bilateral intermittent claudication. It is bilateral intermittent claudication with male impotency. Because in males, the gonads is supplied by internal iliac artery, which is compromised in an iliac occlusion. So, if you have a bilateral intermittent claudication with male impotency, that is a Leydig syndrome. Now, for femoropopliteal occlusion, what is the graft used? It is the autologous reverse, that is upside down, great Cephalus vein. Autologous reverse great Cephalus vein is the graft of choice. The other two you are going to use Dacrin. Okay. Now, quick feedback on your previous exam questions. Okay. Okay. What is the most common site for aneurysm overall? Overall, most common site for aneurysm. The answer is Berry's aneurysm. That is at the circle of Willis. Most common extracranial site is your infrarenal. It is your infrarenal abdominal aorta. It is the infrarenal abdominal aorta. Most common peripheral site for aneurysm. P for peripheral, P for popliteal artery. It is your popliteal artery. Most common morphological type is going to be fusiform variety. The critical diameter for abdominal aortic aneurysm is 5.5 centimeters. The method to expose the aorta in an open repair is what we call it as the Mattox procedure. It is your left medial visceral rotation. It is a left medial visceral rotation. What is the critical increase? If there is an increase of more than or equal to 10 millimeters in 1 year or more than or equal to 5 millimeters in 6 months. Either of them is called as the critical increase. Lyre sign is seen in carotid body tumor. It is seen in carotid body tumor. This is seen in carotid body tumor. So this is with respect to the aneurysmal components. ठीक है? Clear है? चलो. Now, what is the most common type of thoracic outlet syndrome? There is an arterial form, that is the vascular form, and the neural form. It is the neural form, which is the most common type. Most common nerve involved is your ulnar nerve. The tests that we are going to do in thoracic outlet is Adson's, Roos, Wright, and military brace tester. All of them are done for thoracic outlet syndrome. These are the clinical tests for thoracic outlet syndrome. Adson's, Roos, Wright, and military Roos test. Nicode and Brandan sign is done for AV fistula. It is performed for AV fistula. Okay? Good. Clear? So this is in the arterial disorders. Let's quickly go with the venous disorders. You'll talk about varicose vein. We'll have quick image-based component. The first image that you see is your telangiectasia. The second is your reticular vein. It is your reticular vein. Third is your varicose vein. Then you have pigmentation. This is your lipodermatosclerosis. This is your lipodermatosclerosis. And this is your venous ulcer. Now, according to SEEP classification, C0, there is no visible disease. C1, there is telangiectasia and reticular veins. C2 is varicose vein. C2R is your recurrent varicose vein. They can also have C2A and C2S. C2A is asymptomatic. And if they have C2S, then it is symptomatic. Then it is symptomatic. C3 is going to be edema. C4A is going to be pigmentation. C4B is lipodermatosclerosis. C4C is coronophlebectatica. C5 is healed venous ulcer. C6 is active. C6R is recurrent venous ulcer. The most common vein involved in varicose vein is your great saphenous vein. The USG finding, if there is a saphenofemoral incompetency, is going to be Mickey Mouse appearance. It is your Mickey Mouse sign. The surgery that we do is going to be Trendelenburg surgery, which is going to be flush, ligate, and strip. EVL is your endovenous laser ablation. The frequency that we use is 1470 nanometers. Radiofrequent ablation, it generates a temperature of 120 degrees Celsius. The sclerotherapy that we use is your Tasari's method, and the most common agent used is sodium tetradecyl sulfate. It is your sodium tetradecyl sulfate. It is a sodium tetradecyl sulfate. Then there's something called as Bisgard's regime, that is for venous ulcer. Bisgard's regime is for venous ulcer. Now 3E, number 1 is to educate the patient, ask the patient to elevate the limb, and usage of elastic compression stockings. Usage of elastic compression stocking. Usage of elastic compression stockings. Usage of elastic compression stockings. Clear? Right. So when you talk about grades of the elastic compression stockings, how much is grade 1? The pressure in the grade 1. The pressure in the grade 1 is 14 to 17 millimeters of mercury. For grade 2, there's a misprint here. For grade 2, the pressure is going to be 18 to 24 millimeters of mercury. For grade 3, we'll have 25 to 35 millimeters of mercury. So 14 to 17, 18 to 24, and 25 to 35 millimeters of mercury. Beta, you can never get confused between 4A, 4B, 4C, no yaar. Because this is your C1 disease. This is your C2 disease. This is your C3 disease. This is your C4A disease. This is your C4B disease, right? Then your coronophlebectatica. So it's clear, pigmentation, lipodermatosclerosis. You can clearly see you have an inverted champagne bottle appearance here, no? You have an inverted champagne bottle appearance in lipodermatosclerosis. In a lipodermatosclerosis. Okay. But telangiectasia, you can see these thin thread-like veins which are present. Reticular veins are slightly bigger. So how do you differentiate? In telangiectasia, you cannot feel when you palpate, and when you palpate it, you will be able to see. Okay. So telangiectasia and reticular veins are your C1 disease. I've written a bit scratchy here. C2 is your varicose vein, C3 is edema, 4A is pigmentation, 4B is lipodermatosclerosis. ठीक है, क्लियर है? ठीक है, चलो. What is the most common vein for DVT? The most common vein for DVT is going to be calf veins. The most common site for DVT causing pulmonary embolism is your femoral vein DVT. It is your femoral vein DVT. This is your femoral vein DVT. HIT syndrome is your heparin-induced thrombocytopenia. How do you manage it? You have to stop heparin immediately. And then you have to switch. Now, what you are going to switch to? You can switch to number one, fondaparinux. Rivaroxaban, apixaban, and bevalirudin. In this, you will notice that these are factor 10A inhibitors, and bevalirudin is a direct thrombin inhibitor. This is a DTI, that is a direct thrombin inhibitor. Now, DVT with contraindication for anticoagulation, there you will do a IVC filter. We'll use IVC filter, also called as the green field filter. Also called as the greenfield filter. If you have a DVT for the first time, the duration of warfarin is going to be 3 months. If it is recurrent, then it is going to be lifelong. The target INR that you maintain is between 2 to 3, right? You have phlegmasia alba dolens, which is we have combined these two. Okay. Phlegmasia alba dolens is painful white leg. It is painful white leg. And then you have phlegmasia cerula dolens. The phlegmasia cerula dolens is painful blue leg. It is a painful blue leg. The only difference is in painful white leg, you will notice that the superficial venous system is patent. Superficial venous system. The superficial venous system is patent, so blood is flowing back. In cerula dolens, both deep and superficial venous system, deep and superficial venous system is blocked. This is what we call it as cerula dolens. Beta, the minute we are done with the lecture, I will share this PDF soon after. Don't worry, you'll get it. Okay? Right. So for varicose veins, we have certain tests. Number one is Brody-Strenelberg test. The Brody-Strenelberg test is basically to differentiate. Brody-Strenelberg test we do to see whether it is a saphenofemoral junction incompetency or a perforator incompetency. Three tourniquet test is done to identify the site of perforator incompetency. To identify the site of perforator damage. To identify the site of the perforator damage, we do three tourniquet test. Perthes test is done to predict the history of DVT. To evaluate the history of DVT. To evaluate the history of DVT, we do Perthes test. Okay. So this is with respect to your venous disorders as well. Okay. Sure. We'll do one thing. We'll take a short break here for 15 minutes. Okay. It is 120. We'll resume back at let's say 140. Beta PDF, because I think the Telegram is blocked. I think it should be open today. No, 22nd tak blocked tha. I will put this on my Telegram group. I'll put this in the. We have a WhatsApp group for our FMG aspirants. I'll put it on the WhatsApp group. I'll put it on the Telegram group. I'll also put it on the PW's our app also. You can download wherever you want it. Okay? Let's take a short break here. We'll resume back at 1:40. All right, can we start? Can we go? Can we go? All right, so I've taken the feedback. I mean, okay, you're thinking that we're writing too much. There's a reason that I keep it in a way, because if everything is pre-printed, you will not know where to concentrate on. So when I write, it is basically before I write, you should be able to guess the answer. You should be able to recite it. That's the objective behind the session. So if you feel the time is getting dragged on, we'll make sure from next time onwards when we will create the material, it will be mostly pre-printed only, right? Okay, chal. No, I do understand that because the last leg where your exam is a week ago, you'll have a little bit of stress. I totally get that. I'll try to be a little bit faster also so that we cover up that time as well. Now, in terms of burns, what is the most common method used to assess the total body surface area of burn? We call it as the Wallace rule. The Wallace rule is also called as the rule of 9, correct? Second, the best method if they ask you, this is going to be the Lund and Broders chart. It is the Lund and the Broders chart. The most common cause of immediate death. When I say immediate death in burns, it is secondary to asphyxia. Immediate death is because of asphyxia. If they ask you for early death, that is going to be hypovolemic shock. It is the hypovolemic shock. Most common cause of death overall, if they ask you, it is secondary to sepsis. Most common organism causing burn wound infection is Pseudomonas. It is a Pseudomonas. The best topical agent is your silver sulfadiazine. It is silver sulfadiazine with cerium nitrate. It has the ability to penetrate eschar. It has got amazing property of both gram-positive bacteria as well as Pseudomonas it can address. How do you calculate the colloid requirement? It is done with the Muir and Barclay. It is done by Muir and Barclay formula. Now, when I say Muir and Barclay, it is 0.5 into weight in kilograms into percentage of total body surface area burnt. This is how you calculate Muir and Barclay. The fluid of choice, needless to tell, it is ringer lactate. The colloid of choice is your human albumin solution. It is a human albumin solution. Rule of 9, you have to memorize it. The difference between adult and child. In adult, the head comprises of 9%. The child, it is going to be 18%. Upper limb in adult is 9%. Child is also 9%. Anterior trunk we are talking about. Anterior trunk is going to be 18%. Child is also 18%. The posterior trunk. Trunk is chest and abdomen together. So posterior trunk is 18%. Here also 18%. Perineum in adult accounts for 1%. There is no perineum in children. Lower limb in adult is 18%. Child, it is going to be 14%. Right. The criteria to call a patient to be a child, the age should be less than 14 years according to ATLS. Adult in ATLS is age above 14 years. Right. What is the definition of a significant burn? In order to call a patient is having a significant burn, number one, if the age is less than 10 years or it is more than 50 years, then it is more than or equal to 10% of the total body surface area burnt. If the age is between 10 to 50 years, then it should be more than or equal to 20% of the total body surface area burnt. Then we'll call it as a significant burn. It's going to be significant burn. Now, when you look at the burn wound classification, how do you classify them into first degree, second degree, superficial, third and fourth degree? We have a quick recap. If there is only involvement of epidermis, it is your first degree. Papillary dermis, secondary superficial. Reticular dermis, secondary deep, full thickness of the skin, third degree, involvement of underlying structure. Involvement of an underlying structure, it is a fourth degree burn. Color here, there will be only erythema. Second superficial will be bright red. Secondary deep is mottled pink or waxy white. Mottled pink or waxy white. Third degree, it is leathery. Fourth, it is going to be charred in appearance. It is going to be charred in appearance. Now, wherever there is skin, there will be pain. First degree is extremely painful. Second degree is superficial, is painful. Second degree deep, there is no pain, but there is something called as intact pinprick sensation. There is pin prick sensation is present. No skin, no pain. Blisters are actually where you have skin. Secondary superficial blisters. Secondary deep may not. Where there is no skin, there cannot be no blisters. First, second degree superficial, second degree deep will heal. Third and fourth degree will not heal. Management for first degree, see, all of them is going to, because they heal. So wherever you heal, you will follow the conservative management. We'll do conservative management. And wherever you not heal, here you have to go with either skin grafting, and secondary deep, you have to go with flap reconstruction. You have to go ahead with flap reconstruction, right? So this is with respect to classification of the burn wounds. Now, according to ATLS, how do you calculate the fluid required for second degree and a third degree burn? For adult, it is 2 ml per kg per percentage of total body surface area burned. For child, it is 3 ml per kg per percentage of total body surface area burned. If it's a fourth degree burn, irrespective of child or adult, or it's an electrical burn, irrespective of child or adult, it is going to be 4 ml per kg per percentage of total body surface area burned. Remember, whenever you look at the urine output in adult should be more than or equal to 0.5 ml per kg per hour. For children, we expect the urine output should be more than or equal to 1 ml per kg per hour. If it is a 4th degree burn, the urine output to be expected is going to be anywhere between 1 to 1.5 ml per kg per hour. More importantly, here urine must be clear. Urine must be clear. Okay. So this is with respect to 4th degree burn. Now, we'll talk about all the important components of the breast. Now, the first question is management of the fibroadenoma in an elderly patient. In an elderly patient, you have to go ahead with excision, not enucleation. Indication of biopsy for fibroadenoma. So, in fibroadenoma, I would like to take the biopsy. If the size of the lesion is more than 5 centimeters. If there is family history of breast cancer. If there is a family history of breast cancer. For long-standing mammographic finding of fibroadenoma is going to be popcorn calcification. It is a popcorn calcification. When you talk about fibroadenoma in general, important points. Fibroadenoma has got 2 points, that is your fibrous and the adenomatous tissue. So it's a mixed tumor. It is also called as breast mouse. Investigation of choice is ultrasound. Management less than 5 centimeters, it is observation. If it is more than 5 centimeters, then it is going to be enucleation. It is going to be enucleation. Zuska's disease is periductal mastitis. It is periductal mastitis. It is periductal mastitis with normal ducts. Zuska's is seen in age group around 30 years and it is associated with smoking. If you have a patient BIRAT3, that is a breast imaging reporting and data system, Okay. Right. So Byrite series, guys, I don't want you to have any discussion regarding whether the way I'm teaching right now, is it a good method or a bad method, because we don't have any other method as of today. So this is the only method that we have. So let's stick to it. I do understand, I've taken the feedback. I do understand that you guys want to have more quicker revision, especially it's on a YouTube where you're spending a very little time and you want to get the yield. I get it. But then it will be like only chanting a session, right? I'm trying to make some sense here. We'll try to do it. Next session, I'll try to concise the workbook. I'll try to have more printed version, but I don't want you to attend this session another time, because I want you to clear off the FMG exam, see us in NEET PG and INI preparation. There I will implement your suggestion. All right. So अभी के लिए डिस्कशन नहीं रखते, सिंपल कॉन्सेंट्रेट करते हैं. क्या पूछ रहा हूँ, बायराइट 3 का मैनेजमेंट क्या है. ब्रेस्ट इमेजिंग रिपोर्टिंग डेटा सिस्टम अगर आपका कैटेगरी 3 है, कैटेगरी 3 के लिए क्या करोगे, यू विल डू रिपीट अल्ट्रासाउंड after 6 months, and this is the only question that is asked in Byrite's. ठीक है, चलो. Now, when you talk about phylloids tumor, phylloids tumor arises from the interlobar stroma. It is also called as the serocystic disease of Brodie's. The investigation of choice here is going to be true cut biopsy. The HP that you will see is going to be leaf-like arrangement. It is leaf-like arrangement. This is going to be the leaf-like arrangement of tumor cells. It is a leaf-like arrangement of the tumor cells. How do you call it as benign? We say if it is less than or equal to 4 mitosis. Less than or equal to 4 mitosis for 10 high power field, it will be benign. If it is 5 to 9 mitosis, if it is 5 to 9 mitosis for 10 high power field, it is borderline. And if it is more than or equal to 10 mitosis for 10 high power field, then it is a malignant phylloids tumor. Comparison between duct papilloma and duct ectasia. The age of presentation for duct papilloma and duct ectasia, both of them is going to be age above 40 years. Papilloma will present to you as bloody nipple discharge. It will present to you as bloody nipple discharge. I hope everybody remembers the most common cause for bloody nipple discharge is going to be duct papilloma. Duct ectasia will present to you with periductal mastitis. It will have periductal mastitis feature with greenish nipple discharge. With greenish nipple discharge. For duct papilloma and duct ectasia, the investigation of choice is ductography. It is your ductography. Management for duct ectasia, duct papilloma is going to be microdocectomy, that is surgery. Microdocectomy, that is surgery. For duct ectasia, it is your Hadfield surgery. So in microdocectomy, you only remove the duct, the entire duct with papilloma, not the papilloma. The entire duct has to go. That is called microdocectomy. In your Hadfield surgery, you remove all the affected ducts. You remove all the affected ducts. Now, another very interesting question is, they'll ask you which of the following lesions will present to as osteoblastic secondaries versus osteolytic secondaries. For osteolytic secondaries, it is follicular cancer, thyroid, lung cancer, breast cancer, and RCC. Remember, breast cancer will more commonly present to you as osteolytic when compared to osteoblastic. In osteoblastic, you will notice there will be medullary cancer, thyroid, breast cancer, carcinoid tumor, stomach cancer, bladder, and prostate. लेकिन breast cancer में अगर पूछेगा, remember breast cancer. In breast cancer, it is osteolytic secondaries are more common when compared to osteoblastic secondaries. It is osteolytic secondaries are more common when compared to osteoblastic secondaries. Okay? So that is the difference between the osteolytic and the osteoblastic secondaries. Now, specifically on breast cancer, what are the anticipated questions? The gene associated with breast cancers, we all know it is going to be BRCA1, BRCA2, STK11 and P53 gene mutation. These are the important genes. Indication for prophylactic mastectomy. Prophylactic mastectomy is done in lobular carcinoma in situ. It is done in lobular carcinoma in situ. And if the patient is having high, that is if there is a BRCA mutation positive. If there is a BRCA mutation positive. Investigation of choice for screening for high risk population. For high risk, it is going to be MRI, and the age at which you start the screening is about 25 years. HBOC syndrome with BRCA mutation, age less than 25, age less than 25, do nothing. Age more than 25, I will go with MRI. If the family is complete, I'll go with prophylactic mastectomy. Investigation choice for diagnosing breast cancer, it is going to be true cut biopsy. For staging, it is going to be PET CT. Prognosis of the breast cancer depends upon the stage, if not the lymph node status, if not the size of the tumor. There's a sequence that you have to remember. According to luminal criteria, the best prognosis is you have luminal A. The best is going to be luminal A, where there is ER positive, PR positive, and HER2 neogene negative. Worst prognosis is going to be the basal cell type. The basal cell type is what we have triple negative, where you have ER negative, PR negative, and HER2 neogene status is also negative. HER2 neogene status is also negative. How do you know patient is having stage 3A, 3B, 3C? I've told you our magic portion. For 3A, remember if there is an N2 disease. For 3B, remember it is a T4 disease. For 3C, remember it is an N3 disease. If you have these, you have 3A, 3B, 3C. Now, the management for 3A, 3B, 3C is we start the patient on neoadjuvant chemotherapy. Neoadjuvant chemotherapy followed by modified radical mastectomy followed by adjuvant therapy. This is what we follow for your locally advanced. 3A, 3B, 3C is called as locally advanced breast cancer. It's a locally advanced breast cancer, right? Management of early invasive breast cancer. For an early invasive breast cancer, you can go with breast conservative therapy or simple mastectomy. Plus, if the receptor status ER/PR is positive, then you can hormonal therapy. If ER/PR is positive, then you can give HRT. For locally advanced breast cancer, we've already done. It is your see, when I say early invasive breast cancer, for an early invasive breast cancer, it is stage 1, 2A, and 2B. When I say locally advanced breast cancer, it is 3A, 3B, and 3C. We have already done. It is your neoadjuvant chemotherapy followed by modified radical mastectomy followed by adjuvant therapy. In simple mastectomy, what do you remove? I remove the glandular part of the breast. We'll remove the entire stroma of the breast. We remove the nipple areolar complex. We remove the nipple areolar complex and we remove the pectoralis fascia. If you remove this, this is what we call it as simple mastectomy. In modified radical mastectomy, we will do simple mastectomy. We'll do simple mastectomy with removal of level 1, level 2, and level 3 group of lymph nodes. The modified radical mastectomy have 3 varieties. We have Patty's surgery, we have Scanlon, and we have Auchincloss. Remember, Auchincloss is the most commonly performed modified radical mastectomy. Stewart-Travis syndrome is seen post modified radical mastectomy. So a patient has underwent a modified radical mastectomy after 10 to 15 years. After 10 to 15 years, patient develops same-sided ipsilateral same-sided lymphangiosarcoma. Lymphangiosarcoma of upper limb. Lymphangiosarcoma of the upper limb, and that indicates the patient is having Stewart-Travis syndrome, very poor prognosis. Now, why does the skin dimpling occurs? It is because of involvement of Cooper's ligament. It is because of involvement of Cooper's ligament. And remember, stage remains unchanged. The stage remains unchanged if there is dimpling. P of the orange is because of involvement of subcutaneous lymphatics. there's obliteration of subcutaneous lymphatics. Now, this obliteration of subcutaneous lymphatics is as good as involvement of skin, so it will become T4B disease. Minimum number of lymph nodes to be removed. How much minimum number of lymph nodes to be removed in order to stage breast cancer? Quick feedback. This I've asked you before also. Minimum number of lymph nodes to be removed. Quick feedback. Quick feedback. Minimum number of lymph nodes to be removed in breast cancer. Quick feedback. One second, guys. I'm updating my chat box. I've been logged out. One second, guys. Right, back on. What are the minimum number of lymph nodes to be removed in the breast cancer? Remember, the minimum number of lymph nodes to be removed to stage the breast cancer is 10. Now, if they ask you what are the minimum number of lymph nodes, what are the minimum number of lymph nodes to be removed for esophagus? For esophagus, remember it is 12. For stomach, it is going to be 16. For stomach, it is going to be 16. Okay? Not able to access the chat box. Okay. Breast, it is going to be 10. Esophagus is 12. Stomach is going to be 16. Stomach is going to be 16. Okay? Sure. Next, going into thyroid. Now, what is the optimum cytology criteria for a thyroid FNSE? Remember, number one, the size of the needle should be between 22 to 26 gauge needle. It should have 22 to 26 gauge needle. There should be a minimum of 2 aspirate. It should consist of 6 follicles per aspirate. It should consist of 6 follicles per aspirator, and there should be at least 10 to 15 cells per follicle. If you satisfy all this is called as optimum cytology criteria. What is the most common site for ectopic thyroid gland? Ectopic thyroid gland, the answer is sublingual. Investigation of choice for ectopic thyroid gland is your radioactive iodine scan with iodine 123. Most common site for thyroglossal duct cyst, it is your subhyoid. If the subhyoid is not in the option, then you can go with infrahyoid. Surgery of choice for thyroglossal duct cyst, everybody knows it, is a Sistrung's operation, where you remove a part of the hyoid bone also. Thyroglossal duct increases which variant? It increases papillary cancer thyroid. Which condition in simple goiter leads to sudden increase in size and pain if it is associated with hemorrhage? Whenever there is hemorrhage in the gland, there will be sudden increase in size and also cause pain. Which thyroid is associated with painful swelling? It is your Hashimoto's. Sorry, it is your de Quervain's. Painful is your de Quervain's. It is a de Quervain's thyroiditis. Thyroiditis initially hyper, but eventually hypo. It is a Hashimoto's. Thyroiditis initially hyper, eventually U. The eventually U thyroid can only occur in de Quervain's. It's a self-limiting condition. It is a de Quervain's. The thyroiditis which remains hypo throughout, it is a Riedel's thyroiditis. See, Riedel's is idiopathic, but it is also associated with IgG4 class of antibodies. It is associated with IgG4 class of antibodies. It is also associated with IgG4 class of antibodies. Sure. Drug of choice to decrease the vascularity in Graves' disease. Remember, it is your sodium iodide, potassium iodide, and Lugol's iodine. This reduces the vascularity of the gland. The most common ocular muscle involved in Graves' ophthalmopathy is inferior rectus. It is the inferior rectus. Now, the exophthalmos is nothing but Graves' ophthalmopathy. This is because of retroorbital edema, which is in turn because of your glucosaminoglycans, right? Now, when you look at the management of Graves' disease in age less than 40 years, the answer is total thyroidectomy. Age above 40 years, I will give radioactive iodine ablation with iodine 131. Plummer's disease, age less than 40 is total thyroidectomy. It depends upon whether it is unilateral or bilateral, sorry. If it is unilateral, then it is going to be lobectomy. If both the lobes are involved, then it is total thyroidectomy. Age above 40 is also same. It is single involvement lobectomy. If both the lobes are involved, then it is going to be total thyroidectomy. Here, toxic adenoma will go ahead with lobectomy. Age above 40 will give radioactive iodine ablation with iodine 131. Worst case scenario, they'll ask you what is the T half of iodine 131. The T half of iodine 131 is 8 days. And what is the radiation that it emits? It emits gamma rays and beta rays. It is the beta rays that is going to ablate. Beta is going to ablate. Now, this is the radioactive iodine interpretation. This is normal. If it is uniformly high uptake, Graves' disease. If there is completely damage, it is thyroiditis. If there is lesser uptake in one area, cold nodule. Remember, cold nodule is suspicious for malignancy. It is suspicious for malignancy. Hot nodule is a higher uptake that you can see here. If there is a patchy high uptake and cold nodule, hot and cold put together, it is going to be toxic multinodular goiter. Area where you have both hot and cold, it is going to be toxic multinodular goiter. Now, when you talk about thyroid cancers, a quick feedback on that. If they say what is the most common thyroid cancer, answer is papillary cancer thyroid, and that is associated with best prognosis. Most common thyroid cancer in an ectopic thyroid gland is follicular cancer thyroid. The one which is with worst prognosis, anaplastic and associated men's syndrome is a medullary cancer thyroid. All these disorders or malignancies will be seen in age above 50 except for papillary cancer thyroid, which is seen between 30 to 40 years. If you have medullary cancer thyroid associated with men's syndrome, then you will see at a younger age group, that is 20 years. When you look at the risk factor for papillary cancer thyroid, there is history of radiation exposure. It is secondary to radiation exposure and thyroglossal duct cyst. For follicular cancer thyroid, it is long-standing goiter. It is a long-standing goiter. There are no specific risk factors in the other two components. Clinically, when you talk about papillary cancer thyroid, either it can present as solitary thyroid nodule or a lateral aberrant thyroid. What is lateral aberrant thyroid? There is no swelling in the midline, swelling in the lateral neck. This is the metastasis from the papillary cancer thyroid. That is why it is also called as the silent thyroid cancers or occult thyroid cancers. Follicular cancer thyroid will have goiter with pulsatile forehead bony swelling. That is because of metastasis. Anaplastic will have a massive swelling with pressure symptoms. And medullary will have solitary thyroid nodule-like presentation with cervical lymphadenopathy and also associated with diarrhea. Now, this diarrhea is because the medullary cancer thyroid as a paraneoplastic syndrome produces 5-HT3, which is serotonin. And serotonin's effect on GI mucosa, it stimulates the GI mucosa, resulting in diarrhea. The investigation of choice, when you look at in most of these conditions, it is going to be ultrasound with thyroid function test with FNSC. Right? Problem in your follicular cancer thyroid is FNSC cannot differentiate. FNSC cannot differentiate between follicular adenoma and follicular carcinoma. And that is why the investigation of choice for follicular cancer is going to be lobectomy with frozen section. Lobectomy with frozen section. Rest everywhere else, it is going to be ultrasound with thyroid function test with FNSC. Same here. Ultrasound with thyroid function test with FNSC. Your pathology will tell you the two findings that you will see in your papillary cancer thyroid. Number one is your orphan ani nuclei, empty vacuolated cells. Orphan ani nuclei These are your empty vacuolated cells that you see. Another one is this onion peel appearance, which are called as the Samoma bodies. These are what we call it as Samoma bodies. Uh, I think Ranjit sir would have already taken about this. Samoma bodies are nothing but examples of dystrophic calcification. These are nothing but dystrophic calcification. Now, the dystrophic calcifications can also be seen in other three conditions, which can be remembered as PSM. P stands for papillary variant of RCC. It is a papillary variant of RCC. S stands for serous cyst adenoma. It is a serous cyst adenoma of ovaries. And M stands for meningioma. M stands for meningioma. ठीक है? Yeah. Now you can see these hyperstained cells, these are oxyphilic cells. Presence of oxyphilic cells indicates Hurthle cell carcinoma. It is a Hurthle cell carcinoma. And in medullary cancer thyroid, you see these amyloid strands which are breaching. This is what we call it as amyloid in stroma. Presence of amyloid in stroma. Presence of amyloid in stroma. Presence of amyloid in stroma is your medullary cancer thyroid. How does it spread? Remember, papillary cancer thyroid spreads via lymphatics, follicular hematogenous, anaplastic direct. Medullary cancer is both lymphatics as well as hematogenous. The most common site for secondaries here is going to be lungs. Here it is bones and it causes osteolytic secondaries. Here it is going to be lungs again. Here it is liver followed by bones. In bones it is osteoblastic. It is osteoblastic secondaries. It is your osteoblastic secondaries. It is your osteoblastic secondaries. All right. So this is the whole objective in terms of thyroid cancers. Now, whenever you're doing a thyroidectomy, two things: the position of the patient. This is what we call it as where the patient is having an hyperextension of the neck. This is what we call it as the rose position, or also referred to as the barking dog position. Also referred to as the barking dog position, right? This is the retractor that we use in thyroid surgery. It is called as a Jolls self-retaining thyroid retractor. It is a Jolls self-retaining thyroid retractor. If they ask you which is the best cosmetic outcome seen in approach, we have MEVATS, that's a minimal invasive your thyroid surgeries, right? MEVATS is what we call it as. MEVATS is minimally invasive. It is minimally invasive, video assisted thyroid surgery, and in this the best cosmetic outcome is going to be transaxillary. It is going to be transaxillary. For open surgeries, what is the incision? The incision is going to be Cockers incision. It is 1 centimeter below cricoid and 4 to 5 centimeters above the suprasternal notch. Above the suprasternal notch. It is 1 centimeter below cricoid and 4 to 5 centimeters above the suprasternal notch. That is your Cockers incision. Now, which is the most common postoperative complication of thyroid surgery? That is going to be reactionary hemorrhage. It is a reactionary hemorrhage. The most common cause for hemorrhage is slippage of ligature. The most common source of hemorrhage is your superior thyroid artery. If there is hoarseness of voice, it is because of unilateral recurrent laryngeal nerve damage. Loss of pitch is damage to the external branch of the superior laryngeal nerve. Respiratory distress if there is a bilateral recurrent laryngeal nerve injury. If there's a bilateral recurrent laryngeal nerve injury, then you will have respiratory distress, right? So these are your post-operative complications, right? What is the most common cause for primary hyperparathyroidism? It is your parathyroid adenoma. It's a parathyroid adenoma. Pentad of primary hyperparathyroidism. Number one is going to be painful bones. It is your painful bones. You have renal stones, abdominal groans, psychic moans, and fatigue overtones. So painful bones, renal stones, abdominal groans, psychic moans, and fatigue overtones is the pentad for primary hyperparathyroidism. The investigation of choice for primary hyperparathyroidism is your system scan. If I change the question, ask you what is gold standard, then it is your 4D CT. What is the Miami criteria? The Miami criteria is performed to know whether you have removed the right diseased parathyroid gland or not. According to Miami criteria, if there is decrease in parathyroid hormone at 10 minutes after removing parathyroid gland, and that there's a decrease in parathyroid hormone at 10 minutes after removing parathyroid gland, and this decrease should be more than 50% of pre-operative value, then we say Miami criteria is satisfied. That means you have removed the right parathyroid gland. A persistent disease, there is increase in serum calcium within 6 weeks of surgery. Within 6 weeks of surgery. Recurrent is increase in serum calcium after 6 months of surgery. If the serum calcium increase within 6 weeks, that means you have not removed the glands properly. So hence it is going to be persistent. If you have removed it, right, and for 6 months the patient is normocalcemic and then suddenly becomes hypercalcemic after 6 months, we call it as a recurrent disease, right? Now, where do you reimplant? If there's an accidental removal of parathyroid gland during the surgery, it is same side, ipsilateral sternocleidomastoid muscle. Same sided sternocleidomastoid muscle, we are going to reimplant. Surgery for parathyroid hyperplasia, it is going to be 3.5 surgery. And the other half is going to be reimplanted. It is going to be reimplanted onto the brachioradialis. Onto the brachioradialis of non-dominant arm. Of the non-dominant arm. The brachioradialis of the non-dominant arm. Now, in the radical neck dissection, we remove level 1 to level 5 group of lymph nodes, same-sided sternocleidomastoid muscle, spinal axillary nerve, and the internal jugular vein. Now, in a modified radical mastectomy, modified radical neck dissection, what are you going to modify? The first thing, I am going to remove level 1 to level 5 of group of lymph nodes. Now, based upon what we preserve, in type 1, we are going to preserve spinal axillary nerve. In type 2, we preserve spinal axillary nerve and the internal jugular vein. In type 3, we preserve spinal axillary nerve, internal jugular vein, and the sternocleidomastoid muscle. If you preserve all three, it is called as type 3 modified radical neck dissection. What is the current indication? What is the current indication for surgery in an asymptomatic primary hyperparathyroidism? Based upon the age criteria, if it is less than 50, if serum calcium is more than 1 milligram % above its normal limit, So normal is going to be 9 to 11 milligram percent, correct? So 1 above means if it is more than or equal to 12 milligram percent, then I'm going to operate. If renal parameters is your creatinine clearance less than 60 or urinary calcium excretion more than 400 ml milligrams per deciliter, again you have to operate. Skeletal we measure bone mineral density if there is a score of T-score of minus 2.5. Now the T-score that we are going to measure is going to be in the distal radius, femur, hip and vertebra. If you have T-score of minus 2.5 in any of these bones, that indicates that you have to operate. Now, radiologically, the three images that you should know. What is the image number 1? Image number 1 is a subperiosteal resorption. Now, this subperiosteal resorption that you will see, you will notice that this is the radial aspect, this is the ulnar aspect. So, it is, you can see there is bowing of the bone on the radial aspect of the middle phalanx, right? So, the most common site for subperiosteal resorption is going to be the radial aspect. It is the radial aspect of middle phalanx. It is a radial aspect of the middle phalanx. The second one that you see is your salt and pepper skull. It is the salt and the pepper skull. The third one that you have, you can see rugger jersey spine, where there is alternate bright white and dark ones. So this is what we call it as the rugger jersey spine. You have rugger jersey spine, right? So this is with respect to your parathyroid components. Now, in terms of hernia, let's have a quick recap. Difference between indirect and direct inguinal hernia. We all know it. What is the entry point for indirect inguinal hernia? It is going to be deep inguinal ring. The exit is going to be superficial inguinal ring, and the sac will be made up of peritoneum. Correct? Direct inguinal hernia, the entry is going to be from the Hasselbalch's triangle. We all know the boundaries of Hasselbalch's triangle is the lateral border of the rectus abdominis muscle, inferiorly by your inguinal canal and laterally by inferior epigastric artery. Exit is going to be from the superficial inguinal ring. The sac here is made up of fascia transversalis. It is a fascia transversalis. What is the relationship between the sac and the cord? Now, when the sac is going to arise, the sac lies lateral to the cord. Here, the sac lies medial to the cord. Sac lies medial to the cord. Relationship between the neck means entry and the inferior epigastric artery. Remember, the neck lies lateral to inferior epigastric artery in indirect inguinal hernia, and the neck lies medial. Neck lies medial to inferior epigastric artery in direct inguinal hernia. The risk for strangulation is high for indirect, less for direct. Ring occlusion test. So in the ring occlusion test, I'm going to occlude deep inguinal ring. I'm going to occlude deep inguinal ring, and I'm going to look for cough impulse. The cough impulse will be negative here, and on ring occlusion, the cough impulse, if it is direct inguinal hernia, it will be positive. What is the ideal characteristic of a mesh? Whichever mesh you're using, it should be number 1, non-absorbable. It should be non-absorbable. It should be lightweight. When I say lightweight, it should be less than 40 grams per meter square. It is less than 40 grams per meter square. So it should be non-absorbable. It should be lightweight. It should be lightweight. It should be hydrophobic. It should be hydrophobic, and it should be macroporous. There should be large pores. It should be large pores. Now, which is the most common nerve injury that occurs in an open inguinal hernia repair? It is your ilioinguinal nerve. It is your ilioinguinal nerve. The most common nerve trapped in mesh when you're doing an open inguinal hernia repair, it is your iliohypogastric nerve. Most common nerve injury in a laparoscopic inguinal hernia repair, it is your lateral cutaneous nerve of thigh. It is the lateral cutaneous nerve of thigh. It is the lateral cutaneous nerve of thigh. The risk for strangulation, highest is for femoral hernia, then indirect inguinal hernia, then direct inguinal hernia. The most common postoperative complication for an inguinal hernia repair is urinary retention. It is urinary retention. What is a Litter's hernia? If the content of the sac is Meckel's diverticulum. Ammian's hernia is the content of the sac if the content of the sac is appendix. Litter's hernia is if it is Meckel's diverticulum, and if it is appendix, then we call it as the Ammian's hernia. Right. So this is with respect to all the important points of hernia that you should be aware of. Now, one question that they'll ask you again and again, because all of them arise at the inguinoscrotal region. So I have a small comparative table between hydrocele, varicocele, and the inguinal hernias, right? Now, by definition, a hydrocele is the collection of fluid between the tunica vaginalis and that of the testis. Varicocele is the dilated pampiniform plexus. Inguinal hernia is protrusion. Hydrocele can be seen at any age group. Varicocele is seen in age above 40 years. Hernia is also seen in age above 30 years. There is no specific site for hydrocele. Varicocele is more common on left, hernia is more common on the right side. When you talk about the consistency, you will notice hydrocele will be soft. This will have a bag of worm appearance, and this will be variable hernia, whether it is bowel or omentum, it depends upon the consistency. Can you get above the swelling? The answer is yes in these two. You cannot get above the swelling in hernia. Is it reducible? It is not reducible. Varicocele and hernias are reducible. Cough impulse is going to be negative here. Cough impulse will be negative here. Cough impulse is going to be positive. The brilliant transillumination is there. There is no transillumination for these two. Fertility is normal here. It is decreased in varicocele. Hernia also it remains normal. Ultrasound is the investigation of choice for these two. For hernia, it is clinical examination. Treatment for hydrocele is going to be surgery. That is going to be either you can do Lord's procedure or Jabulois. Remember, Jabulois is the surgery of choice. Here it is Palamois varicocelectomy. And here it is Lichtenstein tension-free mesh repair. It is Lichtenstein tension-free mesh repair. It is your Lichtenstein tension-free mesh repair. Now, I've given you two signs that you have been demonstrated in hydrocele. The first is what we call it as the fluctuation sign positive. And second one is your transillumination. It is transillumination positive. It is a transillumination positive. Clear? It is a transillumination positive. Right? Sure. So this is with comparison to that of hydrocele, varicocele, as well as inguinal hernia. Now, in the laparoscopic inguinal hernia, there are three triangles, two triangles and then one area that you should know. Number one is triangle of doom. Triangle of doom, medially what is boundary, which boundary is formed? In triangle of doom, medially it is going to be vas deferens, laterally it is going to be gonadal vessel, inferiorly by peritoneum, apex is your deep inguinal ring. And when you look at the content, the triangle of doom's content is going to be external iliac artery. It is the external iliac artery and the external iliac vein. Injury to this will cause torrential hemorrhage, hence it is called triangle of doom. For triangle of pain, medially it is going to be vas deferens, laterally by iliopubic tract. It is the iliopubic tract, inferiorly by peritoneum, and apex is deep inguinal ring. The triangle of pain is also called as the electrical hazard zone. So here cautery is discouraged. Here the cautery is discouraged. What is corona mortis? Corona mortis is a aberrant obturator artery. It is an aberrant obturator artery. So it's an abnormal communication. It is an abnormal. It's an abnormal communication. It's an abnormal communication between inferior epigastric artery and obturator artery. Inferior epigastric artery and the obturator artery. That is a corona mortis. Right. Now, look at the ventral mesh placement. Now, this is your previous exam question. Now, in order to know the mesh placement, let's quickly run through its objectives also. The superficial is going to be skin that you see. Then you have the subcutaneous fat. Then you have these muscles. These are your external oblique muscle, internal oblique muscle, and the transverse abdominis muscle. Then you have fascia transversalis. Or simply called as the fascia transversalis. And the last one that you have is going to be peritoneum. Let's say the innermost layer that you can see here, this is your peritoneum. Now, based upon where you put the mesh, the first site is here, this mesh. This is what we call it as an onlay mesh repair. Between the subcutaneous fat and the anterior rectus sheath. So these two muscles that you see, this is your rectus abdominis muscle, and it is covered by anterior rectus and posterior rectus sheath, right? Now, if there is a mesh, this is between two rectus abdominis. This is what we call as inlay. Inlay is between the two rectus abdominis muscle. If you place the mesh between two rectus abdominis, it is your inlay. Then you have this. This is what we call as retrorectus. Retrorectus is between the rectus abdominis muscle and the posterior rectus sheath. It is mesh between the rectus abdominis muscle and posterior rectus sheath. The posterior rectus sheath. Then you see there's another one which is here. This is what we call it as sublay. Sublay is mesh between posterior rectus sheath, between the posterior rectus sheath and fascia transversalis. And the last one that you can see here, this is your IPOM. IPOM is intraperitoneal. This is an intraperitoneal onlay mesh repair. So whenever we say word onlay, it is one layer above or one layer below. So IPOM is done a laparoscopic surgery. It is laparoscopic mesh placement. IPOM is laparoscopic mesh placement. So with the help of laparoscopy, when you place just above the peritoneum, it is called as IPOM. So this is your mesh placement. They've asked you, last time they've asked you with a cadaveric image, so it is going to be important from our exam perspective. Okay? Clear? Answer. Chalo. Now, from here on, we have spotters. I want you to spot it quickly and we'll try to roll it across. Okay? Okay. Spotter number 1 in the GIT that you have, the first spotter, this is your coiling of nasogastric tube. Coiling of nasogastric tube is seen in which condition? It is your tracheoesophageal fistula, right? What is the most common type? The most common type is going to be type C variety. It is going to be a type C variety. Okay? Image number 2. You can see cervical esophagus, there is narrowing, right? It's here. It is like a web. It is a upper esophageal web. Upper esophageal. This is your upper esophageal web. Upper esophageal web is seen in which condition? Upper esophageal web is noticed in Plummer-Vinson syndrome. It is seen in Plummer-Vinson syndrome, also called as Patterson-Kelly syndrome. Same way, you have this one, image number 3. This is your lower esophageal web. The lower esophageal web is also called as the Schatzki's ring. They're also referred to as the Schatzki's ring. They're also referred to as the Schatzki's ring. They're also referred to as Schatzki's ring. It is secondary to GRD, where you have mucosal synechia. Image number 4, it's a spotter. It is an apple core sign. Now this apple core sign, as you can see, as if somebody has eaten the apple and left behind. No? It's like a classical apple core sign. The apple core sign is seen in esophageal cancer. It is seen in esophageal cancer. Image number 5, you can see there is a posterior outpouching in the cervical esophagus, and that is your Zenker's diverticulum. That is a Zenker's diverticulum. Now, with respect to Zenker's diverticulum, remember it is an example of a false diverticulum. It is a pulsion diverticulum. It is left-sided, and it's a cervical cervical region, so cervical diverticulum. It is a cervical diverticulum. It's a cervical diverticulum. The anatomical weakness. The anatomical weakness in this condition is seen in Killian's dehiscence. Now, Killian's triangle is made up of upper oblique and lower transverse muscle. The upper oblique is thyropharyngeus. And the lower transverse is made up of cricopharyngeus muscle. It is made up of the cricopharyngeus muscle. Image number 6, a newborn baby. You can see a massive air bubble in the left hemithorax. The heart is shifted on the other side, trachea is deviated. So this is your congenital diaphragmatic hernia. As you can see, it is having 3 important things. The mnemonic is RDS. The baby will have respiratory distress. The respiratory distress is because of pulmonary hypoplasia. It is pulmonary hypoplasia. The left side of the lung is underdeveloped. D, there is dextrocardia. And S, there is scaphoid abdomen. The scaphoid abdomen. Now, congenital diaphragmatic hernia, the one on the left side we're talking about, is the Bostalic hernia. 90% of the congenital diaphragmatic hernias are your Bostalic hernias. They are your Bostalic hernias. Then the spotter number 7, you have red velvety mucosa. There is red velvety mucosa on upper GI endoscopy. On upper GI endoscopy. So this is your Barrett's esophagus. This is your Barrett's esophagus. This is your Barrett's esophagus. It is associated with intestinal type of metaplasia. It is associated with intestinal type of metaplasia. It is associated with intestinal type of metaplasia where you see the squamous epithelium is converting into columnar with goblet cells. With goblet cell, that is an intestinal type of metaplasia, right? Remember, it increases the risk for adenocarcinoma of the esophagus. Investigation of choice for Barrett's esophagus will be upper GI endoscopy with biopsy. There is an upper GI endoscopy with biopsy. So that was spotter number 7. Spotter number 8. So what are the findings that you can see? This is what we call it as the bird beak appearance. It is also called as the pencil tip appearance. It is also referred to as the short rat tail. So the rat tail appearance. All these goes in favor of achalasia cardia. Now in achalasia cardia, what is the defining symptom that you have? The defining symptom for achalasia cardia. The defining symptom for achalasia cardia is going to be dysphagia. Now, when you look at the dysphagia and achalasia cardia, number 1, it is going to be progressive. Number 2, it will be more for liquids when compared to solids. And this will be associated with respiratory symptoms because of aspiration. So, if a patient has a progressive dysphagia more for liquids when compared to solids in association with respiratory symptoms, we know it is achalasia cardia. The investigation of choice for achalasia cardia is going to be manometry. And in manometry, we measure something called as integrated relaxation pressure, IRP of more than or equal to 15 millimeters of mercury with 100% paled peristalsis is going to be achalasia cardia. If I say what is the surgery of choice, is going to be Heller's cardiomyotomy. It is going to be Heller's cardiomyotomy. If in the exam they give you a bouncer, the new answer is going to be Heller-Dorr surgery, where you also do a partial fundoplication, because the minute you do a Heller's myotomy, you will create GRD for the patient. To prevent it, you have to also reinforce that with Dorr, that is your anterior partial fundoplication. It is your anterior partial fundoplication. It is your anterior partial fundoplication. Image number 9, you can see this is what we call it as the corkscrew, also called as rosary bed, also called as pseudodiverticulum, also referred to as beaded appearance. Also referred to as beaded appearance. All these points in favor of diffuse esophageal spasm. It is a diffuse esophageal spasm. They will have severe pain. So it is also called as esophageal angina. They'll also have the severe pain is esophageal angina. They'll have dysphagia. It is going to be equal for both solids and liquids. Again, investigation of choice is manometry. Here we measure something called as DCI, that is distal contractile integral. If DCI is more than 450 millimeters of mercury, then it is diffuse esophageal spasm. If DCI is more than 8000 millimeters of mercury, then it is called as nutcracker esophagus. That is called as the nutcracker esophagus. Spotter number 10 is your sliding hiatal hernia. You can see this is the diaphragm and you can see this is how it is slided up. The sliding hiatal hernia and a part of the stomach invaginating into thorax, this is called as rolling hiatal hernia. This is what we call it as the rolling hiatal hernia. This is what we call it as the rolling hiatal hernia. Now you can see this is image number 13 that you have is retrocardiac. There's a retrocardiac air fluid level. Now retrocardiac air fluid level is seen in two conditions. Number one, it can be seen in rolling hiatal hernia. Number two, in pediatric, it can be seen in Morgagni's hernia. It's also a congenital diaphragmatic hernia. It is called as a Morgagni hernia. So this is your retrocardiac air fluid level. This is your retrocardiac air fluid level. Quite evident. Now image number 14, again it's a spotter. It is what we call it as feline esophagus. Now this is described as stacked mucosal rings. This is also defined as stack of coins. So two conditions where you will see. Number one, it is seen in eosinophilic esophagitis. It is seen in eosinophilic esophagitis. And second, it can also be seen secondary to GERD. Two conditions where you can have feline esophagus. One is your eosinophilic esophagitis, another one is secondary to GERD. Image number 15, you see it is a PA view on a chest X-ray and there is presence of foreign body. Now this foreign body on a PA view, you are able to see the entire face of the coin. So it is having N face. If you see the entire face on a PA view, then it is going to be foreign body in the esophagus. Now, if you see on a lateral view, if you find N face, the entire face is seen on the lateral view. N face on a lateral view, then it is going to be in trachea. So it's a foreign body in trachea. Foreign body in trachea. This is going to be foreign body in trachea. So you can see here. You can see in an PA view, you can see the entire face of the coin. There's an N face and that indicates it is in the esophagus. Now, whenever you give a foreign body, how do you know it's a coin or a battery? Now, this is what we call it as the button battery. And this is the coin. How do you know? You see this rim sign. If you see double rim, if there's a double rim, a double rim indicates battery, right? And here there is no rim. If there's a double rim, it is a battery. If there is no rim, it is a coin. Right, so that was your spotter number 16. Now, spotter number 17 on ultrasound. This is for a 4-week-old baby. 4-week-old male child. The baby had recurrent episodes of non-bilious vomiting. What are the findings on the ultrasound that you are able to see? Number one, it appears like an ultrasound of the cervix. It is called as the cervix sign. This also looks like a projecting nipple, also called as the antral nipple sign. So cervix sign and the antral nipple sign. So the diagnosis for this baby is your congenital hypertrophic pyloric stenosis. The criteria to call this a CHPS, the length of this hypertrophized should be more than or equal to 16 millimeters, and the width of this hypertrophized segment should be more than or equal to 4 millimeters. If this is satisfied, we call the patient as having congenital hypertrophic pyloric stenosis. Surgery is going to be Ramsted's pyloromyotomy. You do a Ramsted's pyloromyotomy. ठीक है? चलो. Then you have neonatal vomiting, which you have just discussed it to have a clarity. Now, if you have a baby who is a 4-week-old and now presents to you with repeated episodes, that is recurrent vomiting, it is non-bilious, it's a male child. Male child, 4 weeks, recurrent episodes of vomiting, non-bilious, and on X-ray, you find single bubble. The diagnosis here has to be congenital hypertrophic pyloric stenosis. Investigation of choice is going to be ultrasound. Management is going to be surgery, that is your Ramsted's pyloromyotomy. It is your Ramsted's pyloromyotomy. Right? So this you can see a massive single bubble that you see as in CHPS. Day 0, day 1 is a child. Right? Again, there is recurrent vomiting. This time it is bilious. You get an X-ray done and you see there's a double bubble sign. There's a double bubble sign. See, one that you have is a gastric bubble, another one is your duodenal bubble. The diagnosis here is going to be either it can be a duodenal atresia or it could be annular pancreas. The surgery here is going to be duodenostomy. It is going to be duodenal. Same thing again, child, recurrent episodes of vomiting, bilious in nature. On X-ray, there is triple bubble sign. Now, if there is a triple bubble sign, you can see the 3 bubbles that you can count. This is bubble number 1, bubble number 2, bubble number 3. So, this is your jejunal atresia. This is going to be jejunal atresia. And management here is going to be jejunostomy. It is going to be jejunostomy. It's a jejunostomy. Okay? So these are the components that you should know in the context of neonatal vomiting. Now let's look at the comparison between the peptic ulcer disease. Now in the peptic ulcer disease, you have duodenal ulcers and the gastric ulcers. The site for duodenal ulcers is D1. For gastric ulcers, it is going to be antrum of the stomach, and that too on the lesser curvature. Ulcers environment for duodenal ulcers are hyperacidic. Gastric ulcers are normo or hypoacidic. Duodenal ulcers, the pain is present. It is seen after 2 hours of consuming food. the pain is present, it is immediately after consuming food. It's an immediate food pain. It is an immediate food pain. The appetite increases, weight gain is there. Here, there is loss in appetite, there is weight loss is there. Risk for hemorrhage is there in duodenal ulcer, but is more in your gastric ulcers. The risk for perforation is more in duodenal ulcers when compared to gastric ulcers. Duodenal ulcers never pre-malignant, gastric ulcers are. Investigation here is upper GI endoscopy, here upper GI endoscopy with biopsy. Whenever you're going to do assessment for H. pylori, remember PPI must be stopped 2 weeks before and antibiotics must be stopped 4 weeks prior to the investigation. That's both of them are exam questions, so pay attention here. Now, investigation of choice for H. pylori is your urease assay test, which is also called as CLO test. The best is going to be culture for any bacteria. Breath urease test is to assess the prognosis of treatment. And the most cost effective or the most inexpensive test is going to be stool antigen test. Management, we all know either it is a bit triple or quadruple therapy. Again, you have give one proton pump inhibitors, 2 antibiotics. Additionally, in quadruple therapy, you give ulcer protective, that is bismuth. Another drug that you can give is sucralfate. Another drug that you can add here is going to be sucralfate. Okay? So this is with respect to management. Now, Mallory Weiss tear, it is a longitudinal tear. It is a longitudinal tear all the way to submucosa. The most common site is going to be the cardia of the stomach. The cause is because of recurrent vomiting. It is because of recurrent vomiting. The clinical presentation would be of upper GI bleed. Investigation of choice is going to be upper GI endoscopy. Management is going to be argon plasma coagulation. It's an argon plasma coagulation if bleeding is there. It's a self-limiting condition. You don't need to do anything. Okay. So, gastric antral vascular ectasia. Again, it is going to be called as watermelon stomach. As the name itself, the most common site will be antrum. The management here is also going to be argon plasma coagulation. Delefoy's gastric lesion is an abnormal arteriole. It is an abnormal arteriole. The most common site is 6 to 10 centimeters from the gastroesophageal junction on the lesser curvature. On the lesser curvature of stomach. Management is going to be electrocoagulation. You buzz the vessel from where the bleeding is occurring. That is your electrocoagulation. ठीक है? All right. So, now important triads in the GIT, again important. The first one is your Carney's triad. Carney's triad is going to be multifocal cyst, paraganglioma, pulmonary chondroma. Macular triad is seen in Borav syndrome where you have retching followed by vomiting, retrosternal pain, surgical subcutaneous emphysema. Bouchard's triad is in gastric volvulus. You have pain, retching without vomiting, inability to pass nasogastric tube. Murphy's triad is in appendicitis, pain, vomiting, and fever. Charcot's triad is going to be in cholangitis, intermittent pain, fever, and jaundice. Quincke's triad, also called as the Sandbulum triad, is seen in hemophilia, where a pain, jaundice with melena. Tilloch's triad is seen in mesenteric cyst, where you have there's a cystic swelling which is present only mobile perpendicular to the direction of the mesenteric root, not along the mesenteric root, and there is a round or a zone of resonance around that cystic area. Now, so this is with respect to all the important triads. All 7 triads of GIT is important. Okay? Chalo. Now, from the rest of the components that are left behind, Technetium 99 is for Meckel's diverticulum. Now, this is the investigation of choice for complicated Meckel's diverticulum. For complicated Meckel's diverticulum. This is your classical coffee bean sign. This is your classical coffee bean sign. And you can see coffee bean is pointing towards the right upper abdomen. So, this is going to be sigmoid volvulus. This is your sigmoid volvulus. Now, this is on a barium enema. This is what we call it as the bird of prey sign. Bird of prey sign, again seen in sigmoid volvulus. Here you can see sawtooth appearance. Sawtooth appearance is seen in diverticulosis. Most common site for diverticulosis is going to be sigmoid colon. It is going to be sigmoid colon. Now you have hereditary cancer syndrome. We'll be comparing familial adenomatous polyposis, Gardner syndrome, Turcot syndrome, Cowden's disease, and Peutz-Jeghers syndrome. All of us know it. The gene for FAP, APC gene, Gardner APC, Turcot APC, Cowden's is P10 gene mutation, Peutz-Jeghers is STK11 gene mutation. The chromosome that you see is chromosome 5P, chromosome number 5Q. This is also 5Q, this is also 5Q. This is your 10Q and this is your 19P. All these disorders are going to be autosomal dominant in inheritance. So they are autosomal dominant. Now, from the familial adenomatous polyposis all the way to your Turcot syndrome, they have adenomatous polyp. They have adenomatous polyp. The Cowden's and the Peutz-Jeghers have hamartomatous polyp. They are hamartomatous polyps. GI features for all of them is going to be multiple polyps, that is polyposis. So all of them will have multiple polyps, that is polyposis. Remember, there is no specific non-GI criteria for FAP, but remember the criteria, there should be more than 100 polyps. Most common site is rectosigmoid. And it's got 100% malignant transformation. (100% malignant transformation). Okay. Now, when it comes down to your Gardner syndrome, the other component that you remember can be remembered by mnemonic, that is your for-fed. F stands for FAP, O is your osteoma, R stands for retinal pigmented epithelium. It is a retinal pigmented epithelium. F is your fibroma, epidermal cyst, and desmoid tumor. Turcot syndrome is basically FAP with brain tumors. FAP with brain tumors. Your Cowden's disease is associated with other components. कोई सवाल बेटा? Any questions? Any questions? Quick feedback. Refreshing the chat box. I have not seen anything. Any questions? No questions? Can you move on? Chalo. Now, when we talk about the Cowden's disease, in the Cowden's disease, the other malignancies it is associated with is your thyroid cancer. It is associated with endometrial cancer, endometrial cancer, melanoma, melanoma and breast cancer. Melanoma and breast cancer. Peutz-Jeghers syndrome, they are associated with mucocutaneous pigmentation. With mucocutaneous pigmentation. The most common site for polyps is jejunum. The clinical presentation here can be of interception. It is an interception. You can see this is the mucocutaneous pigmentation, and this is your more than 100 polyps. Okay. So this is with respect to hereditary cancer syndrome. All of them in a comparative data, quite important. Alright, so now it is your time. अभी तक मैं बोल रहा था, आप लोग सुन रहे थे, अभी आपको बोलना है और मैं सुनूंगा, ठीक है? So this is going to be a rapid fire. We have 5 lists in GIT which almost covers the entire GIT, ठीक है? क्या वो 5 लिस्ट है GIT की? Let's do a quick recap. Ready? मेरी भी उंगलियां दर्द हो रही हैं. I've been writing for last 4 hours continuously. ठीक है? Ready? So list number 1 is about the most common site or the most common type of the disorder that we have displayed it. ठीक है? Tracheoesophageal fistula, the most common type is going to be type C variety. Achalasia cardia, it is the lower 1/3 of the esophagus, which is the most common site. It is the lower 1/3 of the esophagus, which is the most common site. Zenker's diverticulum is seen in the cervical diverticulum. It is seen in the cervical diverticulum. Esophageal cancer is more common in the middle 1/3 of the esophagus. Barrett's esophagus is more common in the lower 1/3. Plummer-Vinson syndrome is seen in the upper esophagus. It is seen in the upper esophagus. It is seen in the upper esophagus. Boerhaave syndrome, where is the perforation? It is in the lower 1/3 of the esophagus. Mallory-Weiss tear, the most common site for tear is the cardia of the stomach. Peptic ulcer disease, most common site is the first part of the duodenum. Gastric ulcer, it is the antrum of the stomach on the lesser curvature. Interception, if they say in children, answer is ileocolic. And in adult, it is going to be colocolic. Adult, it is your colocolic. Volvulus, most common site is going to be sigmoid colon. Diverticulosis is sigmoid colon. Polyps is rectosigmoid. TB stricture is terminal ileum. Typhoid perforation, terminal ileum. Ulcerative colitis, rectum. Crohn's disease is again terminal ileum. Hirschsprung disease is rectum. Ischemic colitis is splenic flexure. SMA artery syndrome, this is the third part of the duodenum that is going to get compressed. Acute mesenteric ischemia, it is the superior mesenteric artery embolism. Large intestinal malignancy, it is rectosigmoid. If this is not in the option, then rectum. If not, into sigmoid colon. Perforation in peptic ulcer disease, it is anterior ulcers that perforate. And it is duodenal ulcers that perforate more often than gastric ulcers. Hemorrhage in peptic ulcer disease, they are posterior ulcers that bleed. Again, it is the gastric ulcers that bleed more often when compared to duodenal ulcer. Most common source of bleeding in peptic ulcer disease is your gastroduodenal artery. It is a gastroduodenal artery. Fistula in ano, when you talk about the most common type, it is an intersphincteric type. According to Parkes. Parkes classification, it is an intersphincteric type. Hemorrhoids, the most common is internal hemorrhoids at 3 o'clock, 7 o'clock, and 11 o'clock. It is 3 o'clock, 7 o'clock, and 11 o'clock. Anal cancer, the anal cancer, it is below the dentate line. That is a squamous cell cancer. That is a squamous cell carcinoma. Okay? So this is your list number 1, all the disorders and their most common sites. Okay? Can we move on? Can we move on? Can we move on? Chalo. Going to list number 2. Named ulcers and their site. So when we talk about aphthous ulcer, it is seen in oral cavity. It is associated with Crohn's disease. See, it is also a Behçet's disease, but we are talking about from GI disorder, it is a Crohn's disease. Cameron's ulcer is going to be seen in hiatal hernia. It is more commonly seen in sliding when compared to rolling. Peptic ulcer disease, most common in the first part of the duodenum. Gastric ulcer, it is in the antrum of the stomach and that too in the lesser curvature, also called as angularis incisura. Duodenal ulcers, most common in the first part of the duodenum. TB ulcer in the terminal ileum. Typhoid ulcer is also in the terminal ileum. Bell-shaped ulcers are nothing but tubercular ulcers, so they are in terminal ileum. Flask-shaped ulcers is seen in Entamoeba histolytica. This is more common on cecum when compared to ascending colon. Serpentine ulcers is in necrotizing enterocolitis. It is seen in small intestine. Cobblestone mucosa, it is seen in Crohn's disease. It will be seen in terminal ileum. Solitary rectal ulcer is going to be in rectum. It is going to be, see, usually it is secondary to rectal prolapse, or it can be because of rectal interception, it can be because of passing hard stools, right? So it is seen secondary to rectal prolapse and chronic constipation. Skip ulcers are seen in Crohn's disease, again terminal ileum. Okay. So that's a list number 2. Going into list number 3, chemo regimes and the malignancies. For esophageal cancer, we follow ECF, epirubicin, cisplatin, 5-fluorouracil. Carcinoma stomach is also ECF. Small intestinal adenocarcinoma, we follow Folfox. FOL is your folinic acid. F stands for 5-fluorouracil. OX is your oxaliplatin. For large intestinal adenocarcinoma, you can use Folfox or Folfoviri. So in this, the Folfox regime is same. Here Fol and F is same. IRI stands for irinotecan. There is your irinotecan. For rectal cancer, it is the same. Anal cancer, that is for squamous cell, it is Negros regime. Now in Negros regime, what do you have? Negros regime is 5-fluorouracil with metamycin C with radiotherapy. It is called as chemoradiation. This is what we call it as the chemoradiation. This is what we call it as the chemoradiation. For GIST, it is, so imatinib is a drug of choice. If there is an imatinib resistance, then it is sunitinib. For imatinib resistant gist, we give sunitinib. For HCC, it is sorafenib. For gallbladder carcinoma, it is gemcitabine. It is gemcitabine with cisplatin. For cholangiocarcinoma and pancreatic ductal adenocarcinoma, we follow the same regime. Then you have the GI malignancy and the margins of resection. Remember, for esophageal cancer, proximal is 10 centimeter, distal is 5 centimeter. Rest everywhere, proximal will remain 5 centimeters. Distal will also remain 5 centimeters. The only change is going to be rectal cancer, where you have 2 centimeter as the distal margin. Is a 2 centimeters distal margin. Disorders and management, we're talking about the surgical management. For achalasia cardia, it is your Heller's cardiomyotomy. It is a Heller's cardiomyotomy. Diffuse esophageal spasm, we only go with medical management. Zenker's diverticulum, less than 3 centimeters, we do diverticulectomy. More than 3 centimeters diverticular mouth, we do a Dolman surgery. Esophageal cancer, we have 3 techniques. We have Ivor-Lewis, we have McEwen's, and we have Oringer's. Oringer's is the most common. CHPS is a Ramsted's pyloromyotomy. But remember, in CHPS, if they ask you what is the first line management, the first line management is electrolyte correction. It is a electrolyte correction followed by Ramsted's pyloromyotomy. Perforation in peptic ulcer disease is your Graham's omental patching. It is your Graham's omental patching. Peptic ulcer disease is triple or a quadruple therapy. Triple or a quadruple therapy. For GRD, first is medical management. If it fails, the surgery of choice is going to be Nissen's fundoplication. Nissen's fundoplication is a posterior fundoplication. It's a 360 degrees fundoplication. For a D1 stricture, you can do Heineken muclids. Pyloroplasty. For duodenal atresia, it is duodenodenostomy. Same for annular pancreas also. For jejunal atresia, it is jejunojejunectomy. It is a jejunojejunectomy. For ulcerative colitis, first is medical management. If it fails, then total proctal colectomy with ileoanal J pouch anastomosis. With ileoanal J pouch anastomosis. Diverticulosis is a medical management. If it fails, then elective sigmoid resection. Then elective sigmoid resection. For familial adenomatous polyposis, we do same as that of your ulcerative colitis, that is total proctal colectomy with ileoanal J pouch anastomosis. For rectal prolapse, now this is important. So you have the perineal procedure. Perineal surgery is done for elderly patients. So this is your Thierch wiring. You have Delrome. and you have Altamere. Then you have abdominal approach. Abdominal approach is going to be Repstein, Wells, and your Freichmann Goldberg. Remember which of the following is an abdominal route and which of the following is a perineal route. For old patients, we use perineal route. For young patients, we'll use abdominal route. For Hirschsprung disease, we do pull-through surgeries. That is Duhamel, Swenson, and Suas. Hemorrhoids, we can do Milligan-Morgan. It is a Milligan-Morgan surgery. Another one is Ferguson surgery. Another one is a Ferguson surgery. Adenocarcinoma of the anal canal, we do APR, that is abdominoperineal resection. It is your abdominoperineal resection. APR, that is your abdominoperineal resection. So this is all in all that you should know in the context of entire GIT. So far, any doubts, quick feedback, any questions? Okay. Chalo. We'll take a short break again here. It is 3:30. We'll resume back at 3:50. And by another 1.5 hours, we should be able to finish, right? So before 6, we'll wrap up this session, right? So we'll take 15 minutes or 20 minutes break. That is 3:50, we'll resume back. Okay? Take a short break. Okay, so let's continue. We'll talk about the Brisbane's terminology for liver resection. Can we start? Can we start? Sure. So talk about the Brisbane's terminology for liver resection. I've given you all the parts of the liver here. So just to give you an objective, this is divided on the base of hepatic vein. This is your left hepatic vein. This is your middle hepatic vein, and this happens to be your right hepatic vein. So what hepatic vein does is it divides the liver into various sections. This is what we call it as the left lateral section. This is what we call it as the left medial section. This is your right anterior section. And this is your right posterior section. And to smaller segments, it is divided by portal vein, right? So when I say right hemiliver or right hemihepatectomy, what are the segments that I'm going to remove? It is 5, 6, 7, and 8. Left hemihepatectomy is going to be 2, 3, 4A and 4B. Right anterior section will be 5 and 8. Right posterior would be 6 and 7. Left lateral is going to be 2, 3. Left medial is going to be 4A and 4B. Right trisectionectomy is 3 sections from right side, that is 5, 6, 7, 8 plus 4A and 4B. Left trisectionectomy will be a 2, 3, 4A, 4B plus 5 and 8. That is a right anterior sectionectomy. Correct. So this is about your Brisbane's terminology for liver resection. Now, the most common organism causing pyogenic liver abscess is going to be E. coli and Klebsiella. It is E. coli and Klebsiella. Most common route of spread is going to be via the bile duct. The most common LFT abnormality in pyogenic liver abscess, PLA, reverse writer is ALP, that is alkaline phosphatase is elevated. Most common organism causing amoebic liver abscess is Entamoeba histolytica. Most common route of spread for amoebic liver abscess, how does it goes to liver? It is via portal circulation. It is via the portal circulation. Drug of choice for amoebic liver abscess is metronidazole. It is a metronidazole. Treatment of choice for hydrated cyst is going to be PAIR, that is puncture, aspiration, and installation of scolicidal agent. Installation as scolicidal agent and reaspiration. And reaspiration. And reaspiration. The most common genetic mutation in hepatic adenoma is HNF1 alpha gene mutation. OCP is a risk factor for hepatic adenoma. It is a risk factor for hepatic adenoma. Giant hemangioma is size more than 5 centimeters. Indication surgery for hepatic adenoma if the size is more than 5 centimeters. Indication for sorafenib in hepatocellular cancer. Child-Pugh classification should be A or B. PST should be between 1 or 2. Lymph nodes should be positive and there should be metastasis. Then you can give sorafenib. What are the components of Child-Pugh classification? I hope everybody remembers it. It is energetic BAP. B stands for bilirubin. A is albumin. Another A is going to be ascites. P is increase in prothrombin time. And E stands for encephalopathy. E stands for encephalopathy. E stands for encephalopathy. Okay. Clear? Chalo, how much is an adequate FLR? Remember, FLR stands for future liver remnant. It is your future liver remnant, and it should be 20%. If there is liver cirrhosis, for liver cirrhosis, the adequate FLR is going to be 40%. Okay, this is 40%. Criteria for liver transplantation in HCC. You have two criteria. One is your BCLC criteria. Another one is Milan's criteria. According to Milan's criteria, it can have solitary or multiple tumors. It can be solitary or multiple. If it's solitary, it should be less than 5 centimeters. If it is multiple, it should be less than 3 in number and less than 3 centimeter in size. And there should be no evidence of lymphovascular spread. No evidence of lymphovascular spread. Then according to Milan's criteria, we can give the patient liver. BCLC on the other hand, it says, see BCLC, number one, the child pug class has to be A or B. The PST should be 0. It should be single tumor. It should be single tumor. Portal vein should be normal and bilirubin should be normal. Then I can go liver to these patients, right? This is according to BCLC criteria. But adequate FLR 20% है, 25 नहीं है. For normal patients, it's 20. For cirrhotic patient, it is 40%. ठीक है? चलो. This is for the transplant in the patient of hepatocellular cancer. Now, comparison between the HCC and fibrolamellar is your favorite question. Remember, HCC is more common in males. Fibrolamellar is equal. HCC is seen in after 5th decade of life. Fibrolamellar is in 25. Tumor are more aggressive and they are poorly differentiated here. Fibrolamellar well differentiated, well circumscribed. Only 25% of the tumors are resectable in HCC. 75% of the tumors are resectable in fibrolamellar variant. HCC is associated with liver cirrhosis as well as hepatitis B, whereas fibrolamellar variant is not associated. The tumor marker is PYQ2, that is protein-induced vitamin K absence 2. Another one is your alpha fetoprotein, which is also elevated. Here, alpha fetoprotein remains normal. So, the tumor marker here is B12 binding protein and neurotensin. Neurotensin is elevated, B12 binding protein is elevated. Prognosis for HCC is poor, fibrolamellar is relatively good. Difference between primary and secondary HCC: primary is going to be large, central and hypervascular. Secondary HCC is small, peripheral and hypovascular. The most common malignancy of livers are secondary. Most common primary malignancy of secondary to liver is your colorectal cancer. Colorectal cancers. ठीक है? Clear? चलो. In the biliary system, what are the boundaries of the Callet's triangle? We know the Callet's triangle is formed by three things. That is your common hepatic duct, cystic duct and the cystic artery. The content here is going to be the lymph node of Lund. If they ask for hepatocystic triangle, it is the inferior surface of the liver or inferior border of liver with common hepatic duct and the cystic duct. Here the content is going to be cystic artery. Content is cystic artery. Most common type of congenital choledochal cyst is going to be type 1 variety, which is a fusiform variety. Congenital choledochal cyst with the worst prognosis is type 4A, both intra and extrahepatic. Surgery of choice for extrahepatic biliary atresia is going to be your portoenteric anastomosis. The portoenteric anastomosis is also called as the Kasai surgery. Composition of cholesterol stones. Now, this has been a previous exam question. What is the composition of cholesterol stones? Composition of cholesterol stones, quick feedback. Composition of cholesterol stones. Composition of cholesterol stones. Composition of the cholesterol stones. It is formed of obviously cholesterol crystals with calcium salts, bile pigments, and mucin glycoprotein. It's a mucin glycoprotein. Composition of the black pigmented stone that occurs secondary to hemolysis, that is your calcium phosphate and calcium bicarbonate. Brown pigmented is going to be calcium palmitate and calcium stearate. Calcium palmitate, calcium stearate. Triad of cholecystitis is going to be pain, fever, leukocytosis. That is elevated WBC count. Charcot triad is going to be pain, fever, jaundice. And all of them will be intermittent. All of them is going to be intermittent. When we talk about Raynaud's pentad is going to be pain, fever, jaundice with altered sensorium, and sepsis. With altered sensorium and sepsis. Retained CBD stone is CBD stone within 2 years of cholecystectomy. Within 2 years of cholecystectomy. One important criteria, these should be non-brown pigmented stones. These are your non-brown pigmented stones. Primary CBD stones are stones formed in CBD. Most common is brown pigmented stones. Most common is the brown pigmented stones. Secondary CBD stones are stones formed in gallbladder and lodged into CBD. Courvoisier's law is basically a palpable distended gallbladder is seldom secondary to stones. That means a gallstone cannot produce a palpable distended gallbladder. As simple as that. Okay? These are your Courvoisier's law. These are the important aspects in the biliary system. Now, this is what they'll ask you again and again with respect to your bile duct injuries. Now, if there is an intraoperative bile duct injury, you see whether it's a known bile duct or is it an unknown bile duct. If it is known bile duct, then it is always repair. If it is unknown, you have to do an intraoperative cholangiogram. In the intraoperative cholangiogram, see the size of the duct from where it is leaking, less than or equal to 3 millimeters or more than that. Less than 3, it is small, you can go and ligate it. More bigger ones, that is more than 3 millimeters, you should always repair because they drain significant amount of area. In post-cholecystectomy pain, any patient after cholecystectomy, they present with pain, the first line management is going to be USG with LFT. Now, on an ultrasound, if there's significant fluid collection, you have to go with USG guide aspiration. If it is bile stain, then you'll go with ERCP and stenting. If ERCP fails, then you'll go to CBD exploration. You take the CBD exploration. Now, if your radiologist says their CBD is dilated, I don't know the cause. To evaluate the cause for CBD dilatation, I'll go with MRCP. On the MRCP, if there is a bile duct injury, then I'll go with ERCP with repair, right? On the other hand, if there is on MRCP, if there is a CBD stone, if there is a CBD stone which is established, we'll do stone extraction. We'll do ERCP and stone extraction. On the other hand, your radiology directly says a CBD stone, directly take the patient for ERCP and stone removal. If there's no biliary pathology identified, then take the patient for CECT. Now, every single time you attempt these questions, sometimes the answer will become ultrasound, sometimes it will become MRCP, sometimes it will be ERCP. Now, this is what you have to remember in order to answer everything precisely. Post-cholecystectomy pain, if the patient develops post-cholecystectomy, if the patient develops pain, what is the first or the next immediate step? Ultrasound guided LFT, right? USG with LFT has to be done. On the ultrasound, now there are 4 scenarios. Number 1, there could be significant fluid collection. Number 2, there could be CBD dilated. Number 3, there is a CBD stone. Number 4, there is no pathology. If there's fluid collection, aspirate, confirm, bile is there, do ERCP. If there is leak is there, do a stenting. If stenting cannot be done, you go and do an open CBD or a laparoscopic CBD exploration. Second, if your radiologist says CBD is dilated, I don't know the cause. It could be stricture, it could be stone. How do you do it? Do an MRCP, confirm the cause, and then move. Third, it directly says on an ultrasound CBD stone is visualized. Then directly go with ERCP and remove the stone. Fourth, there is no biliary pathology identified. That means there is some other structures in the surrounding area that is getting damaged. And for that, you have to go ahead with CECT abdomen. As simple as that. Okay? Chalo. Now, on the HPV images, the first one is the infective one. This is your pyogenic liver abscess. This is your pyogenic liver abscess. How are you able to tell you? There are multiple irregular puddles of collection. They are multiple. They are hypodense. There is irregular collection. So anytime the patient has right hypochondriac pain with high grade fever, with obstructive jaundice, think in terms of pyogenic liver abscess. If there is single collection, this is your amoebic liver abscess. It is your amoebic liver abscess. It is your amoebic liver abscess. One second, guys. Amoebic liver abscess, it is usually solitary, hypodense collection. For here again, there will be right hypochondriac pain with fever, with history of colitis. If this is there, then it's an amoebic liver abscess. Now this septation is present. This is your hydrated cyst. Presence of septation confirms it is your hydrated cyst of the liver. Now on an MRI, if you see peripheral enhancement, it's called as a peripheral light bulb appearance. Peripheral light bulb appearance is seen in hemangioma of the liver. Peripheral light bulb appearance, it is hemangioma of the liver. It is the hemangioma of the liver. It is the hemangioma of the liver. Now you see here, this is a central star-shaped calcification. We call it central stellate calcification. Central stellate scar, star-shaped scar on a CT. Now this is seen in focal nodular hyperplasia of liver. This is also seen in fibrolamellar variant of HCC. It is also seen in serous cyst adenoma of pancreas and renal oncocytoma. And the renal oncocytoma. Now, these are two images that I would want you to identify. Let's say image A and image B. Which of the following is a gallbladder stone and which of the following is a gallbladder polyp? Now, you can see there is no post-echogenic shadow. There's a post-echogenic shadow here. Absence of post-echogenic shadow will make it as gallbladder polyp. There is absence of post-echogenic shadow. And this is your gallstone. There's presence of post-echogenic shadow. Presence of post-echogenic shadow. That is your gallstones. This is what we call it as. This is what we call it as the Phrygian cap deformity. In a Phrygian cap deformity, you will see the gallbladder that is present. The fundus of the gallbladder will have a notch like this. This is what we call it as the Phrygian cap deformity. It is called as the Phrygian cap deformity. Okay? This was a previous exam question. Clear? Chalo. So this is with respect to hepatobiliary images, continuing in the same pancreatic images that you have. This is your double bubble sign. Double bubble sign in pancreatic disorders is seen in annular pancreas. The seen in annular pancreas. On a CT, if there is a sausage shaped pancreas, you can see there is a sausage shaped pancreas. Sausage shaped pancreas. The sausage of pancreas is seen in autoimmune pancreatitis. Autoimmune pancreatitis. It is seen in autoimmune pancreatitis, which is associated with IgG4 class of antibodies. Which is associated with IgG4 class of antibodies. Now here another one on a you say the contrast imaging, that is your MRCP. It is a double duct sign. Double duct sign is seen in pancreatic head cancers. It is seen in pancreatic head cancer. On a ERCP, when you see here, this is your chain of lake appearance. Chain of lakes is seen in chronic pancreatitis. It is seen in chronic pancreatitis. So chronic pancreatitis. Okay. So now in the pancreas, the 4 surgeries that you have to determine. The surgery number 1 is what we call it as end-to-end pancreatojejunostomy. Now this end-to-end pancreatojejunostomy is what we call it as Duval surgery. This is what we call it as the Duval surgery. The second one that you have is longitudinal. It is your longitudinal pancreatojejunostomy. A longitudinal pancreatojejunostomy is also called as Pustow surgery. The third one is your duodenal preserving. Duodenal preserving pancreatic head resection. Pancreatic head resection with pancreatojejunostomy. With pancreatojejunostomy. This is what we call it as beggar surgery. This is what we call it as a beggar surgery. Then this is your duodenal preserving. Duodenal preserving pancreatic head coring. Duodenal preserving pancreatic head coring with longitudinal pancreatojejunostomy. With longitudinal pancreatojejunostomy, and this is what we call it as the Frey surgery. This is what we call it as the Frey's surgery. So there are the four surgeries that you use for chronic pancreatitis. All these are the surgeries of chronic pancreatitis. So if I have to just highlight this, these are the surgery for chronic pancreatitis. Surgery for chronic pancreatitis. For malignancy, we all know we do Whipple's surgery. That is nothing but your pancreatoduodenectomy. Now, in the urology, the spotters that you have, the first spotter is what we call it as the flower vase appearance. The flower vase appearance is seen in horseshoe kidney. It is seen in horseshoe kidney. The most common site for isthmus. It is between second to third lumbar vertebra. Ascent is prevented by inferior mesenteric artery. Now we call it as flower vase. As you can see, this is the pelvic ulcer system. This is the renal pelvis. From here, you see the ureters are flowing across here and they open into the bladder. Now, how do you equate this to normal one? See, when you look at this line, this is the sacroiliac joint. Normally, the ureters, the kidneys are slightly more away. So normally this is the location of the kidney, which is going to be under the 10th rib. And you see the ureter that comes out goes lateral to the sacroiliac joint, not medial to sacroiliac. This is normal. So more medially present and they appear as flower vase appearance. This is what we call it as horseshoe kidneys presentation. Now the image number 2 that you see, it is your spider leg appearance. Spider leg appearance is thinning of the calyx, which is seen in polycystic kidney disease. It is seen in polycystic kidney disease. So PKD you have seen in multiple conditions, so we're not going to go into great details. This is where you can see this is like an adder head appearance. It's like on the back of the cobra's head. This is how it looks like. There's an adder head appearance. Adder head appearance is seen in uretrocele. Adder head appearance is seen in uretrocele. It is seen in uretrocele. Adder head appearance is seen in uretrocele. Now you see this is a fish hook ureter. The fish hook ureter is seen in retrocaval ureter. Retrocaval ureter is going to present to you with hydroureteronephrosis. This is going to present to you with hydroureteronephrosis. This will present to you with hydroureteronephrosis. Now this is your staghorn calculi. This staghorn calculi, because it is exactly looking like a stag's horn, you can see here. This is your staghorn calculi. The staghorn calculi is also called as the triple stone, also called as a struvite stone, also called as the silent stone. Cause is a proteus bacterial infection. It is a proteus infection. It is a proteus infection. Now, urine microscopy, if you have this image, that is your envelope shaped crystal. If you have an envelope shaped crystal, this is a calcium oxalate stones. You have the calcium oxalate stones. If there's a dumbbell shaped crystal, it is calcium oxalate monohydrate. Calcium oxalate monohydrate. It is a calcium oxalate monohydrate. This is your coffin lid. Coffin lid, it is seen in phosphate stones. This is your hexagon. Or also called as benzene shaped. This is seen in cystine stones. This is your cystine stones. Now, what is this image and what is this image? This is your RGU and this is your MCU. RGU is your retrograde urethrogram. This is your retrograde urethrogram. Remember, in RGU, bladder is not filled. Whereas in MCU, that is maturating cystourethrogram, maturating cystourethrogram. Here the bladder is filled. Bladder is filled. You can see there is this dorsal bending of penis. Dorsal bending of penis is seen in a condition called as Penrose disease. It is seen in Penrose disease. Quick feedback. Quick feedback. Any doubts? No, take it. Chalo. Penrose disease. The surgery that we do for Penrose disease is what we call as the Nisbet surgery. Now, where the urethral orifice is getting closed, this is your phimosis. Now, you can see this whitish discoloration that you see around this. This is what we call it as balanitis xerotica obliterans, called as BXO. That is balanitis xerotica obliterans. BXO is your balanitis xerotica obliterans. This is image number 14, that is your paraphimosis. So the thick rim that is present. In paraphimosis, reduce the paraphimosis first and then after 4 to 6 weeks, perform circumcision. Now this is your urinary diversion. Now here you are using an ileal conduit. So the most common conduit that you use is going to be ileum. For urinary diversion, the most common conduit used is going to be urinary diversion, is going to be terminal ileum or ileum basically. ठीक है? बेटा whatever is not repeatedly asked, I'm just trying to run away with it. और जहाँ पे ज़्यादा important था, where we have given enough amount of time. ठीक है? क्योंकि आपके पास बेटा वो हाँ dorsal slit is given when you are talking about the phimosis ना circumcision नहीं करने से dorsal slit करके छोड़ने के लिए. चलो. Now, what is the most common site for benign prostatic hyperplasia? See, BPH is important, so we'll have more details about it. जहाँ पे जिस topic में emphasize करना है, वहाँ पे कर रहे हैं. Don't worry about it. Most common site for BPH is going to be either we call it as the median lobe or the transitional zone. For prostate cancer, it is your posterior lobe or peripheral zone or the peripheral zone. The symptom of BPH is due to, it is not because of enlarged prostate, it is because of detrusor instability or instability. It is your detrusor instability. It is your detrusor instability. Drug of choice for BPH is alpha 1A blocker, that is your tamsulosin. Surgery of choice for BPH is going to be TURP. The irrigating fluid of choice for TURP, if you are using monopolar, TURP, for a monopolar, we are using 1.5% glycine. If it is bipolar TURP, then it is normal saline. Open approaches, we have Frey's surgery, which is transversical. We have Millen's surgery, which is retropubic. And then you have Young's approach, which is perineal. These are the approaches that you have for open prostatectomy. The normal PSA is going to be less than 4 nanograms per deciliter. What is the PSA value for prostate cancer? It should be more than 20 nanograms per deciliter. What are the reasons for elevated PSA? Elevated PSA, remember it is remembered as ABCD. A is your acute bacterial prostatitis. Acute bacterial prostatitis. B is your BPH and biopsy. C is your catheterization. And D if the patient has underwent a digital rectal examination. Most common site for metastatic prostate cancer is your lumbar vertebra. It is the lumbar vertebra. The assessment is done with the help of Gleason's grade. Now, based upon the Gleason's grade, we have the score and the group. If the Gleason score is 6, that is 3 plus 3, it is grade 1. If it is 7 with favorable, that is 3 plus 4, it is grade 2. Gleason score of 7, which is unfavorable, that is 4 plus 3, Gleason grade 3. Gleason's 8, this was your INI question recently asked, this is called as grade 4. And Gleason score 9 is called as, 9 or 10 is grade 5, right? So maximum score in the primary is 1 to 5 and secondary is also 1 to 5. What is TURP syndrome? If you are using distilled water as irrigating fluid causes dilutional hyponatremia. causes dilutional hyponatremia. And this dilutional hyponatremia is what we call it as the TERP syndrome. This dilutional hyponatremia is what we call it as TERP syndrome. See? Nowadays, we don't use distilled water, so we don't usually see TERP syndrome. The most common, we're almost heading into the last leg. Any questions, guys? कोई सवाल? Quick feedback. Can you move on? Take a chalo. Right. The most common testicular tumor in children. In children, when we talk about it is the yolk sac tumor. It is the yolk sac tumor. In adults, it is seminoma. Overall, most common is also going to be seminoma. In adult, that is elderly patients, if they ask you. In elderly patients, it is going to be lymphoma. Now, AFP is a tumor marker and AFP is elevated in number 1, teratoma. AFP is elevated in teratoma, yolk sac tumor, teratoma, yolk sac tumor and embryonal cell tumor. And the embryonal cell tumor. Beta H is elevated in choriocarcinoma. It is elevated in choriocarcinoma. Lactate dehydrogenase is elevated in almost all testicular tumors. Placental alkaline phosphatase is elevated in seminoma. Chalo. Chivasak maneuver is done. It is called as high inguinal clamp biopsy. High inguinal clamp biopsy. This is done for indeterminate testicular mass. For an indeterminate testicular mass. For an indeterminate testicular mass, we do Chivasak maneuver. Now, when we talk about seminomas versus non-seminomas in terms of treatment protocol, seminomas are radiosensitive. Non-seminomas are radio-resistant. So, surgery that we do for both of them is going to be high inguinal orchidectomy. So, in both these conditions, we will perform high inguinal orchidectomy. We do high inguinal orchidectomy in both of them. Radiotherapy is given here, that is in seminomas, whereas non-seminomas are radio-resistant. Retroperitoneal lymph node dissections will be done in non-seminomas. Chemotherapy, if it is an advanced seminoma, we'll give it. And if it is an advanced non-seminoma, then we are going to give it. The chemo regime is going to be, the regime that we follow is beep mnemonic. B is your bleomycin. E happens to be etoposide. P is your platinum compound, that is cisplatin. Another spotter that they can ask you is this X-ray. This is what we call it as cannonball secondaries. The cannonball secondaries to lungs is given by, it is formed by choriocarcinoma. They have the hematogenous route of spread and they present to us choriocarcinoma. They have choriocarcinoma. Now, this is with respect to testicular tumors. Now, we have the surgical positions. Quickly looking at it, if the patient is lying down supine, it is a supine position. Head down is prone position. If you turn laterally, that is lateral decubitus position. Now, we use it for thoracotomy and renal surgeries, right? Lithotomy position, where the legs are up, all your perineal gynecological procedure. Remember, the most common nerve injured here is common peroneal nerve. Now, if you put the patient in prone and then you flip it, that is called, and you bend it, that is called a jackknife position. We don't use jackknife because it increases the risk for asphyxia. Now the modification of lithotomy is Lloyd Davis, where we flex the limb. There's a flexion of 15 degrees. It's not 150, and down tilt of 30 degrees. Normally, we do it for all your endourosurgery, that is TURBT and TURP procedures. If the head is pointing downward, it is Trendelenburg surgery. If the head is pointing upwards, it is called as reverse Trendelenburg position. So it is called the head down position and the head up position. Head down versus head up position. If the patient is sitting and getting it operated, this is your Fowler position for all your cranial surgeries. We usually perform this so that the ICT becomes less. Rose position we've already seen for thyroid. For your digital rectal examination, semi-flexed position of the hip called as Sims position. It is a midway between prone and lateral position, and it is done for rectal examination. Instruments, identify. The first one is blade. Remember, 11 number is for stab and IND procedures. 15 is precise. 22 is thoracotomy, laparotomy. Size 12 is for suture removal. Size 12 blade is for suture removal. Now, if you see, this is small jaw, ratchet is present. This is your Mayo-Hagar needle holder. If you want to suture smaller structures, if you want to hold a smaller needle, we have the Castrovigi needle holder. If you have a smaller tip with the tooth, this is your Adson's tissue forceps. Same thing, if it is longer, it is called as Gillies forceps. If there is no tooth, it is called as Brown Adson's. If there is no tooth with long, it is called as DeBakey's. This is your curved Adson's artery forceps. How do you know it's a sinus forceps? Remember, in sinus forceps, there is no ratchet. In a sinus forceps, there is no ratchet. This is where you have interlocking mechanism with the finger, like this is what your Alice forceps looks like. This is your Alice forceps. This is your Babcock's. You can see the curved tip is there. If there is a triangulated end, this is your dual lung holding forceps. If an oval end is there, this is a sponge holding, but there is presence of ratchet. Oval, but there is no ratchet. That means it is your ovum forceps. This is a curved one, is your Devar's retractor. If it is a right angle, it is your Langenbach's retractor. If it is curved, it is your Morris. If it is bent, it is Doyne's. If one end there is Langenbach, other one there is fangs are present, this is a Zerny's retractor. This is a Joll self-retaining thyroid retractor we've already seen. This is your mastoid self-retaining retractors. This is for abdomen, that is your Gallagher self-retaining retractor, and the Mayo's curved scissors. So these are the important instruments that they will ask you in the exam, right? So this is all in all with respect to the today's marathon, right? I try to cover almost every question and topic that has been there in the last 5 years of our FMG exam. So the whole PDF has been accommodated in order to revise all those topics in a quick succession. See, I have finished the entire marathon in 5 hours. You should be able to revise this in another 5 hours. So today, let's say you finish at 5 o'clock. Okay? Take a break until 5:36, attend your radiology session, and then from 8 o'clock onwards, you sit. By night 12, you should be able to finish this, and that is the only thing you have to read in surgery. Uske beyond nahi padna hai. Okay? I'll be sharing the PDF in my Telegram group. So it is available on the PW Medit Telegram. It will be there on my Telegram also, that is called as the surgery guy. It is by my name, that is Dr. Sandeep Seram Reddy. Okay. I'll upload in our WhatsApp group also. The Medits WhatsApp group is there. I'll try to put that also. Give me a second. Okay, on the WhatsApp, I don't know. I don't have the option to add. Okay, I'll send it on the Telegram group, beta. Provide the link to download. Yeah, we'll do that. I'll ask the team to put it immediately. It is there on the WhatsApp group. I don't know. Mm, 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 mm. Probably it is for the paid students, I guess. That is why it's a closed group. Anyhow, I'll share the PDF as early as possible. Okay? Thank you so much. All the very best for the exam. Stay calm, stay cool. Just revise और इसके beyond कुछ नहीं करना है. ठीक है? Don't read anything new. Just revise what you have read and keep consistent. Right? So we'll see you after the exam. Wishing you all the very, very best. And thank you from my side. Bye, guys.
Okay. Hello, everyone. Welcome to the marathon for radiology for the FMGE exam. Just a few days left, and we will have a quick revision. We'll start with systemic radiology. First, we'll start by brushing up your investigations, identify the investigations. Then we'll jump on the systemic radiology. We'll try to cover almost all the important images, and also that I have included almost all your previous year questions. So this would be a very useful session for you all guys. And if you have any queries, do put it down in the comments. Usually there is a lag of say a few seconds to few minutes when I am explaining and when you are commenting. So what we can do is that I will be answering all your questions, maybe say after 10 minutes or maybe after 5 minutes, but I'll answer all of them. I'll at least try my best to answer all of them, right? Okay. So can we just start? Is it audible? Everything is good, then we can start. Okay, so let's start with one of the most easiest questions, and also because it is tested. Which of the following structures has the lowest Hounsfield unit value on a CT scan? Can someone answer this question? It's a very easy question, a warm question for all of you guys. I'll wait for a couple of seconds. Okay, so I think I'll start. There are people who are yet to join. So the answer over here is air. So what is the concept of the Hounsfield unit? We'll start with Hounsfield unit. So Hounsfield unit is nothing but the attenuation coefficient on a CT scan, right? So the basic principle is that as your X-ray, so CT is mainly based upon X-rays, multiple X-rays, they pass through your body, and the structure that will be having the highest attenuation, the structure that will be having more atomic number, it has the tendency to attenuate all these X-rays. Now, because the attenuation will be depending also on your photoelectric effect, right? So that is the basics in the X-ray physics. We have learned that in detail. More will be the X-ray attenuation. Yes, good evening, Nikki. I can see that. Yes. So yes, so more will be the attenuation, that structure will appear more white. More white means the HU will be more, right? So let's see and just revise about the important soft tissue structures. So first of all, if I talk about the question that is being asked is water, the water is neutral. It has got an HU of 0, followed by soft tissues like almost all your organs. They will be having somewhere an HU between 40 to 50, right? What about the cortical bone, the metal? They will be having the highest attenuation value. So on this particular spectrum, it will be having around 1000 HU. Whereas if I talk about the calcium and if I talk about the cancellous bone, right, the central part of the bone, especially the vertebra, they have a relatively lesser HU, and that will be in the range of 400. Right? What about air? So air, that will be the most black structure, because all the X-rays are going to pass. It is not going to attenuate any X-rays. So the HU will be minus 1000, right? Now, if I talk about the acute bleed, again, this was a question asked, the HU will be around 80. So how is the bleed going to appear on a CT scan? It is going to appear very white. What about metal? Metal will be having an HU that will be around 3000. Okay, it's more than that of 1000. It's so high HU that sometimes the machine is not able to register it, and you will get a streak artifact. You will get a streak artifact. How will the streak artifact look? If there is a metal piece, say for an example, if I talk about any surgical clips are present, right? They are producing the streak artifact, and it will look like that of a sun ray. So if you see a CT scan, it will appear very hyper. It's like ranging from 1000 to 3000 HU, and it is going to emanate this black sun rays type of an artifact, which is called as a streak artifact, right? Now let's start discussing about the pathology. So what are you seeing in this particular image? So there is a lesion that is present centrally. It is along the corpus callosum, right? I give you the hint that the HU is minus 80. It's minus 80. So it is not air. The HU is minus 80. Now minus 80 is what? It is your fat, right? So fat is in the negative HU. It is going to appear black. It is going to appear not as black as air, but it will appear little dirty black in appearance. And it has an HU ranging from minus 80 to minus 100, right? So this particular lesion, centrally placed in the corpus callosum, a fat containing lesion. What is this particular lesion? This is nothing but your corpus callosum lipoma. This is your corpus callosum lipoma. What are you seeing over here? You are able to see a very characteristic calcification pattern, which is called as your bracket calcification, right? This is called as the bracket calcifications of the corpus callosum lipoma. Again, just need to know that it is a fat containing lesion. Now, what are the other fat containing lesions that will appear as black as for the fat? So, the other fat containing lesions are your dermoid cyst, your teratoma. Like for an example, in the mediastinum, they can show you an anterior mediastinal mass, and that will be having a fat containing lesion, plus they may also have some calcifications. Yes, Nikki, it's bracket sign. What about other lesions? So if you talk about the subcutaneous lesions like lipoma, a lipid-rich adrenal adenoma, angiomyolipomas in the kidney, right? They are all your fat-containing lesions. They will be having an HU. Any of these particular lesions can be shown to you, and they will be asking you the HU. The HU is somewhere between -80 to -100. These are your fat-containing lesions, right? Now let's talk about this particular image. Now what is this image? Again, the same thing. Now this is actually an MRI image, right? You can identify the MRI image. How? See, you can see that the subcutaneous fat over here, it is appearing very bright. So fat is bright, right? What about this particular lesion? This is a T1 weighted image. How did I identify that this is a T1 weighted image? Look at the CSF, right? CSF is black in this particular image. So this is a T1 weighted image. Now you are seeing a lesion, right? Exactly in the center along the corpus callosum. Again, this is nothing but your corpus callosum lipoma. This is your corpus callosum lipoma. There is one more structure that is seeing bright on this T1 weighted image. Can you see that? Can you see that structure? It is your posterior pituitary bright spot. So the posterior pituitary bright spot, that is also going to appear characteristically very bright on your T1 weighted image, right? So this is about your fat containing lesions on a T1 weighted MRI image. Now, why does the fat is going to appear bright on a T1 weighted image? This is mainly because any particular substance that is going to shorten the T1 time, that is going to shorten the T1 time, that is going to appear bright. So what are the other lesions that are going to appear bright on a T1 weighted image? It is your fat that we have already covered. This is your corpus callosum lipoma. Look at the subcutaneous fat. Everything is bright over here. What about the posterior pituitary bright spot? That again I have covered. Then melanin will also appear bright. Gadolinium will appear bright. So that is why whenever we do a post-contrast MRI image, we always take a T1 weighted image, right? And then we are going to take a post-contrast T1 weighted image on which the gadolinium is going to appear bright. So the vessels are going to appear bright, and that is the basic concept of your T1 contrast post-gadolinium images. What about minerals? So even calcium, right? Your basal ganglia calcifications, choroid calcifications, they will also appear bright on T1 weighted image. And what about the blood? Again, blood will be appearing bright on a T1 weighted image. Okay, so what about these particular sequences? Can you tell me about these sequences? What is image number 1, image number 2, image number 3? Basic brushing up. These are all very easy questions. I know everyone knows this, but a quick brush up before we start the systemic radiology. So if you see the first image, see, first of all, identify the MRI. CT may, what is going to appear? Your bones are going to appear very white. The cortex will appear very bright, right? Here you can see that the bone in every image of the MRI, it is going to appear black. Right? What about the subcutaneous fat? So subcutaneous fat, as I already said, it is going to appear relatively bright on a T1 weighted image and iso to bright intense on the T2 weighted images. But the main thing that is going to differentiate is your CSF, right? So CSF, water is bright on a T2 weighted image. World War II, water is going to be bright on a T2 weighted image. So this is definitely your T2. Here the CSF is dark. So this is your T1 weighted image. What else do you know? T1 weighted image, white matter is white, right? So the T1 is going to follow all the rules. Your white matter is white on a T1 weighted image, whereas your white matter will be dark on the T2 weighted image, right? So you can see that the white matter over here is very bright on a T1 weighted image. On T2, you can see that your white matter is going to be dark, right? So that is the basic difference. What about the third image? You can see over here that it is almost looking like that of a T2 weighted image in terms of your white matter and gray matter. White matter is black over here, but even the CSF signal is suppressed. We have used an inversion recovery sequence in order to suppress the signal from your CSF. So the third image is nothing but your flare image. So this is your flare image, right? Now flare image is actually your investigation of choice, or I would say the sequence of choice. If I want to see any demyelination, if I want to see any small vessel ischemic diseases, any white matter pathology is going to appear very bright on a flare image. So I would say that this is the sequence of choice for multiple sclerosis also, right? Because I want to see this demyelination plaques and they are going to appear hyper on the flare images. Because I am suppressing the CSF, all the other pathologies will look relatively more bright on a flare image, right? Okay, now let's talk about this particular sequence. What is this sequence? So this is nothing but your post contrast T1 weighted image, right? This is a post contrast T1. The first image I'm talking about, you can see that there is a lesion that is arising in the parasagittal region, right? This is nothing but an extraaxial mass. What is this mass? You are also able to see that there is a dural tail over here, right? So this is nothing but your meningioma. The main point that I have included over here is that this is your characteristic post contrast T1 weighted image. You can see that there is no signal that is present in the CSF. White matter is white, gray matter is gray on a post contrast T1 weighted images. If I want to see any infection, if I want to see any inflammation, okay, in that particular cases, I want to see my ring enhancing lesions, I want to see the brain tumors, my investigation of choice will be, or my sequence of choice will be post contrast T1 weighted image, right? Okay, now let's move towards this particular image. So what is this particular image? So this is your diffusion weighted imaging, right? Now diffusion weighted imaging, again, this is commonly tested. What is the main concept? Because of the restriction of the Brownian motion, the free motion of the molecules, okay, of the normal molecules, if it is restricted by any particular pathology, it is going to appear bright on DWI images. But the main point is that if any particular lesion, yes, Eric, the PDF will be definitely available. We will definitely upload the PDF, right? Because we have multiple images. We have more than 100 images in this PDF. So definitely I will make sure that the PDF is available to you all guys, right? Okay. So if you see over here, the main thing about the diffusion weighted imaging is that it should appear black on the ADC images. Only then it is true diffusion restriction. If it is bright on ADC, if it is going to be bright on the ADC images, then that is not true diffusion restriction, but that will be T2 shine through, right? So you have to make sure that it is also dark on ADC. How will you identify the ADC? You can see on DWI your CSF is black, right? And if you see the ADC, your CSF over here will be white. So that is how, as a student, you can identify your DWI and the ADC sequences, right? Now, this is actually a case of stroke. You are able to see that there is diffusion restriction in the right frontoparietal lobe, in the right MCA territory, with corresponding T2 flare hyperintensity, right? The flare hyperintensity has appeared over here. So that is why I would say that this is actually an acute stroke and not a hyperacute stroke. If there is a hyperacute stroke, if the stroke is less than that of 6 hours, then the only change will be seen on the DWI images. Even the flare will be the signal changes in the flare will appear after more than that of 6 hours, right? So that in the early phases, it is also called as a DWI flare mismatch, right? That is actually a wake up stroke, or I would say a hyperacute stroke of less than that of 6 hours. Another important thing is that cytotoxic edema and vasogenic edema. So if I talk about the cytotoxic edema, which of these two edemas will be showing the diffusion restriction? It is your cytotoxic edema that will be showing diffusion restriction, whereas vasogenic edema is not going to show diffusion restriction. What is vasogenic edema? It is because of the blood-brain barrier. If it is going to be disturbed in any pathology, like for an example, if there is an infection, if there is a tumor, and if there is, because of this lesion, when the blood-brain barrier is going to be affected, then that will lead to vasogenic edema, and that will never show diffusion restriction. It is only a cytotoxic edema, especially in the stroke. What is going to happen? Because there is a damage that is occurring to your sodium-potassium pumps, that will lead to cytotoxic edema, and that is going to show your diffusion restriction. What other pathologies will show diffusion restriction? And it could be tested. So as I said, the mnemonic is seal. Okay, stroke, especially the acute stroke, is going to show the true diffusion restriction. Then your epidermoid cyst, then of course your abscess, brain abscess, because of the pus material that is present, right? Now, because of the, so main thing is that if anything is very cellular, if anything has got lot of pus, if like epidermoid cyst will be having lots and lots of keratin debris, right? So in that particular case, what is going to happen? They are not going to have this true Brownian motion, and they will show the diffusion restriction. What about else? So it is mainly a lymphoma or anything that is very cellular, like for an example, a medulloblastoma, right? So these are the lesions that are going to show diffusion restriction, right? Okay. Now, if I talk about the next question, a 24-year-old male is brought after a high-speed road traffic accident. CT brain is normal. MRI shows multiple tiny blooming foci at the gray-white matter junction and corpus callosum. Which MRI sequence is most sensitive for detecting this particular lesions? So there is an RTA history. CT scan, I say, is absolutely normal over here. So what is the answer? Again, a previous year question. Which MRI sequence will be more sensitive over here? So it is definitely your SWI sequence, right? It is a susceptibility weighted images, the ability to detect the blood, okay, to detect micro hemorrhages, especially what is going to happen over here. There is an axonal injury because of the shearing forces and because of the tearing forces along the axon, especially at some characteristic locations like at the gray white matter junction, right, at the gray white matter junction, at the corpus callosum, at the brainstem, that is going to lead to diffusion axonal injury, okay, diffuse axonal injury. So anything that is going to disturb your local magnetic field like blood products, calcium, iron, metal or air, they will always show blooming, okay. So the characteristic point is that they are going to show the blooming on these SWI images, and that is why they will be appearing as black, right? So this is about your SWI. See, if the answers, if the options will be also including your GRE, okay, or your T2 star, everything is going to follow the same principle of susceptibility. But if all the options are given, suppose SWI, GRE, T2 star is also given in your options, then mark your answer as SWI, because I would say that SWI will be having the highest sensitivity to pick this microbleeds. Okay, they have got the highest sensitivity to pick the microbleeds among all these particular sequences, right? Now let's move towards our next image. Which structure is damaged in the dashboard injury? So you're given first image. If you see the first image, which structure is damaged in dashboard injury? Anyone would like to answer this question? Okay, so the answer over here is PCL. So in dashboard injury, what is going to happen? Again, because of a very high road traffic accident, what is going to happen? The dashboard, the person especially who is sitting next to the driver, what is going to happen? That because he will be flexing his knee and it will be impacted on the dashboard, and because of this, there is a posterior translation of the tibia. So because of this, the structure that is going to be damaged in dashboard injury is PCL. First of all, what is this particular investigation? This is your MRI image, right? You can see the cortex over here. The cortex is going to appear black. If you see the second image, you can see that the cortex is going to appear white. So this is your CT image. If I want to see any bone fractures, if I want to see the cortex, in that particular case, I will definitely go with CT. But if I want to see the soft tissues, if I want to see the ligaments, if I want to see the menisci, in that particular case, I am definitely going to go with the MRI. Okay, let's quickly revise the basic anatomy structure. So you can see that this particular structure inserting anteriorly on the tibia, that is your anterior cruciate ligament. The structure that is going to insert posteriorly on the tibia will be a posterior cruciate ligament, right? What about this particular structure? This is your patellar tendon. And what about this particular structure? This is your quadriceps tendon. This is your patella. This is your sagittal MRI image, right? So this is about this particular identification of your MRI as well as the CT on a MSK structure, okay? Now, especially if I talk about the MRI pathologies, if I want to see the various ligaments, in that particular condition, I prefer a PD sequence, okay, or proton density sequences, because that will actually enhance the, you will actually able to see the edema on the PD weighted images, right? So that is about this particular slide. Now moving towards our next, what is this sign? What is this particular sign you are seeing over here? So here again, I am telling you that the patient is having a road traffic accident. This is nothing but your double posterior cruciate ligament sign, right? This is the double PCL sign. So this is characteristically seen if there is a bucket handle tear. Okay, you are able to see that there are two PCL, right? There is only one PCL. I have shown you the normal anatomy. If you're seeing a structure that is anterior to this particular PCL, what is this? This is nothing but your bucket handle tear, and especially the most common structure, that most common meniscus that is going to be affected is your posterior horn of the medial meniscus. Okay, posterior horn of the medial meniscus, because it is going to be torn, what is going to happen? Because it is going to flip like this. If you see on the axial section, it is going to flip like this. It is going to be torn from the middle. It's a longitudinal tear, and because of this, when it flips, it is going to lie anterior to your posterior cruciate ligament, and that is going to give the characteristic double PCL sign. Right, now moving towards our next investigation. What is this? The grayscale image you are able to see on the right side, that is nothing but your normal grayscale B mode ultrasound. What are you seeing over here? You are able to see the liver, you are able to see the right kidney. Okay, my probe is somewhere in the right upper quadrant over here. So this is a basic B mode ultrasound, right? Now, if you see the second image over here, you are seeing an orangish type of an image. Okay, so this is nothing but your contrast enhanced ultrasound. What contrast agent I am going to use? I am going to use SonoView. I am going to use SonoView. There are many other agents available, but the most common one which we are using in India is SonoView, and this could be tested. It is made up of sulfur hexafluoride gas, and it is surrounded by the phospholipid or by the albumin layer. The main thing is that because these gas particles, they are going to be exhaled in the lungs, whereas the phospholipid layer is going to be excreted in the liver. So there is no role of the kidney in the metabolism. So this is absolutely safe even in the renal failure patients. It is safe in renal failure patients. What other contrast agents you can never use in renal failure? You can never use your iodinated contrast agents. You can never use your gadolinium, right? So this is particularly safe in renal failure, and that is the advantage of contrast enhanced ultrasound. How are you going to give this agent? This is mainly given IV, right? Now let's talk about the beam mode ultrasound. So you need to know about the various transducers also. So if I talk about a low frequency transducer, the most commonly which we are using in the abdominal imaging, the pelvis imaging, the obstetric imaging, we are using a low frequency probe. Now the low frequency somewhere around 2 to 5 megahertz. What will happen if I use a low frequency? It is definitely allowing me to have an imaging at a more depth. Obviously the resolution will not be that great, but you can see the structures that are lying at a depth. If I talk about a high frequency structure, more will be the frequency. What is going to happen? More will be the resolution, though more will be the attenuation also. So you are able to see only the superficial structures. Now what are the superficial structures you are going to see? You are going to see the breast, thyroid, MSK, scrotum. So anything in the question pertaining to these particular structures is asked, always mark your answer as a high frequency probe, which is around 10 to 18 megahertz. Right now, if I talk about how does these probes appear, the low frequency one will be curvilinear, If I talk about a high frequency probe, then it is going to be a linear probe. If I talk about the footprint, right, the high frequency have a linear footprint or a rectangular footprint, whereas the low frequency ones, they will be having a curvilinear footprint. Now, what about this particular investigation? So again, you are able to see over here all the layers of the bowel. So we have actually used an ultrasound probe that is mounted on an endoscope, right? So what are we talking about? We're talking about an endoscopic ultrasound, right? So this, again, this image can be shown to you to identify what investigation we are using. Now, because we are bypassing the normal abdominal structures, the superficial structures, we are bypassing the gas with very close proximity. If your endoscope is in the stomach or either it is in the duodenum, what you are able to see? You are able to see the entire bowel walls. You can see the pancreas through the duodenum. You can see the pancreatic head. You can see the pancreatic lesions in the body as well, especially if the probe is in the gastric pylorus region. So because of this, what happens is that we will be using again a high frequency probe, and you will be able to see the structures that are nearby, not at a very much depth. So high frequency will be there, but a very high resolution image can be also obtained. This is mainly used for the local staging, or I would say the T staging, the pancreatic neuroendocrine tumors, as well as the cyst for their characterization, especially if the lesions are less than that of 2 centimeters. You can very well visualize them. Sometimes they are not even seen on CT and MRI imaging, and you can pick up on the endoscopic ultrasound. Okay, if I want to aspirate the fluid, like for an example, if I want to know contents of the fluid, like for an example, the serum amylase levels, the serum lipase levels, right? Not the serum, but the fluids amylase and lipase and the mucin levels, that could be also tested. And if I talk about the intervention, then of course FNACs and biopsies and fluid aspiration could be also done. Right now, if you see the second image over here, you are seeing multiple colors over here. Now, what is this? This is actually the thyroid imaging, and we are seeing this particular colors, particularly red, green, and blue. So this we are measuring the tissue stiffness and the tissue elasticity, right? So where it is used, it is mainly used for the, so we are talking about fibroscan. Okay, particularly it is used in liver, or in general, if I talk about it, is elastography. Okay, so they can definitely ask you this question to identify which particular sequence is there. It is mainly used to see the liver fibrosis and the cirrhosis, and also to differentiate between malignant versus the benign lesions. Now, if you use your common sense, the malignant lesions, they are definitely going to be more harder, right? The malignant lesions will be more harder. Whereas if I talk about the benign lesions, they will be definitely more softer. If I talk about the liver fibrosis and cirrhosis, over time, what is going to happen? The hardness will be definitely increasing, and that by making use of some shear waves, you can actually know the tissue elasticity of any particular structure. Now, what about this particular investigation? So this is nothing but your color Doppler. You are able to see that on a beam mode ultrasound, you are able to see this red and blue colors. So the basic funda is that on the color Doppler imaging, you can get an idea about the flow as well as the direction of the blood on the basis of the frequency of the moving RBCs. If the frequency, the RBC, they will be moving away from the probe, then it will be appearing blue, right? So this is blue. And if I talk about towards the probe, then that is going to appear red. So it is not that the veins are going to appear blue or the arteries are going to appear red. It is definitely depending upon the frequency of the RBC or the movement of the RBC, whether it is towards the probe or whether it is away from the probe. Right now, if I talk about this particular spectrum over here, what is this? You are able to see the waveform also of this particular vessel. So this is nothing but your spectral Doppler. This is your spectral Doppler. So you are basically getting an idea about the velocity against the time. You are able to generate this waveform. Okay, so this is nothing but your spectral Doppler. Now, what is this type of waveform? This is nothing but your triphasic type of a waveform pattern. So where will you see this triphasic pattern? This is particularly seen in your peripheral arteries. Okay, peripheral arteries may you will be able to see. Okay, whereas a continuous type of flow will be always seen in your visceral arteries. Like for an example, if I talk about the various organs like the kidneys, right, they will not have this triphasic pattern. They will have this continuous type of flow. They will need a continuous diastole flow. Here what is happening? We are getting the first peak in the systole. We are getting the first peak in systole, and then we are getting a reversal over here, right? That is in early diastole. Again, that is mainly because of the stiffness, the resistance that is offered by the vessels, right? And if you can see again, then there is a forward diastolic flow depending upon the elastic recoil of these vessels. So that will give rise to this triphasic form. If there is a peripheral arterial disease, what will happen? The triphasicity, this triphasic pattern will be completely lost, and what you will get? You will rather get a monophasic form, or you can also get a biphasic form in the early disease. Now, what about this particular investigation? This is your power Doppler. This is your power Doppler. So how I have identified, first of all, you can see that there is no red and blue color over here. There is a jet red type of a color that you are seeing. This is actually the kidney, right? So the main problem with the power Doppler is that it will not give you an idea about the direction. It will tell you that the flow is there or not, but it will not give you an idea about the direction. But what is the advantage? The main advantage of the power Doppler is that it is very sensitive. So even if on the normal color Doppler, you are not able to pick up some flows, with the help of power Doppler, because it's very sensitive, even some small flows, okay, some trickled flows, they could be detected, right? So that is the beauty of power Doppler. And you can identify this. If it is jet red type of a color, that is a power Doppler. Now, what about this particular investigation? What are you seeing over here? So this is your MRCP image, right? Now, what is MRCP? Magnetic resonance cholangiopancreatography. Whether we are giving any gadolinium over there? No. So absolutely, it is first of all a non-invasive investigation. I am not using any contrast. This is definitely based on the intrinsic high T2 signal properties of the various biliary structures. So anything that will be having intrinsic high T2 value, like for an example, your gallbladder, your biliary structures, any cystic lesions that are present, they will appear very bright on an MRCP image, and you can generate this very nice image. Now, for an example, if there is any stone that will be present, so how will it appear? It will appear like that of this signal voids on an MRCP image, right? Now, if you see the second image, here you can see that I have actually used an endoscope, and you are able to see that the contrast, we have injected a contrast, and that is appearing black on the image, right? So this is nothing but your ERCP image. So don't get confused between MRCP and ERCP. Now, if the question regarding any biliary pathologies in general, if it is asked, right? If I talk about the investigation of choice for any anatomical, like for an example, if I talk about the choledochal cyst, right, or if I talk about any pancreatic ductal abnormalities, in general, your investigation of choice is always MRCP, because it's the non-invasive type of an investigation. But if I talk about the gold standard method, then the gold standard is always ERCP. The gold standard is always ERCP. First of all, it has got a very high spatial resolution, and also that you can do an intervention in the same sitting, right? So that is why I would say that the gold standard is definitely ERCP. But except for one condition, if I say that for the biliary leaks, the investigation of choice will be your HIDA scan. Okay, that is more sensitive than your MRCP. So for the biliary leaks, for functional type of imaging, like for an example, if I want to assess biliary atresia, if I want to see biliary leaks, in that condition, I would say my investigation of choice would be HIDA scan. Right? Now, what about this particular investigation? So this is your mammogram. You are able to see two views on your image. So this is first image, which is there. It is your craniocaudal view. This is your mediolateral oblique view. So mammogram is a choice investigation for the screening, right? Especially if the patient's age is more than that of 30 years. Now, if the patient's age is less than that of 30 years, right? Because the patient will be having very dense breast. In that condition, I would say that the screening, okay, screening for the cancers, the investigation of choice will be definitely an ultrasound. Okay, what about high risk screening? High risk means if the patient is having BRCA mutations, if the patient is having, say, Cowden syndrome, or any family history of cancer is there, in high risk screening, my investigation will be definitely MRI. It will be investigation will be MRI. See, when I talk about screening, as per the American Cancer Society, what are the guidelines? You have to annually screen at 40 years of age, right? When the women will be turning 40 years, then annually you have to do a mammogram. What is high risk screening? So high risk screening will actually start at the age of 30 or 10 years before the family member has actually been diagnosed with the cancer. right? So that is high risk screening. For that, we will always use an MRI because MRI is the most sensitive investigation among all these investigations. Right now, if I talk about the implants, for implants, your investigation of choice will be definitely MRI, right? We have got multiple signs like Linguini sign, right? All these particular signs will cover when we'll talk about the breast imaging, but for implants, you will always do an MRI, right? Now, if I talk about this particular image, what is this? This is a breast MRI. How do we do the breast MRI? The patient is turned prone, the breast will be hanging down in the breast coils, and that is how an image is obtained. So this is a normal T1 weighted image. Again, how I have identified that this is a T1 weighted image. Look at the fat over here, right? This fat is very bright over here, and this entire complex over here is nothing but the fibroglandular tissue which is present in the breast. Right now, the most important thing, or I would say the heart of the breast imaging or the MRI imaging, is nothing but your dynamic contrast enhanced imaging. So what is going to happen in dynamic contrast? We are going to generate some kinetic graphs, we are going to generate some curves, right? So because when the contrast will be passing, when we give the IV gadolinium, we will be actually tracing the perfusion of the breast, and on this particular basis we can generate these graphs. So graphs can be either of the three. It can be persistent, it can be persistent, or it can be type 1 is persistent, type 2 is plateau, and then we have the third graph which is actually a washout. Okay, so which of the following is benign and which of the following is malignant? Again, very potential question could be tested. So type 1, okay, type 1 which is persistent type, that is actually benign. Type 2 or plateau which is there, it is somewhere I would say an intermediate category, whereas if I talk about the washout, then it is actually indicating that it could be a malignancy. It could be a malignancy. So we don't like type 3 curves. Type 3 that shows a washout, that will be potentially pointing towards a malignancy. Right now, let's move towards our next investigation. So I have shown you 3 investigations. Identify which of the following of these investigations. If you're not seeing it live, just pause and just look at that. Which of the following are the investigations? Just try to identify whether it is CT, whether it is MR, or whether it is a DSA. So the first image over here, you can see that the contrast is black. So contrast is black, that is your digital subtraction angiogram, right? That is your digital subtraction angiogram. Now remember that the gold standard for any vascular pathology is almost your DSA, right? If the question is asked regarding any vascular pathology, gold standard will be your DSA. Okay, it's a fluoroscopy technique, right? We are obtaining continuous X-ray exposure is given after you have injected the iodinated contrast. This technique has got the highest spatial resolution. What is the problem with DSA? It is invasive. We do not like invasive procedures again and again, right? So we have now got better alternatives also, which are non-invasive in nature. So if you can see the second image over here, what are you seeing over here? You are able to see that this is a renal angiogram, and this is actually an MR renal angiogram. So this is an MR angio. And the third image, you can see, if you are able to see the bones. Can you see the bones? The bones are appearing very white over here, right? So this is actually your CT angio. This is again a renal angio, as well as you can also see the aortogram over here. So this is actually a CT angio. This is how you can differentiate. If you are able to see this white bones, then that is your CT angio. Right now, what about the pathology over here? Because we can see that there is a pathology. You can see that there is a proximal renal artery stenosis over here, right? So proximal renal artery stenosis, you can see with renal atherosclerosis. If the patient is having this history of a young hypertension, especially with medical resistance, right? Resistance to more than that of 3 drugs, right? Always screen this patient. Screening for the first investigation, you will do a USG Doppler or a renal Doppler, right? Then it is followed by usually a CT angio. CT angio is usually taken over MR angio, but if I do not want to give contrast, right? If the patient is having renal failure also, if his creatinine level is high, in that particular condition, I will choose an MR angio, because what we can do with MR angio is that even without the contrast, there is something which is called as TOF imaging, which is also called as the time of flight imaging, that can be done. So if my patient is having renal failure, I will prefer an MR angio, right? If the patient is not having renal failure and both the options are given, then choose your answer as CT angio, because it still has got a better resolution as compared to the MR angio for the vessels, right? Now let's move towards the most important slide, I would say. Okay, so before we jump on the systemic, this is the most important slide, right? So if I talk about the various investigation of choices in general, for fluid, for cyst, ascites and effusion, anywhere the fluid is there, always your answer will be ultrasound, right? Your answer will be ultrasound. If I talk about air, pneumoperitoneum or emphysematous cholecystitis or emphysematous pyelonephritis, in that particular condition, my answer will be always NCCT. My answer will be NCCT whenever I want to see any ectopic hair present in the body. Now, if I talk about the calcifications, like for an example, renal calcifications, or if there are any calcified granulomas, like for an example, neurocysticercosis that is present in the brain, in that particular condition, again, my investigation of choice will be NCCT, right? Exception, there is one exception, that is your USG calculi. For USG cal, my investigation of choice will be definitely not you, sorry, for the gallstones. Okay, if I'm talking about the gallstones, my investigation of choice will be definitely ultrasound, right? That is the only exception where for the calculi we are using the ultrasound. Now, if I talk about the soft tissue tumors, or if there is any soft tissue pathology, anything that needs a high soft tissue contrast, in that particular condition, my investigation of choice will be MRI. Now, for the bone cortex, as I've already told you, if I want to see the fractures, right? If I want to see one bone tumor, which is called as osteoid osteoma, in that particular condition, my investigation will be CT. If I want to see the bone marrow, remember M for M, for bone marrow, it is always MRI. If I want to see edema as well as the avascular necrosis. If I talk about acute hemorrhage, like an acute SDH or an acute EDH or subarachnoid hemorrhage, my investigation will be always NCCT. If I talk about the chronic hemorrhages, micro hemorrhages, like for an example, diffuse axonal injury, already discussed, vasculitis, hypertensive encephalopathy, in that particular condition, my investigation will be definitely MRI. And what is the sequence? Either it is SWI, or either it is the GRE or your T2 star images, anything of that could be selected. Right now, if I talk about the vascular pathology, again, if any stenosis, any plaques, if I want to see, so first I will always go with the Doppler. First, I will always go with the Doppler. If I want to see as an investigation of choice, I will always mark my answer as CT angio. CT angio has got relatively better resolution, but if the gold standard is asked, then it is always and always DSA. Again, you can choose this as MR angio also, depending upon if they are asking you that the patient is having renal failure, you cannot give iodinated contrast, you can easily proceed with a time of flight MRI angiogram. But the gold standard will be always DSA, right? Okay. Now moving towards, okay, so what about the pregnancy? What is the most safest modality in the pregnancy? So always remember that the safest modality is ultrasound followed by MRI. Okay, a non-contrast MRI, that is the safest modality, right? You will not use X-rays, or you will not use CECT or CEMRI unless it is absolutely necessary. Of course, they can be used if there is a life-threatening condition, but we generally avoid them because of the radiation exposure. Maximum chance of damage is usually in the first trimester, in the 2 to 8 weeks whenever there is organogenesis. And what about the contrast? Again, because some traces of the contrast, they can reach up to the fetal circulation through the placenta, so we usually avoid them. But of course, when for an example, if there is a life-threatening hemorrhage, if there is a life-threatening bleed, in that particular conditions, we can do a cross-sectional imaging, right? Now let's move towards our respiratory radiology. So some basic X-rays, which we definitely cannot afford to get them wrong. These are like the bread and butter of radiology, so everyone knows them. So first image over here, you can see that this is the meniscus sign or the Ellis curve, and what you are seeing over here, that you are able to see a very nice curve rising laterally. So this is nothing but your pleural effusion, a homogeneous opacity. First sign that you will get will be, for first sign, what you are going to get. So Ajay is asking for atherosclerosis, any radio diagnosis. I'm not getting for atherosclerosis, I'm not able to understand the question. Can you put it in some other words? So for atherosclerosis, particularly if I talk about an initial investigation, yes, we can start, like for an example, if I talk about renal atherosclerosis, and the patient comes in, you're suspecting that there can be renal atherosclerosis, you can start with your color Doppler, and then you can follow it with a CT angio, right? So that is if you are trying to ask me that, okay? So the first, so you are able to see over here that there is a homogeneous opacity, right? The first thing which you are able to see on the pleural effusion on the X-ray will be that there is a blunting of the CP angle. Now for X-ray, for the chest X-ray, this is a normal chest X-ray PA view. You need at least approximately 200 to 300 ml of fluid, right? But I need a better investigation that can detect this particular fluid in a very less amount also. So the best investigation we have already discussed. For fluid, your best investigation will be definitely ultrasound, which can detect approximately 5 to 10 ml of the fluid also. But if they ask you what is the best X-ray, so remember that the best X-ray will be your lateral decubitus X-ray. It will be your lateral decubitus X-ray, right? Now lateral decubitus can detect it in the range of 10 to 50 ml as well, right? Now if you take the second image over here, what is this? You are able to see that there is an air fluid level, right? So this is actually an air fluid level which is present in the pleura. Can you see over here? There are no bronchovascular markings, so this is the pneumothorax, plus there is also fluid, so this is nothing but your hydropneumothorax, This is your hydropneumothorax. Now, if you see the third image over here, you are able to see that there is a lesion again showing an air fluid level, but this is in the lung parenchyma. So what is this particular pathology? Someone wants to answer, please answer. See, you can answer. Maybe I'm a little ahead, maybe I'm one few minutes ahead, but I will definitely appreciate if you could answer them. So the third image is nothing but it is your lung abscess. This is your lung abscess. Okay, they can give you a history of maybe diabetes mellitus or alcoholism, and usually this lung abscesses, they will give you this history of fever also, more commonly associated again in the superior segments or bilateral lower lungs, again because of the risk of aspiration, and then they can turn into this abscesses, right? So look at the clinical hints which they can give in the question. Okay. Now, moving towards our next image, what are you seeing over here? So, what are you seeing? Yes, Nikki, lung abscess, it's right. Yes. So, please try to answer. Please try to be more interactive, and then we'll definitely enjoy this session. We have lots and lots of images in today's class. Okay. So, what about this? A quick revision about the cell house sign. Okay, we will be little quick. If you want to understand any particular concept, just write it down in the comments, and I'll get back if you feel that the speed is too much. We have lots and lots of pages to be covered, so I will be going in little speed. But if you want any topic to be repeated, please put it down in the comments, right? So if I talk about the cell house sign, what is happening? So because if any particular structure, any particular pathology, that will be, if it comes in contact, okay, with any of these particular structures that are present on the chest x-ray, it is going to obscure. Any two structures with similar radiographic density will be obscuring the borders. That is the main funda regarding the cell house sign. So for an example, if there is any particular pathology that is present in the right upper lung lobe, it is going to obscure your right paratracheal stripe. One is your right paratracheal stripe, right? If I talk about the second, the left upper lung lobe, what is this particular pathology? It's the aortic knob. It's your aortic knob that will be cell-houted. Right middle lung lobe, that will be number 3. So this is actually obscuring your right heart border, will be obscuring your right heart border. If there is any pathology or consolidation that is present in the lingula, it is going to obscure your left heart border, right? If there is any pathology that is present in the right lower lung lobe, it is going to cell out the right dome of diaphragm, and if it is present in the left lower lung lobe, it is going to obscure your left dome of diaphragm. So this is very important. If you can see, just we can practically use this particular concept over here. So you can see that there is any pathology that is obscuring the right heart border. Where is it present? Where is it present? If any particular pathology obscuring the right heart border, this is present in the right middle lung lobe. Okay. If suppose your left heart border was not seen, then in that particular condition, I would say that the pathology is present in the lingula. Right. Now moving towards our next images of the respiratory pathology. Here I will give you a hint that the patient is having previous tuberculosis, right? Patient's immunity is okay, but the patient is having a previous tuberculosis. What I'm talking about? I'm talking about an aspergilloma. So you are able to see that there is a crescent of air over here. This is nothing but your monod sign. Okay, so this is a monod sign because there is already a pre-existing cavity, say tuberculosis or silicosis, and then there is colonization by Aspergillus fumigatus. It has given rise to this topic, particularly a fungal wall, and that is called as a monod sign, right? Now, if I move this particular patient, will this fungal ball move or not? It will move. So, I can confirm this, okay? Mask to nahi hai, I have to confirm this. Then I will be asking my patient to lie down prone. Especially on a CT scan, you can see that the ball will move, right? So, that is about the aspergilloma. Now, what about this pathology? You can, I'll give you a hint that the patient is having asthma or atopy, right? Or I would say that he is having a hyperimmune status or something like this will be given to you in the question, that the IgE level is elevated or the eosinophil count which is there, it is also elevated, right? In all that particular condition, what are you thinking about? You're talking about because of a hyperimmune state, there is, what will the aspergillus do now? It will lead to ABPA, which is called as the allergic bronchopulmonary aspergillosis. So what are you going to get over here? You will get this classical finger in glove appearance, right? You will get the classical finger in glove appearance because of the bronchiectasis. Remember that the bronchiectasis is usually in the central part, central bronchiectasis with lots of mucus plugging, and that will give rise to this particular finger in glove appearance. Now what are you seeing over here? Now this was again a question that was asked. So you can see that there is a mucus that is present in this bronchus. So this is lots of mucus plugging, but the characteristic point is that this is a high attenuating mucus. High attenuating mucus. Now what do I mean by high attenuating mucus? Now because of the chronicity, because of the debris of these fungal elements, this has given rise to a high attenuating mucin. And because of this, the HU which is there, it will be somewhere around 60 to 80. right? It will be somewhere around 60 to 80 HU, and that is why it is appearing relatively bright. Can you see? Mucus is usually like fluid. Okay, it should be somewhere around 0 to 10. But if you are seeing this high attenuating mucus, again, that is very characteristically seen for allergic bronchopulmonary aspergillosis. So both the features can be seen with ABPA, right? Yes. Now, if you see this particular image, again, we are talking about this fungal infections. Now, the classical history which you will get is that the patient is having neutropenia, HIV, or the patient is on steroids. So, basically, I'm talking about that the patient is having an immunocompromised status, right? Now, you can see the first image over here. What are you seeing? You're seeing that there is a central area of consolidation, and that is surrounded by a ground glass opacity. So, what I'm talking about your halo sign. Okay, now halo sign which is there, it can be again characteristically seen with what other pathologies? Now this is particularly seen with invasive aspergillosis. So this is nothing but your invasive aspergillosis, right? Now, if you see the other lesions that can also show halo sign, so wherever there is a bleed, whenever there is a hemorrhage, like for an example, hemorrhagic metastasis, or if I talk about say vasculitis, like for an example, the vaginous granulomatosis, in all these particular conditions, you can get this halo sign. Where will you get hemorrhagic metastasis? Like for an example, RCC. For an example, your choriocarcinoma, you can get this particular hemorrhagic mets. Yes, Nikki, very good. Yes, halo sign. Yes, so if I talk about the serum marker which you will get in invasive aspergillosis, that is galactomannan. That is galacto. Okay, that is the serum marker that you will get for invasive aspergillosis. Now, what else you get in the invasive aspergillosis? You can get the air crescent sign. Right now, what about this air crescent sign? So what happens in the state of invasive aspergillosis, right? When the immunocompromised state. Now, because there is lots of consolidation can happen. What is going to happen now? Once you start treating this patient, you give an antifungal treatment. What is going to happen? What is going to happen? It is going to resolve, right? The consolidation, when it's going to retract, this will give rise to this classical air crescent sign. This will give rise to your air crescent sign. Okay, now if I talk about, okay, so this is about your air crescent sign. Now, if I talk about the third image over here, what are you seeing over here? See, there is a difference between air crescent and monod. See, monod will be seen in aspergilloma. Air crescent will be seen in invasive aspergillosis. So, if I ask this patient to move prone, there is no ball over here, right? So, there is no use of any prone imaging, first of all. And another important thing is, it is actually a sign of recovery in the invasive aspergillosis. So, this is actually a sign of recovery. So, this could be tested. Air crescent sign is actually a sign of recovery in the invasive aspergillosis. Now, if you see the third image, you are seeing a sign that is exactly opposite of the halo. You are seeing that there is a central area of ground glassing, and then there is a rim of consolidation that is present, right? So, if you can see over here, what is the diagnosis over here? This is actually your reverse halo sign. So, this is your reverse halo sign. And where are you going to see the reverse halo sign? You will see the reverse halo sign in mucormycosis, right? You can also see this in COVID pneumonias. You can see in cryptogenic organizing pneumonia and chronic eosinophilic pneumonia. So again, this is important. Mucormycosis particularly, I could say that this could be tested. It is going to show the reverse halo sign. What is the other name of reverse halo sign? This is also called as an atoll sign because of its resemblance to that island, right? There is a lagoon. Yes, Uttam. Yes, right. It's atoll sign. Yes, it is also seen in the bronchogenic, the cryptogenic organizing pneumonias, and one of the classical examples is COVID also. I have seen many cases of COVID that used to show this reverse halo signs. And of course, chronic eosinophilic, see, you will have, if they show you this image, they will always give you some clinical hints in the question. Like for an example, in mucormycosis, they will give you a clinical hint of diabetes, right? With chronic eosinophilic pneumonias, they will give you a history of a middle-aged female with some eosinophilias. So something like that, they will give you the history about. So TB it is not seen. TB doesn't show this reverse halo sign. It is classically seen with these invasive fungal infections like mucormycosis, COVID, and chronic organizing pneumonia. Yes, right. Now, if I talk about the various type of calcifications, so because we are talking about respiratory pathologies, now let's talk about some various type of calcifications. So if you see this particular image, what are you seeing? You are seeing a popcorn type of calcification. What is this characteristic image? What is the yes, Ajay, black face coloration also you will see, and you will also get one more sign in the mucormycosis, especially when it comes to the face and sinuses. We'll discuss with the image as well. But if you can tell me what sign you see in mucormycosis, the black turbinate sign. Again, that was tested, right? So that could be also. So that is why I feel that the reverse halo could be tested because they like mucormycosis a lot in the questions. So you are able to see over here a popcorn type of calcification. This is characteristically seen with pulmonary hematoma. Plus sometimes you can also see some fat that is present. Okay, it's nothing but a normal tissue that is present. That is a disorganized growth of the normal tissue in the lung. It is one of the most common benign tumors that is present in the lungs, and you will get this classical pulmonary hematoma appearance. Now, what about where else do you see popcorns in our body? So there are so many areas. So fibroid calcification, like they can show you a pelvis x-ray and they will show you this calcified lesion in the pelvis, and that is on the plain x-ray. Again, that is your fibroid that will show the popcorn calcifications. Then hematomas we have already discussed. Cavernoma in the brain. Okay, so in the brain there is no calcification in cavernoma particularly, but because there will be bleeds that will be of varying signal intensity, it gives and appears like that of a popcorn on the brain parenchyma, right? Now, if I talk about the chondroid matrix, so where will you see the chondroid matrix? Which brain tumor, which bone tumors? You can see them in enchondroma, right? If you can talk about chondrosarcoma, so all these particular lesions will also show your chondroid matrix. Okay, anyone wants to tell me what will you see in the Carney's triad and what is Carney's complex? Okay, we have discussed about pulmonary hematoma, but I wanted to stress on Carney's because there is a lot of confusion when it comes to Carney triad. Carney's triad is not seen with pulmonary hematomas, right? It is seen with pulmonary chondromas. It is seen with pulmonary chondromas. Okay, what other things you see? You also see gist, okay, in Carney's triad, and you will also see your gangliomas, or I would say extraadrenal gangliomas. Extraadrenal paragangliomas, that will be actually talking about the CGG. So remember the mnemonic CGG for the Carney's triad, right? Now if I talk about the Carney's complex, where will you see? So Carney's complex is particularly seen when I talk about myxomas. Okay, if I talk about myxomas, that will be your Carney's complex along with endocrine tumors. Like for an example, they can give you history of Cushing's or some thyroid disease, something like that of endocrine tumors with myxomas, particularly the cardiac myxomas or soft tissue myxomas along with the skin pigmentation. That is your Carney's complex. So both of them are different. Carney's triad, remember CGG, and Carney's complex is myxomas along with endocrine tumors and skin pigmentation. Where will you see eggshell calcifications? Yes, yes, med moments, right? It's skin and endo. Now, eggshell calcification, again, this was a question that was asked. So, it is seen with silicosis and sarcoidosis. It is seen with silicosis and sarcoidosis. Now, if I talk about suspicious calcifications, what are calcifications that will point towards a lung cancer? What is suspicious one? So, it is eccentric type of calcifications. If you see eccentric, or if you see a stippled type of calcification, okay, some small calcifications in a lung mass, then that is suspicious towards a malignancy, right? So that is about the various type of calcifications. Now, next question, again, this is an easy one. I would like you to answer this. The clinical question is ptosis, meiosis, and ophthalmos, and you are being shown in X-ray. There is a shoulder pain radiating to the arm. The most famous, the most simple X-ray, I would say, and could be tested. Yes, write down in the comments. Med moments, yes, speculated is actually the margins of the mass. Okay, it is margins of the mass. I'm talking about the calcification. So stippled calcification, some small specks of calcification or a central calcification that will point towards malignancy. Margins, if it is speculated, then yes, that could also favor towards a malignancy. So this is nothing but you can see your famous Pancoast tumor, right? This is your Pancoast tumor, the most common histopathology for a Pancoast tumor present in the lung apex, right? That will be, no, the breast shadows are normal over here. There is nothing to do with the breast shadows. That is normal. You can see that there is a mass over here. Most commonly, this is also called as your Pancoast tumor. Most common histopathology for the lung cancer will be a squamous cell carcinoma over here, right? Now, because there is a tendency of involvement of brachial plexus and of the sympathetic chain, your CH to T1 nerve roots. If I want to see anything that will be having nerves, right? Anything that will be having nerves, my investigation of choice will be definitely MRI. My investigation of choice will be MRI. Now, the question was asked in the options, if they give you the gold standard to diagnose this particular case, to diagnose any particular lung mass, not only the Pancoast tumor, but any particular mass, that will be always your image guided or say CT guided biopsy. That would be a CT guided biopsy. I've included this because again, this was tested. CT guided biopsy you will mark if they ask you a gold standard method, right? Now, if I think I didn't mention one of the important things. See, if you have been given the investigation of choice for anything that is neurogenic, for Pancoast tumors or for brain tumors, particularly for spinal cord, my investigation of choice will be always an MRI. My investigation of choice will be always MRI. Okay, so that is very important. Now, next will be this particular x-ray, you are able to see over here that there are bilateral hilar lymphadenopathy, right? There is also right paratracheal lymphadenopathy. I am giving you a hint that the patient is having an elevated ACE levels as well as elevated calcium levels. What I am talking about? I am talking about your favorite sarcoidosis, right? So this is nothing but your sarcoidosis. Okay, what staging do we use? We use, so okay, so ma'am, doubt about the size of miliary TB nodule, lung mass and nodule. So see, if they ask you a solitary pulmonary nodule, by definition, it should be less than 3 centimeter, right? Mark my words, it is less than 3 centimeter, that is solitary pulmonary nodule. More than 3 centimeter will be a lung mass. Okay, anything less than 3 centimeter, the chances of it to be malignant is usually less, especially if it's a very smooth and a well-defined type of mass. That is about the solitary pulmonary nodule and lung mass. Now, if you ask me about miliary tuberculosis, I'm going to show you an image just in a moment. They will be centrilobular. So, they will be very, very small. Okay. They will not be coming in the category of SPN or mass. They are very small. They will be present in the centrilobular calcification. Yes, med moments, yes, right. It is your CADing staging. Okay. So, the stage 1 which is there, it will be your hilar lymphadenopathy. The stage 2 will be bilateral hilar lymphadenopathy plus your pulmonary infiltrates will be present. Stage number 3 will be pulmonary infiltrates without any lymph nodes. And stage 4, that is the very rare stage, that will be your lung fibrosis eventually. Now, what will you see on the CT? What type of nodules which you are going to get? You will always get perilymphatic type of nodules, right? You will get perilymphatic nodules. Where will you see perilymphatic nodules? They will be seen along the subpleural location or peribronchovascular location or perifissural locations. These are the keywords or buzzwords for your sarcoidosis perilymphatic nodules which you are going to get. Now, what about this particular image? This is nothing but, if I give you this, I'll just tell you that both of these patients are having tuberculosis. Now, what is this particular nodules you are getting over here? This is nothing but on the CT, you are getting tree in bud type of nodules. Okay, so what is this tree in bud? This is nothing but, I would say that your respiratory bronchioles, when they will be filled with mucus plugging, okay, that will be present in your respiratory bronchioles, that will give rise to this characteristic tree in bud appearance. Okay, your respiratory and the terminal bronchioles, they will be filled with mucus, and if I do an HRCT, they will look like that of nodules, especially in the centrilobular location. Right now, if I talk about this image, you are able to see some very small nodules throughout the lung. I will give you the history that the patient is immunocompromised, right? So immunocompromised multiple nodules, this is nothing but your miliary tuberculosis. This is nothing but your miliary tuberculosis. So what is the difference? Miliary tuberculosis is a hematogenous spread, especially in a immunocompromised status. This is a not what will happen in the miliary. There is a hematogenous spread happening of the tuberculosis. So this will give rise to this multiple nodules. So it is diffusely present. Whereas if I talk about the tree in bud, okay, it is not necessarily it is present in the entire lung. It can be present in, it can be limited to one particular lobe also. This is hematogenous spread. This is a blood spread that is happening. Whereas tree in bud, which is there, it is the endobronchial spread. Again, this can be also seen with invasive type of aspergillosis. Anything invading the bronchi, they can show the endobronchial type of infection, right? So that is about your miliary tuberculosis and your tree in bud pattern of opacities. Now moving towards our next image, what are you seeing? Recurrent chest infections and sinusitis. I'm giving you this particular history over here, and you're seeing this particular X-ray. Try to think before my explanation. Try to answer them in the comments so that we can have a more interactive session. You are able to see that there is a dextrocardia over here. If I give you a chest X-ray, you will also see the gastric bubble is present on the right side. There is a situs inversus that is present over here. There is a situs inversus also present. So what I'm talking about? I'm talking about your Cartagena syndrome or your primary ciliary dyskinesia. On the other hand, if they give you another X-ray with a clinical hint of pancreatic insufficiency, elevated sweat chloride, or if there are recurrent chest infections again, and you are seeing that there is a bronchiectasis that is present over here, okay, upper lobe mein you are seeing this bronchiectasis with recurrent infections, this is nothing but your cystic fibrosis. So both of these pathologies will be showing the bronchiectasis, but situs inversus wala X-ray will be characteristically for your Cartagena or primary ciliary dyskinesia, right? What are the signs of bronchiectasis? Because it's tested, the signet ring sign kisme dikhega, you will see it on the axial imaging. If I talk about the tram track appearance, you will see this tram track, especially on this particular, on the coronal images, because your bronchi will not taper, right? They will be appearing as two parallel lines, so that will give rise to this tram track appearance. So quick revision about the difference between your primary ciliary dyskinesia, Cartagena syndrome and cystic fibrosis. This is very important, so that is why I've included. The main problem in the primary ciliary dyskinesia is that there is a dynein arm defect. In cystic fibrosis, there is a CFTR mutation, right? So the main pathology is over here is the immotile cilia, whereas in cystic fibrosis, there are thick secretions that will be present, right? Now, if I talk about the bronchiectasis, again need to remember that it is more commonly seen in the lower lung lobes, whereas in cystic fibrosis, it is more commonly seen in the upper lung lobes. But the most important difference is the situs inversus. It will be present in Cartagenar and it is not present in the cystic fibrosis. See, both can be presenting with the same history of recurrent chest infections. Okay, look for situs inversus. If they have given you an image, always look for situs inversus, that, or look at the heart shadow, look at the look at the marker that is present where right and left is mentioned. Sometimes they can confuse and they can switch on the X-ray. Right now, the main cause of infertility, okay, in the Cartagenar syndrome, in the Cartagenar syndrome is immotile sperm. Right, because you know that there is a dyne arm defect, but in cystic fibrosis it is nothing to do with the motility of the sperm. It is mainly because of the absence of the vas deferens. Right, now other symptoms like pancreatic insufficiency, meconium ileus, elevated sweat chloride, you will all get this history in the cystic fibrosis. Okay. Now let's talk about, so you want lobe-wise involvement. So in Cartagenar, as I already said, that it's more common in the lower lung lobes. Cystic fibrosis, it's more commonly seen in the upper lung lobes. If I talk about ABPA, right, that will be more in the central area or in the upper area. You will get those characteristic finger in glove type of an appearance, right? So that is about these particular type of bronchiectasis. Right, now if I talk about where else you will see bronchiectasis, you also see it in fibrosis, traction bronchiectasis, especially with UIP and SIP, right? In all those cases also you can see the traction bronchiectasis. Again, in UIP there is an apicobasal gradient, so you will see more in the lower lung lobes. In SIP there is usually not such apical basal gradient, and it's more of a diffuse type of an involvement. Right, now let's talk about this particular image. Again, this is a very characteristic spotter image. You're able to see multiple cannonball mets over here. Right, so these are your cannonball mets. The mnemonic to remember is it's crack, so it's choriocarcinoma, RCC, adenocarcinomas, particularly from the GIT. C is for a childhood, that is Wilms and osteosarcoma, and K is for the Kaposi sarcoma. Right, so I have written most of the things so that it becomes more quicker for us to cover so many topics. We have to see almost all these systems. Radiology is one subject where you have to see like almost every system, so it's a very underrated subject, but I feel it's very important, and it's an integrated subject, right? So almost all these systems we have to cover. So I have written most of the things so that we go quick, and if you feel that the speed is too much, just let me know so that we can just stop over there and we can just revise if you want to revise a particular topic. Right, now again, more very important X-ray over here. What you are seeing over here, you are able to see that this is again a history of newborn that has a severe respiratory distress. Right, you're given two X-rays over here. Which of the following is, so what is image A and what is image B? If someone wants to just think and comment. So the image B which is there, it is your congenital diaphragmatic hernia, right? And image A which is there, it is your CPAM or your CCAM, that is your congenital cystic adenomatoid malformation. So the first image which is there, it's actually a hematomatous malformation that is present in the lung parenchyma. So the pathology is limited in the lung parenchyma itself, and you can see that the right dome of the diaphragm over here is absolutely intact. If you see the second image over here, can you see the diaphragm over here? You're not able to see the diaphragm. All the bowel loops are basically herniated in the left upper lung lobe, in the left lung field, and it has also created a significant mass effect on the mediastinum, right? So this is the congenital diaphragmatic hernia. Sometimes very specifically they can show you a Ryle's tube also that will be lying somewhere over here in the stomach, right? So if they are showing you such a type of an image, that is very characteristic for your congenital diaphragmatic hernia. More will be the mass effect. Diaphragm will not be seen with CDH. In CCAM you will always see the diaphragm. Relatively mass effect is also less with the CPAM, right? Yes, Nikki, right? CDH and CPAM, right? So this is again a very, yes, Lakshay, right? CPAM and CDH, right? Now this particular X-ray, I am giving you the history that the patient is having excessive salivation, choking during the feeds. Okay, so what is this particular X-ray and what is the type of this particular pathology? Okay, so you are able to see that there is spoiling of the Ryle's tube. What I'm talking about, I'm talking about the tracheoesophageal fistula. But if you closely see this X-ray, you are also able to see that there is a gastric bubble over here. So this means that there is a distal communication that is present, right? There is a distal communication that is present with the esophagus of the trachea. So what I'm talking about, this is, yes, of course, it's the type C, right, Lakshay? It's type C, tracheoesophageal fistula. This is the most common type of the fistula. You will be able to see a gastric bubble because there is a communication that is present. If I talk about only esophageal atresia, type A, only esophageal atresia, you will not see this gastric bubble. Even in type B, what you are going to get? You get a proximal fistula somewhere over here. If you get a proximal fistula, will you see a distal air? Will you see a gas shadow? You will not see a gas shadow. right? Now, if I talk about pure esophageal atresia, what is that type? It is type A. You will not see any distal gas. You will only see the coiling that will be present, right? So that was about your respiratory pathology. Almost all the important pathologies we have covered. Now, let's start with the CVS. So you are seeing over here, what is this particular image? So it's very easy. I'm not going to ask you again. So this is basically a pacemaker. So you will be able to see two leads over here. You have to identify the two leads where it is present. So you can see that one of the lead is present in the RA. One lead will be present in the right ventricle. But a better X-ray, chest X-ray would be a lateral X-ray. So I would say that the lateral X-ray will be better because you will be able to differentiate the chambers better. On the RA, you will be able to see that there is a J-shaped curvature, a J-shaped tip moving upward, that is in the right atrium. And if I talk about the RV, it will be moving towards the apex down in the right ventricle, right? So let's talk about the investigation of the choice. If I talk about, it is always an X-ray. If they ask you a question, again, this was tested, the investigation of choice to see the pacemaker, right? Where it is located in the subcutaneous pocket along the left anterior chest wall. It is your chest X-ray. Absolute contraindication, which investigation? Which investigation is absolutely contraindicated? You cannot make that blunder. That is your MRI. Okay, never do an MRI in this patient. If they ask you which is a better X-ray to see the position of the leads, it is a lateral X-ray is better than that of your PA X-ray. Now, what about this particular image? So you are able to see that this is a cardiac patient, right? Now you are able to see that there are two valves. Yes, Ajay, right? It is MRI. Yes. So if you talk about this particular image over here, you are able to see that there are multiple devices. See, one, two we have seen. We have discussed pacemaker, right atrium, right ventricle, the tip is present. Now, if you see what are this particular structures over here, these are your CABG sutures, right? These are your CABG sutures that are present along the sternum. This indicates that recently there has been some surgery that has happened in this patient. Now you are able to see that there are two valves that are present. I am going to draw a line. Can you see this white line? I have drawn this particular line from the right cardiophrenic space up to the left atrial appendage, right? This particular border over here is left atrial appendage. Now the valve that will be located superior to this particular line, that will be your aortic. Remember, A will be up. That is your aortic line, and this particular, the second valve which you are seeing over here below the line, that will be your mitral valve. That will be mitral valve, right? So this is about this particular X-ray. What else do you see on this X-ray? Can you see any pathology apart from all these particular devices? You have seen pacemaker, aortic, mitral valve, the CABG sutures. There is also a cardiomegaly, right? There is a cardiomegaly. The CTR ratio is definitely more than that of 0.5. Now, what are you seeing over here? You are also seeing that there is a horizontal line over here. What is this? This is fluid that is present along the fissure, right? So this is the fissural component of the pleural effusion, right? What will you get? Whenever there is a congestive heart failure, sometimes you can get a loculated pleural effusion. Sometimes this will be also more enlarged, right? And this will be called as a vanishing lung tumor or a phantom lung tumor, can be seen along this particular fissures. So that you can get, right? Now, what else you were seeing? You are also able to see over here that there are prominent veins. Okay, can you see these particular veins? These are prominent veins. This is actually the cephalization of the pulmonary veins. It's an early sign of interstitial pulmonary edema, right? So you are on this particular X-ray, you can see that apart from devices, we have seen that there is cardiomegaly, there is a fissural component of pleural effusion, and then there is also a cephalization of the pulmonary veins, indicating an early sign of pulmonary edema. Right, now moving towards our next. So what are you seeing over here? You have to revise with me the important heart borders. Again, very important. So you, as we know that this particular area, this is your right paratracheal stripe over here, right? This entire area, you can see that this particular structure that is going to be present over here just below the paratracheal stripe and contributing to the paratracheal stripe will be your SVC. If any pathology is present in the right upper lung lobe, we have discussed the cell outside, it is going to obscure this border. Then we know that there is presence of the right atrium over here, right? This particular border is going to be contributed by right atrium. What about this border? This is going to be contributed by RV or LV? Okay, so this is going to be contributed by right ventricle. This is going to be contributed by the left ventricle. And if you can see over here, this particular part is actually your left atrial appendage. So no border is being contributed by the left atrium. Left atrium, which is there, it will be present somewhere over here. It is not contributing to the heart borders on the X-ray, right? Now, what about this particular structure? You can get over here the aortic knob. Okay, this is your aortic arch. And just below the aortic arch, not very well seen on the X-ray, you will also see a main pulmonary artery trunk. Okay, these are your moguls of the heart. Okay, what about this? These are your cardiophrenic spaces. These are your CP angles. So this is just a quick revision about the important chest X-ray findings. Now, if you can see that What about the various congenital heart diseases? Okay, so quick revision. I'm going to give you the hint, and along with the hint, we will be just telling you which signs you are seeing, characteristic named X-ray signs. So what are you seeing? That the patient is cyanotic. Okay, and the patient's age is few months. You are giving a classical history of an ejection systolic murmur. What are you seeing over here? You are seeing that this is a boot-shaped heart, right? This is a boot-shaped heart, which is also called as a core and sabot, that is characteristically seen with TOF. Remember, in the TOF, you will always get a decreased pulmonary blood flow. You will get a decreased pulmonary blood flow, right? Ejection systolic murmur because of the pulmonary stenosis. Now, what about this image? What sign you are seeing in this? Yes, Nikki, Laksh, right? It's TOF. What about this particular X-ray? What are you seeing over here? Okay, so make the scans. Okay, so Ajay will try to share both the unannotated and the annotated ones. We'll do that definitely, yes. So if I talk about the cyanotic heart diseases, what are you going to get over here in the cyanotic? You are able to see that there is a snowman sign or a figure of 8 sign. Okay, so this is nothing but your TAPVC, again a cyanotic heart disease. Now, why do you get this type of a snowman appearance? You can see that there is a widened superior mediastinum. Why do I get a widened superior mediastinum? So we mainly get this because there is a vertical vein. All the 4 pulmonary veins, they will be forming a common vertical vein that will be draining in the brachiocephalic vein and then into the SVC. So if you see the CT, you will be able to see all these particular vascular structures. So I would say my investigation of choice actually to see the TAPVC will be CT angio. Because I will be able to see all these particular vessels very nicely forming the snowman or the figure of 8 sign or the TAPVC. Right, now let's move towards this particular X-ray. I am giving you a classical hint that the patient, the mother, used to take lithium, right? So what is this characteristic history? You can see that there is a massive cardiomegaly, which is also called as the box-shaped heart or wall-to-wall heart, which is seen in the Epstein anomaly. So they can also show you a CT image. What are you seeing over here? You are able to see that there is an apical displacement. There is an apical displacement of what? Of the septal as well as of the posterior leaflet. Okay, of the tricuspid valve, there is an apical displacement. So because of this, what you are seeing over here, that there is an atrialization of the right ventricle, right? So you are going to get over here massively enlarged right atrium, and that will lead to this cardiomegaly, characteristically giving rise to this box or wall-to-wall shape of the heart, right? Now, moving towards our next pathology, you are able to see that again. Now, if I'm giving you a hint that the patient is a newborn, okay, who is having a cyanotic, okay, who is having this cyanotic heart disease, okay. So earlier in TOF, I said that the patient was few months or maybe in the early age, maybe 1 to 2 years. But if they give you this classical history of a cyanotic newborn history, and you are getting this increased pulmonary blood flow, in TOF you get a pulmonary oligemia. In this pathology, you are getting a increased pulmonary blood flow. What I am talking about? I am talking about your TGA. Okay, or this is also called as your egg on side appearance. This is also called as your egg on side appearance. Now, why do you get? Can you see this is a very narrow mediastinum over here, and you can see that the heart which is there, it looks like that of a like a egg that has been sitting on the side. I never found this sign very useful, but it is being given for the TGA, which is the egg on side appearance. It's the transposition of the, yes, egg on side or egg on string, one and the same, Nikki. Yes. So what is happening over here? The main pathology is that because there is no spiraling of the aortopulmonary septum, because of this, the aorta will be arising from the right ventricle and the pulmonary artery will be arising from the left ventricle, right? Now let's move towards our next images. Again, this is very characteristic. You are able to see that there is a vein that is present, right, along the right atrium, right? So this is an anomalous pulmonary vein. This is your PAPVC or partial anomalous pulmonary venous return. This characteristic sign, which is called as the Schmitter sign because of its resemblance to that of a sword, a Turkish sword, and this is mainly seen because the right pulmonary vein is draining into the infrahepatic IVC, right? So because of this, you will get this Schmitter sign. Now the syndrome which you will get, again, what is the Schmitter syndrome? What is this? So what is this particular Schmitter syndrome? So Schmitter syndrome will be seen whenever there will be a PAPVC. Along with this, there will be a lucency. There is a unilateral lucency that will be present, right? Along with this, now why there is a lucency? Because there is an absent or a hypoplastic pulmonary artery. And there is also volume loss that will lead to the dextroposition of the heart. So if you see this 4 things, right? If you see all these 4 things on one particular X-ray, that is called as a Schmitter syndrome, right? And Schmitter sign is only the PAPVC. You can see this particular image. This is your Schmitter sign that you will get, right? This is a acyanotic type of a heart disease. TAPVC was a complete cyanotic heart disease. Now, if you get a history that the patient is having Turner syndrome, or if there is presence of a radiofemoral delay, right, and you are getting this classical figure of 3 appearance or a figure of 3 sign, this is characteristically seen with aortic coarctation, right? What other things you can get with aortic coarctation? You can also get a bicuspid aortic valve. You can get a bicuspid aortic valve. What else you will get? See, always remember that if I want to see PAPVC, if I want to see TAPVC or any aortic pathologies like the bicuspid aortic valve, aortic coarctation, my investigation of choice will be always a CT angio. It will be always CT angio. Anything I want to see vascular, it will be CT angio. If they ask you only TOF, right? If they ask you only the Epstein anomaly, in that cases, echo will be a better investigation. Echo will be the investigation of choice, especially in the pediatric patients. I will not want unnecessary radiation if my pathology is getting detected on the echogram, right? Right. Yes, med moments. Yes, you will also get inferior rib notching. What is the sign? What is the name of that sign of the inferior rib notching, and what ribs are involved? So particularly bilaterally 3 to 8 ribs, posterior aspect, inferior rib notching, also called as a Rosler sign. Okay. And what about the barium? You will get a reverse 3 sign, right? You will get a 3 sign on the X-ray, reverse 3 sign on the barium, or the E sign on the barium swallow. Okay. Now let's just revise quickly about the various important structures which you will get on an axial CT. What is number one? So try to just pause and maybe you can just try to identify. So remember that if I talk about number one, that is your ascending aorta. That is your ascending aorta. If I talk about number two, that will be your main pulmonary artery. The third structure which is there, it is your right pulmonary artery. The fourth will be left pulmonary artery. The fifth structure is your descending aorta. Okay. And what about number 6? Number 6 is SVC. Okay, you can remember this way. It is SAP, right? SVC, ascending aorta and your pulmonary artery. No mistakes in this. This is the most important image and definitely they can ask you to annotate, right? Now, if you see this particular image over here, what is this particular? What again identify? This is the CT cardiac image. So what are the chambers? So number one which is there, it is your right atrium. Left is number two is your left atrium. You can see this particular vein. Sometimes they can show you a lower section. Veins will be draining. So this is nothing but your pulmonary veins that will be draining into the left atrium. Okay. Now what about this particular structure? Number three is the right ventricle. The fourth will be left ventricle. This structure will be your mitral valve. What is this particular structure? This is the aortic annulus, just the beginning of the aorta, that is your aortic annulus. And if you see a proper coronal CT, you will be also able to see on the proper cuts, you will be able to see the tricuspid aortic valve also. That is the normal valve, which is a tricuspid aortic valve. Now, what about this particular structure? Very important. Can you identify number 5? Can someone identify number 5? Okay, so the number 5 is a structure that is present in the atrioventricular groove, in the right atrium and the right ventricular groove. So this is your right coronary artery. This is your right coronary artery, very important. Now from the coronary arteries, now I am telling you to identify this particular pathology. You are able to see that there is a thrombus that is present in a coronary artery. This is particularly your left anterior descending artery, right? That is present between the atrium, you can see over here, right? This is actually your left anterior descending artery. This is a little superior section, but it is present in the anterior interventricular groove. So what is this particular pathology we are talking about? I am giving you some hints, like patient is having a fever of more than 5 days, no cause has been identified, there is conjunctivitis which is bilateral non-purulent conjunctivitis, or there is rash, adenopathy, mainly in the cervical region, there is the strawberry tongue, hand feet changes, edema and deformation. We are talking about the characteristic Kawasaki disease. Okay, so Kawasaki disease, it is actually medium vessel vasculitis. It is a medium vessel vasculitis, and remember that it is the most common cause of an acquired heart disease in a pediatric age group patient, right? So they can give you this particular CT image with a thrombus in a pediatric patient with all these clinical hints, and you have to mark your answer as Kawasaki's disease, right? Okay. Now, if I talk about this particular image, this is everyone's favorite. This is a bread and butter. I'll be very quick. I'm sure everyone knows this image very well. Yes, Lakshay and Nikki, yes, it's Kawasaki disease. Okay, so you can talk about this tearing pain and there is hypertension. This type of a history will be given. This is a tennis ball appearance. This is a characteristic aortic dissection. Now tell me which of the following is a true lumen and which of the following, 1 or 2, which is the true lumen? 1 or 2, which of the following is the true lumen? So the number 2, which is there, it is your true lumen. So remember number 2, if I talk about any false and true lumen are usually smaller. It is usually smaller and they will be also showing a good contrast enhancement. False will be showing a slow flow, or they will be showing a relatively, I would say, a delayed flow, right? And they will be also definitely larger. So this is how you can differentiate between the true and the false calcification. Yes, right. Chatbot, Lakshay, yeah, everyone is right. It's true. Yes. So if I talk about the investigation of choice in the unstable patients, if I talk about, yes, the double barrel sign, yes, fine. Another important signs, just I have not included the image because I am sure everyone knows this, the cobweb sign, okay, as well as the beak sign. You will all get that, all those signs in the false lumen. Now, if I talk about the investigation of choice, unstable patient, what is the investigation of choice? It is very important. It is transesophageal echocardiogram. If I talk about a stable agent, again, anything which is vascular, I will always mark my answer as CT angio, but I need my patient to be stable because it will take some time, right? We have to stabilize the patient. If the patient is unstable, we don't have time, directly go for a TEE, right? Or a transesophageal echocardiogram. Now, quickly identify this particular spotter. This is a barium swallow image. You are seeing a very smooth and a posterior indentation. Again, same patient. I am giving you the history that the patient is presenting with dysphagia. Of course, there is dysphagia. There is a mass effect that is seen on the esophagus from the posterior aspect. And what you are seeing over here is that there is a vascular structure that is going just behind the esophagus. This is nothing but your dysphagia lusoria, which is characteristically seen with aberrant right subclavian artery. This is seen with aberrant right subclavian artery, right? This is the most common vascular anomaly that is seen in these patients. Sometimes it is absolutely incidental, but if it causes a significant mass effect, right? If it causes a significant mass effect, then in that particular condition, you will get this particular type of a posterior indentation and dysphagia lusoria also. Right, now what about this particular image? These are the characteristic signs of left atrial enlargement in a mitral stenosis. So what signs you are going to get? In the mitral stenosis, you will get straightening of the left heart border. Okay, so why do you get this straightening? Because of the enlargement of your left atrial appendage. Because of the enlargement of your left atrial appendage, you will get this sign. You will also get that there is a splaying of the carina. Splaying of the carina will be by more than that of 90 degrees usually. See, normally the angle is approximately 60 degrees. But if the angle will be increasing to more than 90 degree, you will get this type of a sign in mitral stenosis. Okay, the main pathology is, because as I already told you, what structure will come over here? Left atrium. Left atrium will be pushing this left bronchus posteriorly and superiorly, and that will lead to this splaying sign. Okay, and what about this particular sign? You can see very beautifully over here, two heart borders are seen. So there is a normal heart border that we know that it is formed by the right atrium. That is formed by right atrium. But if you are able to see another structure over here, another border that is contributed because of the left atrial enlargement, that is your left atrial border, that will give rise to this double border sign. Right, so that are about these important signs of mitral stenosis and left atrial enlargement. Right, now if I talk about the pulmonary edema, I've already shown you one x-ray. You can get pleural effusions, you can get those fissural component and phantom tumors, but most importantly, when I talk about the pulmonary capillary wedge pressure in the early stages, like 12 to 17 mmHg, if the pressure is only 12 to 17, in that particular case, you will get cephalization of the pulmonary veins. Now, what is this sign also called as? It is also called as the antler sign, right? Or the reverse mustache sign, because only the upper limb, because of the pulmonary vein, because the blood flow is preferentially diverted into this upper lobe pulmonary veins. Right? Now, if I talk about 17 to 25 mmHg, what you will start seeing, which lines? Curly B lines. You will start seeing curly B lines also. Now, this will be seen more commonly in the bases, in the subpleural location, approximately 1 to 2 centimeter long, because of the interstitial or the interlobular septal thickening that will be seen in the cases of fluid overload. And if it is more than 25 mmHg, you will get that classical bat wing appearance, right? Bat wing is mainly because of the alveolar edema. You will get this perihilar fluffy opacities, right, in the perihilar location, because of, again, excessive amount of the fluid overload. Now, if you do an HRCT also, you will see this multiple ground glassing and the consolidation more commonly in the perihilar and the peribronchovascular location. Okay, now some classical echo findings we are going to discuss. What about this particular MRI image? First of all, we'll talk about the MRI image, and then I'll talk about the echo finding also. I am giving you a history that the patient is a young athlete who is having a sudden cardiac death. And you have been shown this particular MRI image. What is this particular image? What is this image? So this is nothing but an asymmetrical hypertrophy of the septum. So this is a asymmetrical hypertrophy of the septum that is characteristically seen with HOCM. Okay, that is seen with HOCM, hypertrophic cardiomyopathy. Remember that the investigation of choice, if I want to see the morphology, right, for any cardiomyopathy particularly, it will be always an MRI. Okay, to see the morphology, M is for morphology, you can remember, for this cardiac pathologies like cardiomyopathies per se. Now, if I talk about, or even if I talk about, say, restrictive cardiomyopathy, anything of that sort is given in the question, mark your answer as MRI. Now, important thing is that septal thickness, asymmetrical hypertrophy, the septal thickness will be more than that of 15 mm. What will be the echo findings? Characteristic echo finding, if someone can tell me, you will get the SAM, right, which is also your systolic anterior motion of the mitral valve that is going to further narrow down your left ventricular outlet. That is the characteristic echo finding you will get. For investigation of choice for morphology, you will always mark your answer as MRI. Now, if I talk about some other important echo findings, where will you see the McConnell sign? The McConnell sign will be seen especially in a massive pulmonary embolism. Because of this, what happens? There is a right ventricular akinesia. You will see a right. Okay. So you will see a right ventricular akinesia as well as hypokinesia. Right? Now, what about the septal bounce? Where you will see the septal bounce, or I would say the dancing septum. This is characteristically seen with your constrictive pericarditis. This is seen with constrictive pericarditis. Okay, so what happens? Because there is a rigid pericardium, especially if I talk about constrictive pericarditis, the most common cause in India is tuberculosis. And what you are going to get, because the pericardium is very rigid and very thick, when the blood will be filling the right atrium and the right ventricle during the inspiration, because the pericardium is thick, it cannot move towards the outer side. Rather, it will be creating a mass effect on the septum, and your septum will be moved towards the left side. Okay, and when during the expiration, when the blood will now come into the left ventricle, what is going to happen? Again, your septum will be pushed back. So this will give rise to the septal bounce appearance in the constrictive pericarditis. Right? Now let's move towards the next pathology. I am giving you a clinical hint. So look at this question. A 65-year-old postmenopausal woman develops acute chest pain. ECG shows mimicking myocardial infarction. There is elevated troponin levels. There is a recent emotional stress, physical stress. Coronary angiogram is showing a normal coronary artery. What is this particular pathology? So this is your characteristic Takotsubo cardiomyopathy, right? So this is the classical history which you will get of emotional stress of these patients with normal coronary arteries. And what are you getting over here? You will get this Japanese octopus shaped heart, because there is a narrow neck, but the base which is there, it is ballooned, right? So this will give rise to this characteristic appearance. What will you see in the echo? What are you going to see in the echo? You will see that there is a apical hypokinesia, but there is a basal hyperkinesia in Takotsubo cardiomyopathy, right? So this is an important pathology and this could be tested. So I have covered this pathology as well on cardiac MRI and what are the echo findings, right? Now, what about this particular image? You are seeing over here. The question is that there is an inguinal swelling after a catheter angiography in a patient in the inguinal region, right? You are putting an ultrasound probe, and what are you seeing over here? You are seeing that what happens is, because of the catheter angiography, there is a damage that has occurred to the vessel, right? The adventitia is damaged. So because of this, what is going to happen is that the blood is going to move like this. Okay, blood is going to move like this. So if I put my ultrasound probe over here, it will be confused, right? There will be a blood that will be flowing towards the probe, and then there is a blood that will be moving away from the probe. So you are getting this classical Pepsi sign, or it is also called as the yin-yang sign. So what pathology I am talking about? I am talking about a damage to the vessel wall after a catheter angiography. This is your pseudoaneurysm, right? This is your pseudoaneurysm that you will give rise to this classical Pepsi and the yin-yang sign, right? So that is all about all these particular things, right? Yes, Lakshmi, yes, it's the yin-yang sign. I hope this is clear to you. Okay, now cardiovascular is over, chest is over. Now let's move towards the breast border image. Is very easy. Let's make it very easy for you. So you can see that the first image you are able to see again popcorn calcifications. We have already discussed popcorn calcifications in the breast. You are able to see this involuting fibroadenoma. So this is nothing but an involuting type of fibroadenoma. Quickly tell me what will be the barrage of an involuting fibroadenoma. Absolutely benign. Bireds will be 2. It's not normal, so it's not Bireds 1, but it's Bireds 2. Absolutely benign. Now, if you see this particular calcification in the breast, very small calcifications, I would use the word microcalcifications, right? Or I can also use the word, say, fine pleomorphic type of calcifications, or I can also use the word I would say ductal calcifications or linear calcifications, right? So all these particular calcification, if anything of this sort is given to you in the question, right? So this is all pointing towards a malignancy. So this is actually your Birad's 4C or Birad's 5, right? This is always suspicious. You will always mark microcalcification, the suspicious pathology, because what is going to happen, because your ductal carcinomas, if I talk about, they are going to grow along the ducts, right? And in the chronicity, what is going to happen, they will calcify, and that is why you will get this particular casting type of calcification. So remember that this is always and always feature of malignancy. Okay, you can also see that there is a lot of architectural distortion that is happening. This is absolutely an abnormal finding on a mammogram, okay, pointing towards a breast carcinoma. Now, moving towards this particular pathology, what is this particular pathology? I'll give you a hint. This is breast within a breast appearance, right? So this is again where we have discussed hematoma in the lung. This is a breast hematoma. Absolutely, I would say a benign finding. It is made up of fibroglandular tissue and fat, and that is why it is looking like that of a normal breast only. So it gives rise to a breast in breast appearance. You will get this beautiful pseudo capsule also in this particular lesion, right? So when I talk about the Birad's, again, this is an absolutely benign finding. So this is absolutely, this will be Birad's 2. Now, if I talk about this particular pathology, again, you can see that this is a very well speculated type of a mass, a very ugly looking mass, I would say speculated mass. A characteristic keyword will be speculated mass. And if I closely see, I don't know whether it is seen to you, but you are also able to see some small microcalcifications. So this is your Birad's 5. This is absolutely Birad's 5. This is very suspicious for a malignancy. Okay, of course, we have to confirm it with the help of a biopsy. Confirmation will be always done on the histopathology. Imaging will just help you to tell whether it is a benign imaging pathology or whether it is a malignant. But this speculated with microcalcification is very characteristically seen for a Birad's 5 lesion. Now, what about this particular sign? You are able to see this is a, I have already written, this is a linguini sign. So this is actually an implant rupture. Tell me whether it is an intracapsular or an extracapsular rupture. It's very easy. I just need to bring some water. So that is why I'm asking you, intracapsular or extracapsular? Okay, so this is basically intracapsular rupture. Okay, so what happens is, because when we put a saline or a silicone implant, there is a fibrous capsule that is going to be formed by the host. So that external capsule is intact over here. Your silicone or saline implant shell which is there, it has broken and it has retracted, and thus has given rise to this noodle type of an appearance into the breast. So this is definitely your intracapsular rupture. In the initial stages, you can also get this particular type of a sign which is called as a nose sign. Okay, or it is also called as your tear drop sign. It is also called as a teardrop sign. Okay, linguini sign on an ultrasound, what will it give rise? Hyperechoic lines. So multiple hyperechoic lines on the ultrasound, that will give rise to your stepladder sign on an ultrasound. A stepladder sign on ultrasound. Okay, what about extracapsular rupture? There is only one sign which we need to remember in extracapsular rupture, because your saline, the silicone is going to now come. Okay, especially if I talk about silicone, it is very hyperechoic on ultrasound now, because it's going to come into the axilla. If I put my probe in the axilla, you will get this characteristic multiple hyperechoic appearance. Multiple reverberation artifacts can be produced, and that will give rise to your snowstorm appearance, right? So extracapsular may you will get snowstorm appearance on the ultrasound. Snowstorm appearance. I hope this is quickly revised for you, all the signs we have discussed. Okay, what about this type of calcification? One calcification was left, we have covered. You are getting this characteristic eggshell type of calcification, right? A very beautiful eggshell calcification. This is nothing but your oil cyst. Okay, it's a type of dystrophic calcification. Again, I would say this is the type 2 Birad's, and you can also say fat necrosis. See, fat necrosis in the early stage, it is called fat necrosis, and when over the long run, it will turn into a cyst. It will organize itself with this eggshell type of calcification, and this will become an oil cyst, right? I hope all the breast imaging spotters are clear. I want each and every of your answer. If a breast imaging question is asked, I'm sure that nothing will come apart from this. Okay, these are the only pathologies which I usually ask, so I'm sure that you will get all of these right. Okay, now let's talk about the MSK. We have quickly come to the MSK, a quick revision of MSK, then we might take a short break. So let's talk about the various skull imaging pathologies. I am giving you a hint that the patient is having RCC, and you are seeing in the skull multiple varying size lytic lesions. So what is this? This is your METS, okay? Multiple varying size lesions, punched out lytic lesions you are getting. This is your metastasis. Always look for the clinical hint, some sort of clinical hint they will give you in the question. Now, the second image, I am telling you that the patient is having chronic renal failure, and you are seeing this characteristic salt and pepper type of an appearance. This is mainly because of the trabecular resorption. You're talking about the trabecular. Med moments, we have already discussed the views of mammogram. You can see it in the initial part of the class when we have discussed about the various investigations. We have covered the views of the mammogram and about the imaging investigations, what to be used when. We have discussed that in the beginning of the class, right? So if I talk about the chronic renal failure and the skull appearance, you're getting this characteristic salt and pepper appearance. Okay, so this is a salt and pepper appearance. Characteristically, I'm talking about your hyperparathyroidism. So because of the trabecular resorption, the small lytic areas you will get, and this will give rise to this salt and pepper appearance, right? Now, the most specific X-ray, if I want to diagnose hyperparathyroidism, most specific one body part that will surely tell that yes, this can be hyperparathyroidism. This could be a hand X-ray. Okay, what is going to happen in the hand X-ray? You will see resorption that will be present on the radial aspect of your index and the middle fingers, right? Because of because the main pathology is hyperparathyroidism is resorption of the bones, and that is going to give rise to this characteristic imaging appearance on a hand X-ray on the radial aspect of your index and the middle finger. That is the most specific sign for hyperparathyroidism. Now, the next skull X-ray, I will give you the history that the patient is having an M spike, patient is having anemia, patient is having renal failure, and what you are getting over here is the classical raindrop skull. What are we talking about? We're talking about multiple myeloma, multiple small punched out lytic lesions, almost of the similar sizes. We are talking about multiple myeloma. If I talk about bone scan, multiple myeloma will be cold, right? On bone scan, if I talk about metastasis, they will show a hot uptake on the bone scan. Right now, what about this particular image? I am telling you that the patient is a pediatric patient. You can also look from the skull, it's a pediatric skull. And if you see the single lytic lesion, this is characteristic of hole-in-hole appearance. Also, this is mainly because of its beveled edges, because there will be more resorption or more lysis that will be involving the inner table than that of the outer table, right? So because of this, it will be producing this characteristic hole-in-hole sign. What I'm talking about? I'm talking about eosinophilic granuloma, also called as a Langerhans cell histiocytosis, and you will also get a characteristic button sequestrum. Okay, what is the sequestrum? It is a dead devascularized bone. So sometimes you can see this button sequestrum also in the center of the lesion. Where else will you see a sequestrum? You will also see it in chronic osteomyelitis. Sometimes you can also see with lymphoma, but I think it's important for you to remember these two important pathologies, that is EG and chronic osteomyelitis, right? So that is about the various skulls we have discussed. Okay, there are few skulls more. So when I talk about this particular image, I'm giving you a history that the patient is an elderly. The ALP level is also elevated. What are you getting over here? You are getting this multiple sclerotic lesions, okay, multiple fluffy type of opacities looking like that of a cotton ball. Okay, and you can also see that there is a extreme widening of the diploic spaces over here, right? So this is characteristically called as your Tam O'Shanter skull. Okay, this is called as your Tam O'Shanter skull because it looks like that the person is wearing this particular hat. So this is your characteristically Paget's disease. Very good, mid moments. Yes, it is your Paget's disease. Yes, Ritik Soni. Yes, it is Paget's disease. This is especially in the sclerotic phase that you will get this particular cotton wool appearance. Remember that in Paget's, what is going to happen? Your bone is going to expand. Bone is going to expand, right? Because of this, the skull is also expanding. Vertebra will also enlarge. Vertebra mein what sign you get? You get ivory vertebra. Okay, in the vertebra, because your bone is going to be densely sclerotic and it is also widened, you will get an ivory vertebra, completely dense vertebra in the Paget's disease. What pathology will also give more ivory pathology? You will get an ivory pathology, ivory vertebra. Also, you will see it in lymphoma, right? And bone metastasis, maybe you will get this ivory type of appearance of the vertebra. Now, what about this pathology? So someone has, I think already, I think someone has deleted. So this is right. Yes, it is the hair on end appearance, right? Yes, increased heart size. Yes, Ritik Soni. Now, this particular image, this is characteristically seen with extramedullary hematopoiesis, right? Hair on end appearance you will get in thalassemia. And you can also get the sickle cell. Yes, in femur you will get the banana fracture. Yes, banana sign you can get, right? Now, if I talk about this, you will see it in thalassemia. Now, I will tell you one more question. Now, suppose they will give you a lesion that will be having a hair on end that is particularly in one particular part of the skull. Okay, which metastasis will also give a hair on end appearance? This is an extra edge point. So, it is in neuroblastoma metastasis. So, neuroblastoma metastasis can also give this hair on end. You will see a lytic destruction along with this hair on end type of a periosteal response in the neuroblastoma. And what else you will get? Orbital metastasis producing the raccoon eyes, that will also be seen in neuroblastoma metastasis, right? So hope this is clear from the skull. Now what about this particular pathology? Classical spotter image in the calcaneum, I would say most common benign lesion of the calcaneum. You are seeing that there is a lytic lesion with the central calcification. This is nothing but your cockade sign, because it looks like that of a cockade, right? You must have seen those cockades, those people who put those cockades, right? Those badges, right? That particular appearance. This is the cockade sign. Most commonly, this is seen in the wards, the triangle of the calcaneum. This is the characteristic location. This is nothing but your calcaneum lipoma. This is your calcaneum lipoma. Okay. We have not discussed contrast yet. We will be discussing contrast in the last section, right? We have kept, after systemic, we have covered the physics and the contrast part, right? So when I talk about it's a do not touch lesion, okay, for the confirmation for investigation of choice, if I want to see fat, it will be your MRI images, right? Now this is a do not touch lesion. We do not have to do, if you diagnose, it's absolutely incidental. We don't do anything. What other pathologies are do not touch in our body? So it is non-ossifying fibroblasts, your FD, enchondromas, and simple bone cyst, right? These are all your do not touch lesions. We don't do anything except if there is a fracture that has happened into these particular pathologies, then only we will be doing something about them. Otherwise, these are do not touch lesions, right? What about this? This is again very classical spotter image. So you are able to see that this is a case of chronic infection. This is chronic osteomyelitis. First image, the red, the dense part, this particular part, the dead devascularized part, can you see that anything that is devascularized, that will be showing an increased density, right? So what are you going to see? This is called as a sequestrum, right? Now what about this particular part? You can see that there is a sinus that will be also draining, right? So this is the cloaca, right? And if you can see the solid periosteal response over here, this is your involucrum. That is your involucrum. So this is characteristically all these three findings. Anything can be asked to you to identify. So I don't want any one of you to make this wrong. This is very easy: sequestrum, cloaca, and the involucrum, right? I hope this is clear. Now let's move towards this. Again, a do not touch lesion, I would say, a very characteristic incidental finding. I see these cases like routinely. Sometimes we don't even report because this is absolutely a benign finding. So this is a vertebral hemangioma. On axial, you are going to get this polka dot appearance, and on the most common site is in the dorsal vertebra. What are you going to get over here? You are going to get this particular vertical trabeculations, okay? So there is a resorption of the horizontal trabecula, prominence of the vertical trabecula. What are we talking about? We're talking about the vertebral hemangioma. So these are the hemangioma's two characteristic signs, that is your polka dot sign and the Corduro sign that you will get, right? These are absolutely incidental findings that you will get for a vertebral hemangiomas. Now moving towards our next imaging finding, what are these particular vertebra? You can see that there is a central depression that you can see in the end plane. These are your codfish vertebra. These are characteristically seen with what? Can anyone tell me? Characteristically, codfish vertebra, we see it with osteoporosis. We see it with osteoporosis, right? And sometimes whenever there is a significant, suppose there is a fracture that will be also associated, what you will get over here? You can also get this compression fractures, or you can also get vertebra plana. Which pathology you will also get vertebra plana? You can get it with eosinophilic granulomas also, especially if they show you a pediatric patient. Okay, sometimes they can show you multiple compression fractures, multiple wedge compression fractures and vertebra plana, especially in an osteoporosis patient. So codfish vertebra and this vertebra plana you will get in osteoporosis. H-shaped vertebra kisme dikhega? H-shaped vertebra, can someone tell me? H-shaped vertebra. We have this image also, but I want you to answer because we are discussing about the various vertebra. H-shaped vertebra we see with characteristically sickle cell disease. Right now, if I talk about the definition, see, very important, this can be tested, very, very important, I would say. Investigation of choice will be DEXA scan for osteoporosis. Now, which of the following scores will you use? Which of the following you will use? Whether you will be using a T score or whether you will be using a Z score. So the answer over here is I will be using a T score, right? I will be using a T score. Now, if you want to remember that T which is there, it stands for typical. So I will be comparing the bone mineral density which is calculated on the DEXA scan to a typical young age person, okay? It doesn't stand for typical. This is a mnemonic for you to remember. T which is there, it stands for typical, right? Typical means I will be comparing this with a young age person, right? Like for an example, 30-year-old patient. 30-year-old male, say I will be comparing the bone density which is obtained, and that is used to calculate this particular score. Okay, so the definition which is there at osteoporosis is that the score will be less than minus 2.5, right? If severe osteoporosis, you will also get a fragility fracture, minus 2.5 plus a fracture. What about osteopenia? It will be minus 2.5 to minus 1. And if I talk about normal, it will be more than that of -1. That is about the T-score. Now, what about Z-score? So, Z-score I will be comparing. So, remember Z which is there, I will be zooming it for the same age, for the same sex. Okay, so this is how you can remember, zooming for the same age and for the same sex. When I will do this, when I will be requiring the same age, so this is particularly in the premenopausal women, or say for children, or for men who do not have osteoporosis in general in common. In that particular conditions, I will be using my Z-score. Okay, so hope this is clear. Yes, fracture assessment using the DEXA tool we use in the OP. Yes, right. Okay. So now let's move towards our different other vertebra. So what are you seeing over here? You are seeing a beaking over here, right? So what is this particular? Remember the mnemonic high ma, okay, and this is how you are going to clear this particular thing. It's very confusing. Anterior beaking, inferior beaking. So seen with mucopolysaccharidosis, high. So H which is there, it is your Hurler syndrome. So Hurler may you will be getting inferior beaking. And if I talk about your Morque's, M which is there, it is your Morque's disease. What you will get? You will get an anterior beaking. Okay, so this is actually anterior beaking. So for your MCQ point of view, you can remember this is Morque's beaking. Inferior beaking you will get in Hurler's disease. Now what about this? These are your bullet shaped vertebra. Where will you see this characteristic bullet shaped vertebra? This is seen with achondroplasia. This is seen with achondroplasia. Now, what about this particular pathology over here? You are seeing the H-shaped vertebra in sickle cell disease. What are the signs you will get? You can also get splenomegaly, right, in sickle cell disease in the initial stages. And then finally, it can also get auto-infarcted and it can go into this completely calcified type of a stage, right? Now, if I talk about the other findings, what you can get? You can also get avascular necrosis, right? Especially in the femur, you can get in the dactylitis, okay? In the small bones also you can get. So, these are the characteristic findings of sickle cell. So, I hope all the vertebrae are clear to you, right? Now quickly we'll be discussing about the bone tumors. We don't have much time, but I really wanted to cover because one question is definitely a must from bone tumors. So we'll just quickly cover almost all the bone tumors. Important images I'll be covering. So remember that if I talk about the epiphyseal, we'll classify them first so that it becomes easy to revise. So epiphyseal, we have only two, chondroblastomas and giant cell tumors. Very easy to remember. If I talk about giant, more than 20. A giant is definitely more in age. So more than 20 years after the skeletal maturity, if you see an epiphyseal lesion, it is GCT. Less than 20 years, it will be a chondroblastoma. Now diaphyseal, it's a very easy mnemonic, that is female O. So it's FD, Ewing's, multiple myeloma, and even metastasis you can remember. Then we have adamantinoma, which is characteristically seen in which bone? It is seen in the tibia bone. Okay, lymphoma and enchondroma. Okay, and if I talk about the enchondroma and O, which is there, it is your osteoid osteoma. Okay, so metaphyseal, no need to remember. You can just remember epiphyseal and diaphyseal, and almost rest all the other pathologies which are there, they are going to come in the metaphyseal category, right? So that is all about these particular bone tumors. So let us now start discussing. So before I jump upon the various images, a quick revision. Benign kaisa dikhega and malignant. How will the malignant look? So remember, benign which is there, it will be relatively well defined, right? If I talk about the bone, so relatively it would be a very well defined type of a lesion. It will have a very narrow zone of transition. What is narrow zone of transition? That means that it will be well marginated and you can easily see the adjacent bone around it, right? You can easily see. It looks like that you have drawn a outline from a sketch pen, like it looks so well defined. So that is your narrow zone of transition. So almost all the benign pathologies will present like this. If I talk about a malignant pathology, it will be more ill defined. It will be more in wide zone, right? More wide zone of transition. Okay, what happens is it will either be a permeative pattern, okay, or either it will be having this moth-eaten type of a pattern, and it will have this lytic appearance on the bone. Apart from this, you will also see usually a large soft tissue that will be also seen. So usually to see this malignant pathologies, what will be my investigation of choice? It is always MRI, because I have to see the soft tissues. I want to see the skip lesions. I want to see the metastasis that will be happening. Sometimes there will be skip lesions that will be seen. So for an example, if it is present in lower end of the femur, sometimes a skip lesion can be seen in the upper end of the femur also. So in all these particular conditions, my investigation of choice, which is there, it becomes an MRI, right? And usually they are definitely ill-defined and very lytic in appearance. So let's see about these particular pathologies. So 15-year-old boy, I am telling you without seeing the X-ray, I am giving you the age. Sometimes they will not give you the age, and you can see a skeletally immature X-ray, and you can see that there is a lesion that is present in the epiphysis or in the apophysis. What is the diagnosis? Lytic, well-defined, and a very unilocular type of a lesion. You can see it's very well-defined, very narrow zone of transition. What is this? Try to answer in the comments. Even if I'm moving ahead, I will try to appreciate each and everyone. Please comment. This is chondroblastoma. Okay, this is chondroblastoma. I hope this is clear. Moving towards our next question, a 35-year-old female, so definitely more than the skeletal maturity which is there. The patient is skeletally mature more than 20 years, and you are able to see again a lesion that is spreading and involving the epiphysis. Of course, there is some metaphyseal extension that is also seen, that you can see with these lesions. Metaphyseal and articular extension can be seen. What is this particular diagnosis? So this is the characteristic. Yes, Nikki, mid-moments, very good. It is chondroblastoma, the first one. The second one, more than 20 and epiphyseal lesion. This is your GCT. Okay, sometimes you will also get this classical, either it can be unilocular or you will get this soap bubble appearance, right? It is in the epiphyseal. It can have this metaphyseal and articular spread, and appearance it can be uni or multilocular. Now, if I talk about the diagnosis of third image, okay, again very characteristic. You are seeing that there is an entire femur that is deformed. You are able to see that there is a ground glass matrix over here, right? And I'm giving you the hint also that the patient is only 10 to 20 years. The location is, you can see it's in the diaphysis, mainly in the diaphysis. What is this? Characteristic ground glass matrix. This is nothing but your fibrous dysplasia. Okay, it can be in a single bone, monoostotic. It can be multiple bones. It will be polyostotic. What about the various syndromes? If I talk about two important syndromes, McCune-Albright syndrome. What is the triad over here? Polyostotic. Yes, Tinku. Yes, very good. It's fibrous dysplasia. So polyostotic FD with Capillus spots and with precocious puberty. Okay, so these are the characteristic McCune-Albright syndrome. And what about the Mazabrod syndrome? So again, very important, polyostotic FD. Plus, if you are seeing even the soft tissue myxomas, they can give you an MRI image with FD, and multiple soft tissue muscular myxomas they can give you. So that is your Mazabrod syndrome. Okay, so this is the characteristic Shepherd-Crooked deformity. Now, what about this particular image? Okay, this looks like similar to that of a GCT, but you can see over here that your epiphysis is spared. Okay, the epiphysis is spared. So this lesion is particularly in the metaphysis, and you can also see sometimes this particular septations over here. You can also see these particular septations, and you can see that the age also is skeletally immature, less than 20 years of age. A soap bubble type of a lesion, again you can see over here, or a honeycomb type of an appearance. If I do an MRI, what I am going to get in this particular lesion? No, chatbot, it's not osteosarcoma. On the MRI, I will give you a hint that I can also get multiple blood fluid levels, right? So this is nothing but your ABC, okay, or your aneurysmal bone cyst. Yes, Nikki, right? It's aneurysmal bone cyst. Multiple hemorrhages will give rise to this classical blood fluid levels on in MRI. And again, this is an expansile lesion that can lead to a thinned out cortex. I hope this is clear. Epiphysis is clear over here. It's a metaphyseal lesion. What about this? Very characteristic sign. You are getting over here a fallen fragment sign, or you are also getting a hinged door sign. Okay, so what is this particular sign? This is, I will say that this is a do not touch lesion, but in this particular patient is presenting with a fracture. This is painful. So usually these patients are going to present as that of a pathological fracture. Again, in skeletally immature, it is more common, less than 20 years of age. This is a simple bone cyst. Very good, Ritik Soni. Yes, it is simple bone cyst. It is located again in the metaphysis, characteristic in the proximal humerus and in the femur. And you need to remember that it is more commonly, it is unilocular with no septa. Septa will be seen in the ABC. Yes, med moments, correct. Moving towards our next pathology, characteristically, agar aapko, if they are giving you a hand X-ray with a very well-defined lytic lesion, if you are seeing it in the diaphysis, what is this particular lesion? In the diaphysis, a lytic lesion. Again, you are seeing there is an endosteal scalloping. It's a very well-defined type of a lesion. Narrow zone of transition. If you see very closely, sometimes you will also see the chondroid matrix. I've already discussed chondroid matrix very clearly with you. Chondroid matrix, what will it show? It will show either popcorn type of appearance or calcification, or ring and arc type of calcification. What I am talking about? Enchondroma. Very good, Tinku. This is an enchondroma. And what about the age? So age is somewhere in 20 to 40 years, characteristically involving the diaphyseal. Remember the mnemonic, right? Female O. So that will be diaphyseal lesion, more commonly seen in these small bones. Now, what are the syndromes which you need to remember? So syndrome will be Ollier's disease and Maffucci. Ollier's mein what will happen? There will be multiple enchondromas. And what will happen in Maffucci? There will be multiple enchondromas. Plus, there will be also your soft tissue hemangiomas. So, how will they test you? So, they will show you a soft tissue growth. And they may also show some calcifications which are nothing but phleboliths, right? That are seen in hemangiomas. So, if they are giving you an X-ray of hand, multiple enchondromas and soft tissue mein calcifications, think about Maffucci disease. Why Maffucci is important? There is more chances of conversion of chondrosarcoma. There are more chances of conversion into a chondrosarcoma or malignant transformation if I talk about Maffucci syndrome as compared to the Ollier's disease. right? I hope this is clear. Now moving towards our next pathology, what are you seeing over here? I would see almost all the bone tumors may your investigation of choice is MRI, except for one lesion, that is your osteoid osteoma. Okay, I'm telling you the answer. So investigation of choice, which is there, it is definitely your NCCT. Why? Because what you are having over here is you will be seeing a central area of nidus, which is less than that of 2 centimeters, and you are able to see that there is a extensive amount of cortical or a periosteal response, a smooth benign type of a periosteal response you are getting, right? I will give you a classical history that the patient is presenting to you with night pain, and sometimes it is also present in the posterior vertebral elements, and that will lead to scoliosis. So this type of clinical hint they will give you in the question, right? So this is your osteoid typical age is 10 to 25 years. Most common site is femur. Remember, it's a cortical tumor, it's a diaphyseal tumor. Investigation of choice is CT. Treatment of choice kya hoga? See, you give NSAIDs, patient will be responding to NSAIDs, but the treatment of choice is radio frequency ablation, right? That is the treatment of choice. You have to ablate the nidus. Now, if I talk about the another important differential, that will be having more than that of 2 centimeter. If there is a lytic lesion more than that of 2 centimeter and that doesn't respond to NSAIDs, what I'm talking about osteoblastoma. Okay, that is about your osteoblastoma. Now, important point is that there are 3 important lesions which are present in the posterior vertebral elements. In the posterior vertebral elements, that is your OOA, which is your osteoblastoma, your osteoblastoma, and your ABC. Yes, Khalid Ansari, yes, correct. Yeah. Okay. Now let's move towards the next pathology. I would say the most common benign lesion. Okay, the age is 10 to 20 years. What you are seeing over here, there is a bony outgrowth, very easy, right? They can also show you an MRI image, something like this, and you can see that this hyper area, what is this area? This is your cartilage cap. What is the length over here? This is 4.5 mm only. Okay, this is the cartilage cap. We are talking about exostosis, right? Everyone knows this pathology. This is exostosis. So what is going to happen over here in the exostosis? The lesion, it is arising mainly from the metaphysis. It is going to grow away from the joint. Most common location, it is going to be seen near the knee. It is going to be seen near the knee, in the femur or in the proximal tibia, away from the knee joint. MRI pe, what are you going to see? You are going to see a characteristic cartilage cap. Now, this is absolutely benign, most common benign tumor, but if there is a growth that will be seen after the skeletal maturity, or if the lesion becomes painful, or if the cartilage cap becomes more than that of 1.5 centimeter on an MRI, then I have to start thinking that it can get converted into a malignancy. And which malignancy it is going to get converted? It is your chondrosarcoma. It is your chondrosarcoma. Okay. Now, multiple lesions, what is it called as? It is called as hereditary multiple exostosis or diaphyseal eclasis. Remember that again. Remember, with diaphyseal eclasis, again, you have to remember that it has more chances of getting converted into a chondrosarcoma as compared to a simple incidental exostosis, right? Now, let's move towards some of the malignant lesions. Very characteristic history. Young age patient, second decade, 10 to 20 years. Most common primary malignant lesion, you are getting this characteristic sunburst type of an appearance or a speculated type of periosteal response. And sometimes you can also get an elevated periosteum, right? A triangular shape elevated. What I'm talking about? Codman's triangle, right? So we are talking about osteosarcoma, right? Secondary, if you are presenting with such a lesion in an older age group, okay, start thinking about of secondary osteosarcoma. You will get history of Paget's disease. You will get history of Paget's disease or prior radiation. Location, again, remember, it is metaphysis. Most common site where it is going to metastatize. Yes, Nikki, correct. It is osteosarcoma. Metastasis will be lungs. Remember that osteosarcoma is one metastasis, an extra edge point for you, that it can also produce pneumothorax. What type of matrix you will get? You will get an osteoid or an ivory type of a matrix. Right now, if I talk about the bones, again, most commonly it is seen around the knee and the lower tibia. In the lower part of the femur or the upper part of the tibia. Periosteal response, you can get sunburst type or a speculated type of a response or a Codman's triangle, and you can see how dense ivory type of matrix you are getting. That is a characteristic. What? Your osteosarcoma. Okay. Now moving towards our next pathology. So again, here I would say that this will be a malignancy. A malignant tumor more than that of 40 years of age, and more commonly they will give you an image of either pelvis or shoulder, something in the axial skeleton, and you are again seeing a chondroid matrix over here. That will be your ring and arc or popcorn type of calcification. These are your buzzwords. Again, location arising from the metaphysis. What I am talking about? I am talking about your characteristic. Again, this is a very lytic and an aggressive. You can see how the entire pelvis is destroyed over here. Eye leg bone is completely destroyed. What is this pathology? Please write it down in the comments fast. Primary, more commonly in the pelvic bones, femur and humerus, and the secondary, it is going to arise from enchondroma and osteochondroma. What I'm talking about? So this is nothing but your chondrosarcoma. This is your chondrosarcoma. Yes, cloud-like. Perfect. Yes, Nikki, it's a chondrosarcoma. Cloud-like appearance, that is your chondrosarcoma, right? Okay, so that is all about these particular bone tumors. We'll take a quick break of only 15 minutes, 10 to 15 minutes, not more than that, and then we will be doing neuroradiology, GIT, and the hepatobiliary and the pancreatic radiology. Okay, so quick break of 10 to 15 minutes. You guys can have some dinner, and I'll be back to cover, and of course, we'll also cover a bit of nuclear as well as the radiotherapy in the end, right? So let's take a break. So it was really a quick break. And because we are short on time, we have to cover again almost half of it. Half of it is done. So 2 more hours to go and a quick revision of the other important topics which are left. So let's start discussing about neuroradiology. So what they are commonly testing you, what they are going to ask you is, they are going to ask you the anatomy, right? So on the axial as well as on the sagittal MRI brain images, we have already discussed the sequences, right? So this is your T1 weighted image. Let's quickly see the important structures on it. So what about this particular structure over here? You can see that just adjacent to the frontal horns, you're going to get your head of the caudate nucleus. You will get your head of the caudate nucleus. Right now, what about this particular area over here? This will be your lentiform nucleus. Two important structures will come in lentiform nucleus. The inner part which is there, it is your globus pallidus, will be your globus pallidus, and the outer part which is there, what will be there? It will be your putamen. So that will be both forming your lentiform nucleus in this particular area. Now, what about these particular areas? You can see that there are the lateral ventricles. What are the structures that are present in the lateral ventricles? That is your choroid plexus, right? They can ask you any of these structures to just annotate them. So you should have a basic idea about it. This particular part over here is your third ventricle. Two structures just adjacent to your third ventricle. What are they? They are your thalamus. That will be your thalamus, right? What about this? Again, this is very important. Your genu of the so this anterior part which is there, that will be your genu of the corpus callosum. The posterior part which is there, it will be your splenium of the corpus callosum. Now, what is the structure that is going to divide these two lateral ventricles? So that will be your fornix. That will be your fornix. And in the superior part, you can see this is your septum pellucidum. What will happen if the septum pellucidum is absent? You will get boxcar shape of ventricles, right? If there is no separation between them, you will get a boxcar shape of ventricles. So that is again important thing. And apart from this, what is this? This is your torcular hierophily, right? All the confluence of the various sciences that you will be getting over here at this particular point, that is okay. What about the internal capsule? So you can see that this particular part over here, this is your internal capsule. Now it is important to remember the internal capsule. You know that there are two parts of internal capsule, an interior part and a posterior part. The posterior limb of the internal capsule will be having your corticospinal tract, right? So that is very important. So that is about your axial section. Now if you can see over here, this is your sagittal sections. There are some important structures which are commonly tested. So you need to know that the structure that will be having a belly in the brainstem, that will be your pons, right? The part that will be superior to the pons, that will be your midbrain. The part that will be lying just below it, that will be your medulla oblongata. So that is easy to identify. This is your cerebellum part, right? This is also very easy to identify. Now what about this black structure? This is your corpus callosum. Again, the interior part which is there, that will be your genu of the corpus callosum. The posterior part which is there, it is your splenium of the corpus callosum, right? You can also see the various venous sinuses. So you can get the superior sagittal sinus, the most superior part over here. How are the vessels going to appear? They will appear as flow voids, right? Moving blood will be always appearing as a flow void on T1 and T2 weighted images. Now what about this particular structure over here? Just the vessel that will be located just interior to the pons, you are able to see the basilar artery. They can also show an axial section at the level of the pons, and the vessel that will be located just interior to the pons, that will be your basilar artery, right? Now what is this particular structure over here? This is your optic chiasma. Again, very important. Just anteriorly, you see this part over here, just adjacent to the third ventricle, you know that is thalamus, right? The structure that will be just below it and anterior to it, that will be your hypothalamus, right? And if you can see over here, just below it, there will be your mammillary body, and here you can see that this particular rectangular type of a structure, that is your optic chiasma. So these are important structures over here. Now more importantly, in the posterior part, can you see this particular structure over here? This particular structure is the pineal gland over here. This particular part is the pineal gland. Now why it is important? Because if there is a tumor that is present in the pineal gland, it is going to compress the superior colliculus. So they will give you this characteristic history of Perinode syndrome, right? In which there is an upward gaze palsy. So that characteristic history you can get from this particular, they can just show you this particular image, and they will ask you to annotate and what particular structure is affected in the Perinode syndrome. So they can ask you some tricky questions like that on the basis of the anatomy. So it's just your normal anatomy, I'm sure you must have seen, but they can just give you this cross-sectional axial and the sagittal sections, and they can test you for them, right? So that is about your axial and the sagittal sections. Now quickly see about the various pathologies. The first one, the most easy one, you are able to see that there are multiple cystic lesions. If I just zoom it, you are also able to see that there is a black dot sign, right? So what is this particular thing? This is your dot in hole sign. This is characteristically called as your neurocysticercosis, right? Now if I talk about neurocysticercosis, there are 4 stages: vesicular, colloidal, granular nodular, and the calcified stage. So this particular dot in hole sign, that is characteristically seen with your vesicular part, vesicular stage, that will give you this dot in hole sign. So this could be question: which stage will give you the dot in hole sign? Why this hole, why this black part is seen? Because of the scolex. Yes, see, starry sky appearance can also be seen on the CT images. On the CT images, you can see that multiple calcifications, especially in the 4th stage. In the calcified stage on the CT, how will the calcification look? We have already discussed. It's going to look bright, right? So you will get this characteristic starry sky appearance. Now if I talk about the 2nd stage, colloidal stage, you will get this characteristic ring enhancement pattern, and this is also the most symptomatic stage, because in the colloidal stage there will be maximum edema that will be present, and the 3rd stage will be your granular nodular stage, right? In this, the symptoms will decrease, the overall edema will decrease, but you will also have this characteristic ring enhancement pattern. So that is about your neurocysticercosis. Now what about this history, this particular image? This is a T1 weighted image. On T1, CSF should appear how? It should appear black. But you can see that the CSF in the basal cisterns particularly, it is appearing white. This means that there is some proteinaceous debris, or there are some exudates that are present in the CSF. This is particularly in a particular meningitis we are talking about, basal exudates. Which particular appearance? You will get this characteristically in the TB meningitis. So you will see this appearance characteristically in the TB meningitis, right? Now let's talk about this particular image. You're seeing a ring enhancing lesion, and I have not shown you the image. See, the question is that the patient is having high fever, altered sensorium. So they will give you this clinical history with ring enhancing lesion, because it's very tricky. There are multiple ring enhancing lesions and multiple differentials. They will give you the history of high fever plus a ring enhancing lesion. Also, they can show you diffusion restriction. We have already discussed about diffusion restriction. So this is particularly your pyogenic abscess. A very smooth wall, you can see, a smooth wall with diffusion restriction. This is your pyogenic bacterial abscess. We'll discuss about all the ring enhancing lesions, don't worry. This is some important spotter images first we are covering. So here you can see, yes Nikki, it's an abscess. Now, if you see this particular image, again, I will give you a history that the patient is a newborn with sensory neural hearing loss. You are able to see some periventricular calcifications over here. Okay, so this is characteristically your CMV infection, right? This is your cytomegalovirus infection, characteristic periventricular type of calcifications in a newborn with sensory neural hearing loss, right? Now, another history which you can get is that the patient is also having polymicrogyria. So this is, they will see what happens in polymicrogyria. The gyri which are there, they will be multiple. They will be multiple folding appearance. So gyri will look like this, something like this. So that is polymicrogyria, and that is also characteristically associated with CMV infections, right? Which other virus will also show this polymicrogyria? So that is your Zika virus. They can also show polymicrogyria. So this is little an extra edge point for you guys. And apart from this, of course, you can get microcephaly. Now, if I talk about toxoplasmosis, what is the calcification pattern? You will get more of diffuse calcifications when I talk about toxoplasmosis, but you will also get hydrocephalus in toxoplasmosis. So that is a little differentiating point in toxoplasmosis. There is hydrocephalus and diffuse calcifications. In Zika, again, you can get microcephaly. As I already said, you can also get polymicrogyria, but you can get cortical and subcortical calcifications rather than periventricular calcifications, which we see in CMV. In the Zika virus, you will get cortical and subcortical calcifications. Here's Nikki, right? CMV. Right. Now, what about this particular image? This is again a very characteristic image. I will tell you that the patient is coming with fever and altered sensorium. And if they are showing you bilateral involvement of what are these lobes? These are your temporal lobes. What are these lobes? These are your basifrontal lobes. Bilateral, I would say asymmetrical. You can see that the lesion is more on the right, little bit less on the left. This is flare image. You are able to see that there is hyperintensity. And you are also seeing that there is some enhancement. So there is some encephalitis that is going on. What are we talking about? We are characteristically talking about the HSV1 encephalitis or herpes simplex encephalitis, right? So here you will get this classical history of altered sensorium. Sometimes they will also give you that the patient is having seizures. This is a hemorrhagic necrotizing encephalitis. Remember that this is asymmetric involvement of medial temporal lobe as well as the inferior frontal lobes. Japanese encephalitis, just in a moment we are going to cover, Nikki. Okay, so what about the treatment over here? So treatment over here will be, see, whenever a patient is coming and you are suspecting, Okay, I will not wait for doing a lumbar puncture. If you are seeing this particular imaging findings plus a clinical diagnosis is there, I will immediately start my patient with acyclovir. Immediately I will start with acyclovir. I don't want any life-threatening complications to happen. I will immediately start my treatment with acyclovir in these patients. But the most sensitive investigation, if I want to confirm that this is HSV encephalitis, see this appearance you can also get with autoimmune encephalitis, okay, involvement of temporal lobe. So to confirm it, definitely I will have to do a lumbar puncture. On lumbar puncture, you can do a PCR, right, for the HSV1 virus. And apart from this, on the lumbar puncture, on the CSF, you will also get one more finding. You will also get xanthochromia, right? You will also get RBC because it's a hemorrhagic pathology. So you will also get RBCs in the CSF, right? Now let's talk about these two images. Here, first image, I am giving you a history that the patient is having rapid dementia. This is the history I'm giving, and you, as I've already discussed, thalamus are involved over here. So bilateral thalamus may there is a pathology, there is a hyperintensity in the flare, and clinical history is that the patient is having dementia. What is this pathology? Please think and please write it in the comment. So this is characteristically your variant CJD or prion disease. This is your variant CJD or your prion disease. You will get this characteristic pulvinar sign or the hockey stick sign. Why do you get pulvinar sign? Because of the involvement of the pulvinar nuclei over here, right? And if there is also involvement of the dorsomedial, okay, dorsomedial part of the thalamus, this will look like that of a hockey stick. So that is why it is called as a hockey stick sign, but this is particularly seen in the CJD or the prion disease. Right now, what about this image? I am giving you clinical hints that the patient is coming to you in monsoon. I'll say particularly a young patient, monsoon, history of a mosquito bite, an altered sensorium as well as fever. What is this characteristic history? You can see again there is hyperintensity involving bilateral thalamus. So look at the clinical history, okay? Both dono mein thalamus is involved. But the characteristic history of altered sensorium, fever and encephalitis is given to you in this. We are talking about your Japanese encephalitis in which there is involvement of bilateral thalamus, right? So this is particularly caused by a flavivirus. Okay, the JE virus, Japanese encephalitis is a flavivirus, and it is particularly caused because of the Culex mosquito bite, right? So I hope this is clear to you. Now moving towards the ring enhancing lesion, a quick revision. See, pyogenic abscess we have already discussed. You will have a smooth ring enhancing lesion. Patient having fever, altered sensorium, plus it will always show diffusion restriction. What about GBM? So GBM will have this irregular type of border, right? They may also involve the corpus callosum, and it will give rise to this characteristic butterfly appearance because it is going to cross the corpus callosum. But the most important thing is that the wall, it is not smooth and well defined. It will have a very irregular type of a solid type of a wall in GBM. NCC we have already discussed. They will always test you for with the cyst with this type of an appearance with, I would say, dot in hole appearance, right? Dot in hole appearance. Whereas for tuberculomas, they can always show you, again, a ring enhancing lesion will be present, but the characteristic differentiating point of tuberculoma is that on T2 weighted images, it will have a caseous center, right? Because of the caseous material, what will happen? Almost all the lesions show T2 hyperintensity. But tuberculomas which are there, they will show a T2 hypointensity because of its caseous center. Right? And another important thing is if they ask you, they can ask you for an MRS peak. So what MRS peak you will get in tuberculoma? You will get a lipid lactate peak. You will get a lipid lactate peak. Okay. Now again in demyelination, I would say acute demyelination. In acute demyelination of multiple sclerosis, you can always get an open ring type of a enhancement pattern. So this ring which is there, it will be mostly pointing towards the cortex. But remember that it is not a complete ring, but it will be usually an open ring, especially in the acute demyelination stage of the multiple sclerosis. And metastasis, it's very easy. They are usually multiple, and they are characteristically present at the gray matter and the white matter junction. That is the characteristic location for the metastasis. So look for the clinical hints which they will give you in the question and the characteristic appearances for this various ring enhancing lesions. Okay. Now, if I talk about this, again, ring enhancing lesions in an HIV patient. Okay, again, this was a previous year question. This was asked recently in INICET also. So very important, you are able to see that there is a ring enhancing lesion. I'm telling you that the patient is having HIV, and this is a single lesion that you are seeing in the periventricular deep white matter. This is characteristically your lymphoma. This is your lymphoma. What about the second image? You are getting, see, you will get a history of, say, fever and altered sensorium over here. But what is this image? Try to answer. You are able to see multiple ring enhancing lesions, especially I would say these are present in your gangliocapsular region, and there are multiple lesions. Okay, sometimes you will also see this eccentric target sign, a lesion that will also show not only ring enhancing, but there is a nodule that is present that will be showing this eccentric target sign. What is this? This is your toxoplasmosis. This is your characteristic toxoplasmosis. So this is the differentiating point between your lymphoma and toxoplasmosis. Now, another important thing is that the lymphoma will always show diffusion restriction. And if I talk about the thallium and the FDG PET scan, they will be, because they are more cellular, so they will obviously show a positive thallium scan as well as a positive FDG PET scan. Right? So I hope all the ring enhancing lesions are clear to you. If there is any doubt, you can just definitely ask me. Now, what about this particular pathology? So here you are again seeing some periventricular calcifications, and they will always give you some hint when they are testing you for this neurocutaneous disorder. I will say that the patient is a young patient presenting to you with mental retardation and seizures with periventricular calcifications. What I'm talking about, these are your subependymal nodules, which are characteristically seen with tuberous sclerosis. And which tumor will present in the tuberous sclerosis? At the foramen of Monro, this over here between the two frontal horns, if there is a lesion that is present that is showing enhancement, we are talking about the subependymal giant cell astrocytoma, characteristically seen with tuberous sclerosis. What are the things you will get in tuberous sclerosis? A quick revision. You will get lymphangioliomyomatosis. You can get AML. You can get AML means angiomyolipomas in the kidneys. And of course, you can get multiple cardiac rhabdomyomas as well. Right? So that is all about your tuberous sclerosis, a quick revision. What about this pathognomic image? Bilateral acoustic schwannomas. And on an MRI image, if they are showing you, they are characteristically testing you for only one pathology, that is neurofibromatosis 2. Right? So you will get bilateral acoustic schwannomas. Now, important thing regarding acoustic schwannomas is that there will be other lesions also that can be present, and the mnemonic is MIS-ME, which is multiple meningiomas, multiple schwannomas, and multiple ependymomas, right? Nikki, I hope this is clear. So you are quite good. You are answering almost all the questions. So I think you are well prepared. And if I talk about neurofibromatosis 1, you will get bilateral optic glioma. So don't get confused. Bilateral acoustic schwannomas will be NF2. NF1 will be bilateral optic gliomas. You will get both optic nerves that will be enlarged, maybe giving you an image that will be showing contrast enhancement, right? Yes, ice cream cone appearance for your acoustic schwannomas, right? Now, what about this particular pathology? Here you are able to see that there are some tram-tack calcifications that are seen into the brain parenchyma, right? And you can sometimes also see that this particular part of wherever there are tram-track calcifications, even in the skull, you can see there is an associated atrophy that can be present. So what I'm talking about, I'm characteristically talking about we are talking about your Sturge-Weaver syndrome. So this is your Sturge-Weaver syndrome that will give rise to your gyriform type of calcifications, right? This will be also, how will the patient present? They will present with port wine stain, or they will also present. So what is this? What is the main pathology in Sturge-Weaver? It is your leptomeningeal angiomatosis, right? And you will get this characteristic port wine stain, especially in the maxillary, ophthalmic, or the mandibular divisions of the trigeminal nerves on the face, right? I hope this you can recall this. So this is a I have not included the image, but these are the characteristic radiological images of the neurocutaneous syndromes. And again, this is very high yield, can be tested. Right now, what about some important brain tumors? Let's quickly revise about some important brain tumors. The first image, you are seeing this butterfly. You are seeing this, I have already told you about. Again, you can see that there is an irregular peripheral enhancement pattern. And you are getting this characteristic butterfly appearance. So this is for GBM, okay, involving the corpus callosum. Which other lesion can also cross the corpus callosum? It is your lymphoma, okay, that can also cause the corpus callosum. Now, what about this lesion? You are seeing that there is an extensively calcified mass, more commonly in the frontal lobe. It is particularly, I would say, a cortical tumor rather than a white matter tumor. So, cortical tumor calcification most common in the frontal lobe. Which particular tumor I am talking about? Oligodendroglioma. So this is your oligodendroglioma. On histopathology, you will get the characteristic fried egg appearance, right? So that is about your oligodendroglioma. What about this particular lesion? The third lesion you are seeing is that there is a soap bubble lesion that you are seeing. The classical history that you will get is that patient is a young patient presenting with epilepsy, and it's a drug resistant epilepsy, not responding to drugs. You're seeing the soap bubble lesion in the cortex, maybe in the frontal lobe, maybe in the temporal lobe. What are we talking about? Characteristically, which lesion will show this appearance? This is your DNET tumor. This is your dysembryoplastic neuroepithelial tumor, very classical cortical tumor. Yes, Ritik, Nikki, good, oligodendroglioma. So I am going little ahead of you. I'm little few minutes ahead. So good, I'm appreciating that you are answering. Right, so this is your DNET tumor. Now, what about this particular lesion over here? You're seeing that there is a lesion in the cerebellum giving you a characteristic tigroid appearance, right? So this tigroid appearance, you're seeing this alternate black and white appearance, right? So this is, what is the abnormal part? The white part is abnormal. The left, the black part which is there, it is a residual cerebellar folia. Your cerebellar foley are enlarged in this particular pathology. I would say that this is not a true brain tumor. It is rather a hematomatous growth. So what I'm talking about your Lermite-Duckler syndrome, right? It's a benign hematomatous syndrome, also called as a dysplastic cerebellar gangliocytoma, right? Now, if I talk about the syndrome it is associated with, and they can give you in the question, it is associated with Cowden syndrome. What is the mutation? It's a P10 mutation. And if I talk about the other lesions that you will see in Cowden syndrome, you will get multiple GIT polyps, right? You can get hematomatous polyps again, mucocutaneous pigmentation, and which cancers you will get? You'll get breast cancer, thyroid cancer, and endometrial cancer. So very important, all the clinical hints which I have included, very high yield from your MCQ point of view. So we have just integrated this with your surgery. We have the Cowden and the P10 mutation, and if together it is present, right, it is also called as a cold syndrome, right? It is called as a cold syndrome, Cowden syndrome with Lermite-Duckler syndrome. So that is about your dysplastic cerebellar gangliocytoma, not a true brain tumor, a hematomatous growth. Now again, you can see that there is a posterior fossa tumor. I will give you the hint that the patient is a pediatric, and you can see that overall how this particular mass is very hyperdense on the CT. Hyperdense means it's highly cellular. Highly cellular means it will be also showing good amount of diffusion restriction. This is particularly arising from the roof of the fourth ventricle. And in a pediatric patient, the most common malignant tumor we are talking about is a medulloblastoma, right? So this is your medulloblastoma, a hyperdense lesion showing diffusion restriction. And most important thing is that once you diagnose it, what is the next step? You will always go for spinal imaging. You will always go for spinal imaging. Yes, med moments, right? P10, thyroid, endo, breast, and mucus, good. Now, if I talk about your drop metastasis, what is this drop metastasis? It will give you the sugar coating type of an appearance. So what happens is that there is a CSF dissemination or leptomeningeal metastasis commonly seen with these tumors, highly cellular tumors. It's a small blue round cell tumor. What other pathology will also show you drop metastasis? It is seen with lymphoma. It is also seen with germinoma in the brain. So in all these particular tumors, my next step will be always to do an MRI spine to rule out leptomeningeal metastasis. Now, what about this particular lesion over here? This is in the suprasellar location. You are getting this characteristic cystic and a calcified appearance. So what I am talking about? I am talking about a craniopharyngioma. Can you tell me the type of craniopharyngioma? Whether it is a adamantinomatous type or a papillary type. So a calcified one, a cystic and a calcified lesion, it is always a adamantinomatous type. It's cystic plus calcified. What are you going to get on histopathology? You will get wet keratin as well as the cholesterol in the adamantinomatous type. So adamantinomatous type is more commonly seen in the pediatric age group. It is more commonly in the pediatric age group, whereas if I talk about papillary, they are more common in the adults. And you will get this characteristic solid and a contrast enhancement that doesn't show calcification. So that is your papillary type. Right? So this is an adamantinomatous type. Now there is another important tumor that is located in the sellar region involving the pituitary. I will give you the classical hint that the patient is having bitemporal hemianopia presenting with this characteristic snowman appearance, right? So what will happen in the snowman appearance? What is this? Because of the constriction at diaphragmatic sella, we are talking about your pituitary macroadenoma, right? To classify as a pituitary macroadenoma, the size which is there, it is more than that of 10 mm or more than that of 1 centimeter. So that is about your pituitary macroadenoma giving a snowman appearance. I hope this is clear. Now again, we have discussed the sagittal anatomy also. You know that there is a, what will happen over here? This particular area, there is a lesion that is present over here just below the thalamus. This is in the hypothalamus, right? Now you are seeing that there is a non-enhancing mass in the hypothalamus. So this is a hypothalamic hematoma, and you will get the characteristic history of gelastic seizures over here, right? And apart from this, you can also give a history of precocious puberty. So particularly these are seen in young male patients with characteristic history of precocious puberty, gelastic seizures. This is a hypothalamic hematoma. Look at the characteristic location just below. This is your thalamus, right? This is your thalamus just adjacent to the third ventricle, and you will be seeing a hypothalamus just below the thalamus. That is your hypothalamic hematoma, right? Okay. Now, if I talk about your various pineal gland tumors, again, we have already discussed this when we were discussing about the sagittal anatomy. So, if your lesion is somewhere over here, right, this is your pineal gland, right? Don't get confused between hypothalamus, optic chiasma. This part is optic chiasma, and this particular part over here, this particular part, this is your pineal gland, right? So if there is any lesion in the pineal gland, it is going to compress the superior colliculus in the midbrain. So that will lead to upward gaze palsy, and that will present as peri-nod syndrome, as the peri-nod syndrome. Okay, so I hope this is clear to you, right? Now let's move towards the most common tumor of the brain. I would say most common in general, it's the most common tumor. So this is everyone's favorite. This is meningioma. It's an extra-axial tumor, not intra-axial. Extra-axial tumor that can also show you characteristic dural tail sign. Okay, it will show a dural tail sign. Now, apart from this, what is the most common location? So most common location, as you can see also over here, it is parasagittal. See, along the falx. Okay, the falx is in the mid part, right? And if you see a enhancing lesion just adjacent to the falx, that is most commonly a meningioma. Another place where you will find this meningiomas is in the CP angles. But in CP angles, remember that the overall most common tumor, the ice cream cone appearance, we have discussed schwannoma. So schwannoma is more common in the CP angle, followed by meningioma. And what about the other lesion, E, which is there? It is your epidermoid cyst. That is your epidermoid cyst, right? Now, if I talk about the syndrome, again, this we have discussed. Which syndrome will be showing you multiple meningiomas? It is your neurofibromatosis type 2. It is neurofibromatosis type 2. Now, what about the Samoma bodies? So, you know that in meningiomas, you are going to get Samoma bodies. Okay. And apart from this, you will also get Samoma bodies. So, what are Samoma bodies? Lamellated areas of calcification, right? On the histopathology, you will get it in mesotheliomas. Where else you get? Very high yield question. So, I have included this. So, you will also get in the papillary carcinoma. Okay. Anyone wants to answer? What is the S? I think I'll wait. You will get it in serous. Yes, you'll get it in the serous cystadenoma. So these are the places where you are going to get your Samoma bodies. Now, another important thing is what other sign you will get with this multiple meningiomas. You will also get your mother-in-law sign, right? The contrast which is there, it is going to come early and then it is going to retain for the late. So that will be called as your mother-in-law sign. And sometimes you will get this characteristic history of the spoke wheel pattern of enhancement. That also you can get in the Samoma bodies, right? So that is about this. Yes, med moments correct. Meningioma risk factor is radiation. One more tumor that can develop secondary to radiation is your GBM. That is your GBM, right? Yes, Ritik Soni, serous cystadenoma. Perfect, right? So all of you are well prepared. I'm happy. Now you can see this particular lesion, CP angle, my third lesion, third most common tumor, I would say. So this is characteristically showing a diffusion restriction. You can see that the hypodense mass showing diffusion restriction. What I'm talking about, I'm characteristically talking about an epidermoid cyst. Okay. So epidermoid cyst has this characteristic ability to show diffusion restriction because of its thick keratinaceous debris, in contrast to arachnoid cyst, because arachnoid cyst will never show diffusion restriction. That is the differentiating point between these two important pathologies. So I hope this is clear. A very important spotter image could be tested. Now, if you see this particular tumor, again, two classical spotters, I am sure everyone must be knowing this. This is your famous eye of the tiger sign. In which pathology you see this eye of tiger sign? What is the pathology over here? You can see that there is a blackish area in the globus pallidus. Okay, so this particular area which is there, it is your putamen. This particular area is the globus pallidus, and black area in the globus pallidus is nothing but your iron deposition. So this is your Haloverden-Spatz disease, which was an earlier name. Now we are calling it as a PCAN, which is pantothenase kinase associated neurodegeneration, and it is actually an NBIA, which is neurodegeneration with brain iron accumulation. So this is your characteristic eye of the tiger sign. And what about the face of a giant panda sign? Where will you see? Again, everyone knows this. I'll give you the clinical hint that the patient is having liver cirrhosis, or there are case of Fleischer rings in the question. So this is your characteristic Wilson disease. Now, what is the pathology over here in the Wilson disease? What is the pathological part? You can see in the midbrain, this white part, that is basically your tegmentum, right? So that is abnormal. That is going to show this hyper intensity. And apart from this, you are able to see this black part over here. The ears which are there, they will be formed by substantia nigra. If you see the eyes, it is going to be formed by the red nucleus. It is going to be formed by the red nucleus. And if I talk about this particular part over here, this is your superior colliculus, right? The mouth is formed by the superior colliculus. So I hope this is clear to you. This is your Wilson's disease, characteristic history you will get. Now, important thing is that the most common site where you will first see this T2 flare hyperintensity, that is your putamen. And that is why the patient will all present with dystonia or sometimes of tremors, something like that of history can be given with a putaminal hyperintensity. That is again for Wilson's disease, right? So I hope both these images are clear. Now, quick word on MRS. A very quick revision will do. You need to know that this is a normal MRS. What is this? X-axis is the ppm, which is parts per million, which is actually the frequency shift, which is characteristic individually for every molecule that would would be different, and that you will plot on the x-axis, whereas the y-axis which is there, it will give you an idea about the concentration of these molecules. Normally NAA which is there, it is the marker of neuronal integrity of the neurons, so it is always at a high level that is present, right? So if you see, if you draw an angle, right, this is present at 2 ppm. So remember, the two A's are present, so it is at 2 ppm. And if you see at this particular concentration, you can see that the angle that is formed over here, it is approximately 45 degree from the horizontal. This is a normal Hunter's angle. This is the normal Hunter's angle. What will be present at 3 and 3.2? So remember, creatinine and choline, these two you have to remember. So if I talk about E and O, remember that E comes first. So this will be at 3. If I talk about choline, O comes later. So this will be at 3.2. Apart from this, we have also got glycine and glutamine. That will be again very near to 2 at around 2.2. At around 2.2. So that is a quick revision. So whenever there is any brain pathology, maybe say any particular tumors that will be present over here. Okay. So if there is any particular tumor, the NAA level are going to decrease, right? So that is the main funda. But there is one pathology that is going to show an elevated NAA, only one pathology, and that is your Canavan's disease. Okay. Again, can be tested, very important. That will be your Canavan's disease. Right. Now, if I talk about the other important MRS findings, so quick revision, 0.9 to 1.4 you get lipids, 1.3 you will get lipid lactate. So remember that these are products of brain destruction and anaerobic glycolysis. So you will get this characteristic peak in tuberculomas, okay. And apart from this, you will also see in the GBM that will be having a necrotic center. Okay, NAA we have already discussed about. The neuronal marker decreased in almost all the brain pathologies except for the Canavan's disease. 2.2 to 2.4, that will be glutamine as well as glutamate. It is going to increase in hepatic encephalopathy. I have seen in encephalopathy, right? Now, if you talk about your 3 and 3.2, that is creatinine and choline. So choline again is important because that will be indicating a cell membrane turnover. So whenever there is any highly cellular tumor, like for an example, say medulloblastoma, or if I talk about lymphoma, that will be always showing an elevated choline. So there will be a reversal of your NA. NA will decrease, choline will get elevated in any brain tumor. Okay, and again, creatinine is not used individually per se, it is always used as the ratios, right? Like we use as choline to creatinine ratios, which is going to increase whenever there is a highly cellular brain tumor. Now, if I talk about 3.5, it is mainly myoinositol. That is again a marker of osmolyte. It's a glial cell marker. Okay, so just remember 3.5 is myoinositol. Now, meningioma, what is a marker which we will see in meningioma? Let's see if any one of you can answer. So, meningioma mein which particular molecule is going to show the peak? I'll give you a hint. It is at 1.48 ppm. Okay, I'll just wait for you fast. Can someone answer? It's a very high thing, could be tested. So I think I'll answer, it is alanine peak. Okay, it is alanine peak that you will get in the meningioblastoma. Okay, sorry, in meningioma. And medulloblastoma you will get taurine peak. Again, that is a little extra edge. So in medulloblastoma you will get taurine peak. Okay, so these are some important, I would say some rare ones. So that is why I'm teaching you this one, right? Now, if you talk about this particular image, this is a DSA image, a characteristic, it's resembling like that of a puff of a smoke. So this is a puff of smoke appearance, and where will you get this puff of smoke? This is characteristically seen with Moya disease. Okay, and it is usually seen, see, it can be idiopathic, right? We don't know the cause, that is the primary, but secondary it can be seen with this classical clinical hints. Look for the question neurofibromatosis 1 or prior radiation history of the, or if there is a Down syndrome also, it can be seen. Why this occurs? Because of the obstruction, because of the narrowing of the supraclinoid ICA that will lead to the opening of your lenticulostriate vessels, right? So that will be a Moya disease. And what about this? This is again a very characteristic spotter image, could be tested. A midline cystic pulsatile mass. If you are seeing on a sagittal brain image, if you are showing you this image, they can also show you a fetal ultrasound with a cystic malformation, right? And extremely in the center, very important. This is nothing but your vein of Galen malformation. So this is your vein of Galen malformation. Now, if I talk about the vein of Galen malformation, it's actually a misnomer, I would say, because it is the persistence of what? Your median prosencephalic vein, right? The persistence of the median prosencephalic vein will lead to the opening of multiple arteriovenous feeders, right? And multiple arterial feeders are directly opening in this venous channel. So it's type of an AV fistula, okay? And that will lead to this extremely pulsatile cystic mass, extremely in the center. Right now, if I talk about the cause of death, so again, this could be tested. It is high output cardiac failure. It is high output cardiac failure. That is the cause of death, right? So this is all about your neuro. Okay, we have covered almost all the important pathologies, and let's move towards a little bit of ENT. We are covering very briefly. So two important classical X-rays. So if I talk about the classical X-rays over here, what are you seeing over here? I'm giving you the clinical hint that the patient is having a muffled hot potato voice, a tripod positioning is there, and then there is drooling of saliva, and you are able to see a soft tissue opacity, right? What is this particular thing? Right, yes, med moments, it's heart failure. So you can see over here that there is a prominent swelling that you are seeing, prominent soft tissue. This is nothing but your epiglottis. So this is also called as your thumb sign. This is characteristically seen with H influenza B virus involvement of the epiglottitis. This is your thumbprint sign because of this prominent epiglottis, right? That is going to indent on the trachea. So that is one sign. Now, what about this particular sign? You are seeing that there is a narrowing. There is a extreme narrowing you are seeing in the laryngotracheal region. This is nothing but a steeple sign, right? So this is the characteristic. The patient over here is relatively comfortable, but the patient has barking cough. So yes, Nikki, it's acute epiglottitis. So what are we talking about? We are characteristically talking about your laryngotracheobronchitis, or we can also see it as the croup. Okay, this is also called as the steeple sign, and it is seen with characteristically para-influenza virus signs. Yes, Ritik, perfect. Yes. Yes, so these are the two classical spotter images which are tested. Now mucormycosis, we have already discussed. What we discussed the reverse halo sign, right? Now they will give you the classical history of facial plane, black nasal discharge, and then there is diabetes mellitus. What I was talking about, you are seeing this MRI image. This is a post-contrast MRI images. Normal turbinates are enhancing. Okay, you can see that how the normal turbinates are enhancing over here. But if you see this particular area, the turbinates are not enhancing because of invasion by a particular fungus over here, and that has led to severe devitalization and necrosis. So what are we talking about? We are talking about the black turbinate sign that is characteristically seen with mucormycosis, right? So this is a black turbinate sign. Again, this was tested previously. It's a black turbinate sign, not enhancing because of necrosis and devitalization. Right, now moving towards our next section, and that is the GIT radiology. Again, we have covered almost all the important images. So let's start. First of all, a quick revision of what are these investigations. So first investigation, what is it? You are able to see all the small bowels. How did I identify? Can you see this particular jejunal loops? They will be having this characteristic feathery appearance because of the valvula conniventes, right? So what are we talking about? This is nothing but your barium meal. Okay, so this is your barium meal. What about the second image? You are able to see the esophagus, right? Up to the stomach, up to the GE junction. So that is your barium swallow. That is your barium swallow, right? Now, if you see the third image, you are able to see the entire colon, right? In the colon, what you will get? You will get multiple haustra that will be well defined. They will be well spaced as compared to the valvula conniventes that will be showing you this feathery appearance. So this is how you will differentiate between the colon as well as between the jejunum. So that is your barium enema. This is your barium enema, right? So this is the identification. Just remember that barium which is there, it is water insoluble. You will always never give IV. Okay, never give the barium IV. The only contraindication, okay, what is the contraindication and commonly tested? That is perforation. So if you are suspecting any leak or perforation, you will never ever give barium because that can lead to barium peritonitis. Right? I hope this is clear. Now moving towards some important barium pathologies. The first image, you are able to see the clinical hint is that the patient is presenting with dysphagia and halitosis. And you are able to see that there is the posterior outpouching from the esophagus. So what are we talking about? This is nothing but your Zenker's diverticulum. This is your Zenker's diverticulum. Right? Now if you see the second image over here, you are able to see that there is a smooth narrowing over here, right, of the barium. So this is your achalasia cardia. Characteristically, what is this? This is your bird beak appearance. This is your bird beak appearance. Now what about this? So gold standard is, of course, you have to measure it with the manometry. Now what about the third image? You are able to see that there is an irregular type of a growth that is present in the lower esophagus, right? It is looking like that of a rat tail appearance, right? So this is basically your esophageal carcinoma. This is your esophageal carcinoma. And fourth image which is there, it is your characteristic. You are seeing this corkscrew appearance. So the corkscrew appearance you will see with intermittent dysphagia, right? This is characteristically, again, the history which is there you will get for liquids and solid dysphagias along with the chest pain. We are talking about what? We are talking about diffuse esophageal spasm. Okay, we are talking about your diffuse esophageal spasm. Corkscrew esophagus appearance. Okay, so I hope this is clear about your important barium pathologies. Now identify this. Okay, so just the gold standard for this particular investigation is definitely your manometry. And if I give you one more classical hint, In which pathology will you see a patulous G junction in which the G junction is widened? So you will see this in characteristically with scleroderma. Okay, you will see this in the scleroderma in which your GE junction and the esophagus is dilated. Okay, now let's talk about this investigation. What is this investigation? Can you identify? This is a CT image. But what is this investigation? Can you see the bowel? The bowel which is there, it is fluid filled, right? It's look like that we have given some fluid in the bowel so that they are well distended so that you can appreciate the wall after giving the contrast very well. So this is nothing but your CT enterogram. Okay, if I want to see TB, Crohn's, ulcerative colitis, such ulceroconstrictive diseases, I will do a CT enterography in which I will be giving my patient what particular thing I will be giving? I will be giving a neutral contrast. Okay, neutral contrast means that follows water. HU of water is what? 0. Okay, so mannitol or polyethylene glycol, something like that I will give for the distension of the bowel. So this is an important investigation which they can test, right? So this is an enterogram. Now just a quick revision, single bubble sign where you will see it in congenital hypertrophic pyloric stenosis. Okay, this is on an X-ray. Okay, sometimes they will show you this X-rays of characteristic. I have not included the image. I'm sure everyone knows that. So single bubble will be seen with CHPS, double bubble you will see with duodenal atresia, annular pancreas and with the land bands, and the triple bubble sign you will see it with the jejunal atresia. Right, so these are the classical X-ray signs you will get. Okay, now what about this particular pathology? I'll just zoom it over here. Okay, so this is I will give you that the patient is coming with severe, it's a pediatric patient coming with abdominal pain and red currant jelly stools, right? So this is a characteristic history for intussusception. Telescoping of the bowel occurs, right? So because of this bowel within a bowel appearance, they will produce some characteristic signs on your barium enema images. The first image you are able to see over here, can you see this? This is a claw sign. Okay, or it is also called as the meniscus sign because of the telescoping of the bowel. Okay, so that will give rise to this claw sign. What about this? Now here you can see again there is a filling defect that you will see in the bowel. What is this? There is a trapping of the contrast that is happening into the intussusceptum as it is moving. So what is this sign? Yes, it's intussusception. Everyone knows this. I'm asking you about the signs. Okay, so this is your coiled spring appearance on the barium enema image. This is a coiled spring appearance, right? Now if you see the ultrasound, what is this particular sign? You are getting this characteristic hyperechoic and hypoechoic layers because two bowels are there. So you are able to see on the cross section, if I do an axial imaging within ultrasound, you are able to see the bowel walls of two bowels, right? Intussusceptum and intussuscipiens, right? So this is your target sign. This will give rise to your target sign. Okay, so that is all about these particular signs that you will see in the intussusception. Right, now moving towards our next important image. Again, this is like a bread and butter image. So this is, you will see that the classical history you will get is a young patient. Right, a young patient is there, and if you are able to see that there is a large dilated loop, particularly that will be with an apex that is facing towards the left upper quadrant. What we are talking about, this is also producing a sign which is called, it's looking like that of an embryo, right? So this is also called as an embryo sign, or some people also say it as a comma sign. So this is particularly your cecal volvulus. This is your cecal volvulus. But if they give you a classical history that the patient is an old patient who is having chronic constipation as well as dementia, as well as the patient is in a nursing home, some sort of this history is given. And if you are seeing that the apex over here is pointing towards the right upper quadrant, right, a coffee bean sign is seen, right? This is characteristically your sigmoid volvulus. Management kisme, what will you do in the sigmoid volvulus? What is the management surgery in which particular volvulus, cecal or sigmoid? Okay, the very important in the cecal volvulus, it is important that you will be proceeding with the surgery. You have to do a surgery, a cecopexy has to be done. But if I talk about the sigmoid volvulus, the first step which is there, it is usually, unless it is complicated or it is perforated, you will do a decompression type of sigmoidoscopy. You will do a decompression sigmoidoscopy. So this is an important difference, and that is why you have to identify. Okay, always match with the clinical hints which they are given in the question. Now moving towards our next image, you are able to see that patient is admitted in the ICU for sepsis. So they are giving you a hint that the patient is in ICU for sepsis, means that the patient is on some antibiotics for a very long time, right? So if the patient is in antibiotics for a very long time, what pathology will occur in the colon, especially if the patient complains of abdominal pain or hematochezia? We are talking about your pseudomembranous colitis. We are talking about pseudomembranous colitis. Characteristic antibiotics which will be given in the question will be your clindamycin, CCF, clindamycin, ciprofloxacin, okay, as well as chloroquinol. So this broad spectrum antibiotics will be given to you, and the management will be either vancomycin or fidaxomicin. And if it is recurrent, then you will be going for what? You will go for a fetal microbiota transplant, right? And if it is complicated, suppose there is a toxic megacolon, transverse colon more than 6 centimeter, right? Or if I would say that it has perforated, in that cases you have to do a surgery. So what sign you are getting over here? You are seeing that very thick hostra are there, barium are entrapped between these particular hostra. You are producing this characteristic accordion sign. This is the accordion sign of pseudomembranous enterocolitis. Okay, now quickly revise with me the WHO classification. So remember that the WHO classification for hydatid cyst, okay, we do not follow Garbi anymore. Maybe they can ask you for your MCQs, but I think that WHO is more important. It is going to give you the ultrasound appearance, okay, 1 to 5, and apart from this, it will also indicate what is the stage, whether it is active, transitional, or inactive. So we do a very quick revision. If I talk about the type 1, which is there, it is usually a unilocular sign. A unilocular, if you see a simple cystic lesion, okay, a simple cyst, then that is your type 1. Okay, remember type 1 and type 2, which are there, they are your active stage. The type 2, which is there, what you will get? The type 2 you will be getting over here will be your honeycomb appearance or your multi-septated type of an appearance. So honeycomb and multi-septated appearance that you will get in type 2. If I talk about type 3A and type 3B, what you will get in 3A, you will get the water lily sign because of the detached membranes, whereas in 3B, you will get multiple daughter cysts that will be arranged in a solid matrix, right? So that is about this particular 3A and 3B, and remember these are your transitional stages. Now if I talk about your type 4, this will be your inactive stages, in which CE4 will be your heterogeneous so what happens over here in type 4, it will become more of a solid appearance in which there will be no daughter cyst, but you will see this thickened debris type of material, that is your type 4. Whereas type 5, you will have this calcifications and calcified wall, that is your type 5. So both 4 and 5 are inactive stages. So remember when I talk about the management, so pair management, puncture, aspiration, instillation of ethanol or hypertonic saline and reaspiration, this will be done in CE1 and CE3A. Whereas if I talk about the surgery, that will be mainly done in the CE2 and the 3B stages, right? So that is about this important revision about your hydatid cyst, okay? We prefer nowadays WHO, that will be giving you an idea about not only the appearance, but also about the stage of the hydatid cyst. Okay, now moving towards some another important ultrasound pathologies and CT pathologies. What you are seeing over here, you are seeing that this is a gallbladder, right? On an ultrasound image, you are seeing that there are multiple stones that are present that are showing you posterior acoustic shadowing. But apart from this, can you see this particular wall? The wall is also extremely thickened. So if the wall is extremely thickened, this is actually an acute calculus cholecystitis, right? So the wall thickness is usually more than that of 3 mm. Now, if I talk about the Murphy's sign, right, that will be positive clinically. You will have this ultrasound finding, plus you will be also having pain. And apart from this, what happens is that if I talk about the HIDA scan, the most sensitive investigation to diagnose an acute cholecystitis is actually the HIDA scan. You will see that there is non-visualization of the gallbladder on the HIDA scan after 4 hours. After 4 hours, and that will be diagnostic for an acute cholecystitis. Now, what about the second image? What are you seeing over here? You are seeing that there is air that is present in the gallbladder wall, right? So what I'm talking about emphysematous cholecystitis. So they can also show you an X-ray over here. So this is nothing but your emphysematous cholecystitis. This is your emphysematous cholecystitis. The best investigation, as I've already told you, the best investigation to see the air, will be always an NCCT, Any ectopic air, it will be NCCT. Ultrasound is a very bad modality to see your air. Now, what about this particular pathology? You are able to see that there are multiple hyperechoic areas that are present in the gallbladder wall. What I am talking about, this is nothing but a comet tail sign, and this is seen with the GB adenomyomatosis. Okay, so this is mainly because of accumulation of the cholesterol crystals that will be present in the Rokitansky-Ashoff sinuses, and that will give rise to this characteristic reverberation artifact because of the cholesterol accumulation, and that is your GB adenomyomatosis. Now, what about this pathology? You are seeing that the entire wall of the gallbladder is calcified. Okay, they can give you a CT. Again, CT is the investigation of choice to see this calcification, or they can also show you an X-ray. So this is nothing but your porcelain GB. Okay, a porcelain gallbladder. So remember that porcelain gallbladder, it is a pre-malignant condition. So you have to do a cholecystectomy. If you diagnose a porcelain gallbladder, right? So that is all about your important gallbladder pathologies. Now, what about this? This is a very good spotter image. You can see that this is an MRCP image, and you are seeing a very black linear type of a hypointensity, right? It's, if there was a stone, then it will look like a small dot, right? Like a calculus. But you're seeing a linear structure into the MRCP. So what is this particular image in the CVD? This is nothing but your ascariasis. This is your ascariasis, right? So this is characteristically ascariasis. Yes, Nikki, you are right. You are giving me all the correct answers, right? So if I talk about the next image, so biliary leak, as I have already told you, for the biliary leak, the most sensitive and the best investigation, if they ask you, it will be your HIDA scan, right? It will be your HIDA scan because it is more sensitive to pick up the small peaks, right? Now, if I talk about the ERCP, so this is an ERCP image. We have already discussed the ERCP image as we have started with the various investigations. Here you are able to see that there is a small filling defect that is present in the distal CBD, right? This is your CBD. Right, so what you are able to see, a small filling defect, this is nothing but your CBD stone. This is your CBD stone or choledocholithiasis on an ERCP image. If you see on an MRCP, how will it appear? It will appear black or it will appear as a signal void. As I've already told you that almost for all the biliary pathologies, gold standard is always the RCP because you can also do the management in the same setting. MRCP is usually the investigation of choice if I want to see the anatomy, right? Now, if I talk about this particular image, again, you can see over here that you are able to see that there is a beaded appearance of the various biliary radicals. So this characteristic rosary bead appearance, and also you can see that there is paucity. There is, in general, you can see that there is significant paucity of the biliary duct. So what I'm talking about, this is pruned tree appearance, and this is also characteristically seen with primary sclerosing cholangitis. So primary sclerosing cholangitis is characteristically seen with ulcerative colitis. It is classically associated with ulcerative colitis, and you can see this small strictures. There are multiple inflammation of the biliary tree that lead to multifocal strictures and areas of alternate dilatation that you will see with the PS, right? Okay, now moving towards some of the cross-sectional images. So if you can see over here, you are able to see that there is a peripheral nodular type of an enhancement. This is first of all a triple phase CT. You are able to see that there is an arterial phase image, a portal phase, and then we have also got a delayed phase image. You are able to see that there is a peripheral nodular discontinuous enhancement that is showing a centripetal progression on the delayed images. What is this particular pathology, characteristic pathology? You are able to see this is a hemangioma. Okay, this is a cavernous hemangioma, absolutely benign. Again, one of the common benign liver tumors that you will see. Right? Now, if you see this particular pathology over here, you are able to see that on the arterial phase image, you are able to see that there is a central scar. And if I see this particular central scar on a delayed image, it is showing contrast enhancement. So, scars usually will show a delayed type of a contrast enhancement. This is characteristically, I am talking about a FNH. Okay, I am talking about a fibronodular hyperplasia. Again, that's a benign lesion. And you will see this characteristic pattern of delayed enhancement of the scar. Okay, now what other pathologies will also show you scar? You will see it with fibrolamellar HCC. You will also see scars in oncocytomas in the kidneys, and you will see it in the serous cyst adenomas in the pancreas, right? So these are the pathologies where you will see this characteristic scar appearance, right? Now let's move towards our next pathology. I will give you a hint that the patient is alcoholic and patient is having an HCC. You can see that on the plane you are not able to appreciate any lesion. On the arterial phase, you are able to see that there is an enhancement, and then finally you can see that on the delayed phases and also on the portal venous phases there is a washout. Okay, so an early arterial enhancing lesion showing a washout on portal vein as well as the delayed phase images. This is characteristically seen for your HCC or your hepatocellular carcinoma, right? So this is about your various important pathologies on the triple phase CT. Right? Now let's move towards our next pathology. Here I am giving you the hint that the patient is having a right upper quadrant pain and fever, and you are able to see this again a ring target type of a lesion, but actually it's a double target appearance. You can see that there is a lesion, a rounded lesion over here that is hypodense. You are able to see that there is a hyperdense rim because of the granulomatous reaction that has formed this particular wall. When apart from this, you are also able to see that there is again a hypodensity surrounding it. That is nothing but your vasogenic edema. That is your vasogenic edema. So actually you are getting a double target sign. What I am talking about? I am talking about a liver abscess. I am talking about a liver abscess, right? So this is a characteristic liver abscess that will give you target sign. Sometimes you will also get cluster signs. What happens in the cluster sign for these amoebic abscesses or liver abscesses, you will get that multiple small hypodensities, they will actually be seen together and they will actually coalesce in order to form a larger abscess later on. So that is called as the cluster sign. Again, that can be seen with your various liver abscesses, right? So I hope all the signs are clear for your hepatobiliary pathology. A little bit about the pancreas. Of course, we cannot cover everything, but this is a classical X-ray which is tested. Multiple numerous calcifications, especially in the pancreatic region, in the epigastric region. This is characteristically you can see for chronic pancreatitis. You can see this with chronic pancreatitis, right? And if you can just revise with me the revised Atlanta classification. Sometimes they will give you this multiple collections on the CT image, but they will always give you some classical hints in the question regarding the age of that particular collection, right? You have to first of all identify necrosis. To see this particular necrosis, remember that I will always do my CECT in a case of acute pancreatitis after 72 hours, right? It is only after 72 hours that your necrosis is going to appear. So necrosis, what is necrosis? It will not show any contrast enhancement. Your pancreas area will be affected and it is not going to show contrast enhancement, right? Now, if I talk about the necrosis, right, I will classify it on the basis of the age. So if there is no necrosis less than that of 4 weeks and more than that of 4 weeks, less than 4 weeks will be an acute peripancreatic fluid collection and more than 4 weeks will be a pseudocyst, absolutely clear with no necrosis. But once your necrosis will develop, and if it is less than 4 weeks, it is called as an ANC or an acute necrotic collection. And if it is more than 4 weeks, I will say it is a walled off necrosis, right? So quick revision about your various pancreatic lesions and your classical X-ray appearance of chronic pancreatitis. Okay, so I hope this is clear. The double target sign, the cluster sign, which we see in liver abscess, HCC, there is a washout that you will see on the triple phase imaging. And regarding the timings also, arterial phase is 20 to 30 seconds, portal venous is 60 to 70 seconds, and delayed is 3 to 5 minutes. Delayed pay, if there is an enhancement you are seeing, right, there can be two pathologies. One is scar and one is cholangiocarcinoma. These two important pathologies will show a delayed enhancement, right? That is important. Then hemangiomas, you will see this peripheral nodular enhancement with centripetal progressive filling on delayed images, right? Then of course you know about very well, we have discussed about your CVD stone on both the ERCP images and the MRCP images, and beaded and prune tree appearance that you will see in the PSC. I hope everything is clear. Ascariasis, the thin and elongated type of a filling defect you will get, right? So that was all about your hepatobiliary. We have discussed almost all the important pathologies. Now the most favorite, the genitourinary radiology. We have many images over here also. So let's start with the first image. So first image, can you see this? What are you seeing over here? You can see that both the lower chalices, they are meeting in the midline. It's looking like that they are holding their hands. This is called as a hand holding chalices. Also, it is called as a flower shake. It is called as the shaking hand sign or the flower vase sign. This is characteristically seen with your horseshoe kidneys, right? And what is the vessel that will be preventing the ascent of the horseshoe kidneys? It is your inferior mesenteric artery. At what level you will see the horseshoe kidney? At L3 to L5. We are going to do it very quickly. If you have any doubt, please write it in the comment, because we have many images in the genitourinary, many IVP images, RGU images we have to cover all, right? Now you can see the second image. You are seeing a ballooned out pelvis, right? A dilated. This is an IVP image again, ballooned out right renal pelvis. What is this pathology? This is your PUJ obstruction. This is your PUJ obstruction. Before I say the answer, just try to, answer mentally you try to answer all these questions before I reveal the answers, right? Now moving towards our next image, what you are seeing over here? You are seeing that there is a drooping lily appearance. There is a drooping lily sign. So what is this drooping lily? This is actually, I would say, a functioning callicial system. So it's a duplex callicial system, but because there is an upper moiety that is not functioning, it is hydronephrotic, it is creating a mass effect on the lower calyx, right? So that is going to give rise to this drooping lily appearance in the, where will you see? In the duplex collecting system. Now, what is this Wiegert-Meyer law? Just revise with me. Wiegert-Meyer law, remember that with the two moieties, the upper moiety which is there, it will be having an ectopic insertion, and it has there are more chances of ureterocele. Remember, upper is IM, so there is the ureter will be having an inferior and a medial insertion. Now, if I talk about the lower moiety, it will be having a more superolateral insertion, and the lower moiety is the normal site, right? This is the normal location of the ureters, that is superolaterally. That is not ectopic. Ectopic is always upper moiety, and the lower moiety is more commonly associated with your vesico-ureteric reflux, right? So this is about your three important pathologies. Now moving towards our next one, what are you seeing over here? You are able to see that there is a dilatation of the ureters, right, in the lowermost part in the IVP. So this is your characteristic. cobra head appearance, right? So this is your uretroceles or the adder head appearance that you will see in uretrocele, right? Now, what about this particular image? What are you seeing over here? You can see that there is medial deviation of the ureters, right? So this is your maiden waist deformity, and this is characteristically seen with retroperitoneal fibrosis, okay? Retroperitoneal fibrosis, because there is a pull effect, there is a fibrosis, and in the retroperitoneum, it is going to pull this ureters, and sometimes it can also encase the ureters, and it can lead to obstruction, and the patient can present with obstructive uropathy and hydronephrosis, right? So this is particularly seen with retroperitoneal fibrosis, also called as the Ormond's disease, which is an IgG4 related disease. Now moving towards the next image, what are you seeing over here? First of all, identify whether this is an IVP image or something else. Okay, you are able to see over here the urethra as well. So this is actually, I would say, an MCU image. Okay, maturating cystourethrogram. I have injected the dye retrogradely through the bladder. And this is a young patient who is again presenting with UTI. What you are seeing, that there is a reflux of the contrast that is happening in the entire ureter and the PC system. What I am talking about? I am talking about a grade 5 vesico-ureteric reflux. So identify if a ureter is shown, if a urethra is shown to you on such an image, this is particularly they are talking about a vesico-ureteric reflux, and you can see this is a grade 5 because the massively dilated PC system is there with blunting of the cholysis and the cornices, right? So that is about your MCU image, and your viewer grade 4. Now, what about this image? Again, this is an MCU image. You are seeing this characteristic keyhole appearance because of a dilated posterior urethra, as well as the bladder because of the presence of a posterior urethral valve, right? So that is about this particular pathology, the keyhole or the posterior urethral valve that you will see, right? Now moving towards our next, so what you are seeing over here, you can already see the answer. It's a fish hook or an S shape or a J shape, one and the same. You can see that there is a kinking of the urethra because it is, what is the pathology over here? The pathology is that this is actually a circumcaval, okay, earlier also called as a retrocaval ureter, because the ureter which is there, it is going to pass behind the IVC. Actually, it's a problem in the IVC development, not the ureter. IVC has come interior to the ureter, and that has led to this circumcaval type of a ureter appearance. Now, what about this particular pathology? What is this? You are seeing that there are two PC systems on one particular side. What are we talking about? This is your, anyone wants to answer? So this is not your duplex collecting system. Don't get confused. This is your cross-fused ectopic, right? Cross-fused ectopic, the lower pole, okay, of the right kidney is going to be fused to the upper pole of an ectopic left kidney. So this is your cross-fused ectopic, right? So that is about this particular spotter image. Now what about this image? Okay, first of all, identify, is this an IVP or a plain image? So these three are plain images. So look, there is no contrast that is present in the bladder or the ureters. These are bilateral staghorn calculus, okay? Characteristically, history associated with that of UTI, okay? You will get the struvite stones, which are also called as the MAP stones or the magnesium ammonium phosphate stones, commonly associated with E. coli and Proteus infections. Now, what about this particular image over here? You are able to see that there is a completely calcified kidney, which is also called as a putty kidney or the cement kidney. Where you will see your putty or cement kidney, you will see this with the tuberculosis, right? In the tuberculosis, in the end stage and autonephrectomy stage, you will get this type of an appearance. Now, what about this particular appearance? You are able to see medullary calcifications. Okay, so this is characteristically seen with your medullary nephrocalcinosis. Medullary nephrocalcinosis. Now, remember the mnemonic for the medullary nephrocalcinosis. What is the mnemonic? It is FAM. What are the pathologies where you can see medullary nephrocalcinosis? You can see how medullars are calcified in a triangular pattern. So this is seen with primary hyperparathyroidism. You can see with hypervitaminosis D. Okay. Yes, Ritik Soni, sterile pyuria, that is characteristic history you will get for tuberculosis, right? Then type 1 RTA, that is also the distal one. Remember, don't get confused. It's type 1 RTA that will give rise to medullary nephrocalcinosis, right? And M, which is there, it is your medullary sponge kidney, right? Because of the ectasia of the collecting ducts that leads to this chronic calcifications because of the inspission of the urine that will lead to this calcifications, and that will again give rise to this medullary nephrocalcinosis. Now, what about this particular appearance and the IVP? A beaded appearance of the ureter. Again, that will be seen with your tuberculosis. So beaded appearance because of multiple strictures along the path of the tuberculosis that you will get with this. Again, what are the other points you will get in tuberculosis? So you can get thimble bladder, a small capacity bladder. Remember, you can also get moth-eaten calyx. This is the first sign which you will get on IVP. That is your moth-eaten calyx. Then you can also get your phantom calyx and amputated calyx in the tuberculosis. And most importantly, you will also get papillary necrosis. So we have discussed papillary necrosis in detail. You can see my video on FMG predictor series, which we have discussed very recently. I have explained you all the signs of papillary necrosis. We are not covering it right now because of time. But again, that is very important, papillary necrosis. that you can see with tuberculosis. Right, now the second image, yes Ritik Soni, it's right, it's schistoscomiosis. You are going to get this characteristic fetal skull calcifications. Remember which carcinoma is more common and which is tested to you? It is your squamous cell carcinoma, not transitional. More common in schistoscomiosis is your squamous cell carcinoma. Characteristic history with transitional cell carcinoma, you will always get history of a smoking history in TCC. Schistoscomiosis is, remember S for S, squamous cell carcinoma. Now, what is this particular pathology? You can see a bladder shadow also, and there is a calculus that is present in the bladder. This is your jack stone calculus. Okay, you can see that there are these spicules, this projecting spikes. This is a jack stone calculus. It resembles a toy, a jack stone toy. That is why it is called as jack stone calculus. And this is particularly seen with the COD stones, which is calcium oxalate dihydrate stones. Okay, calcium oxalate dihydrate stones, that will give rise to this characteristic jack stone type of a calculus. Now, what about this? Our favorite, a popcorn has appeared again in the pelvis. So you can see this popcorn type of calcification in the pelvis. What is this pathology? This is your characteristic calcified fibroid or a popcorn appearance that you can see in a pelvis. So don't get confused with all these calcifications which I have shown you. Okay, bladder wall, jack stone, popcorn, fibroid. I hope everything is clear to you, right? Now moving towards this next image category, what are you seeing over here? You are seeing over here that there are two stents. What are these names? I just want the name of the stents, nothing else. Okay, so this is your DJ stents. Okay, don't make mistakes in simple MCQs. These are your DJ stents bilaterally placed. Right? What about this particular investigation? Identify the investigation. What is this tube? This is a percutaneous nephrostome tube. I have injected my contrast over here. It has distended the entire PC system up to the ureter. So this is nothing but your enterograde pyelogram. This is an enterograde pyelogram. Okay, I have enterogradely injected the contrast rather than an IVP intravenously. I have injected directly through the percutaneous tube. Right? So that is about these two important images. Now next, what is this image? Identify this fast. Okay, so what is this particular image? This is nothing but your IVC filter, also called as the Hunter's filter, IVC filter. Where we use it for the recurrent DVT so that your DVT don't go into the lungs, right? So that is about your IVC filter. Don't get confused. This is how it is going to appear. You can see the struts that will be arising. The normal location which is there, it is at L1 to L3 level. It is towards the right of the vertebral column because IVC is present on the right side and it is usually infrarenal in location. Okay, it is mainly see to see that there is no strut fracture has happened or it has not migrated. To see the position, an X-ray can be used to identify the IVC filter. Right? Now moving towards few other images. What is this particular image? You are getting this characteristic Swiss cheese appearance, multiple cysts in bilateral kidneys. Also the cysts are present in the liver. We are talking about your ADPKD, right? So this is your autosomal dominant polycystic kidney disease. Again, very important. Now if I talk about the IVP, what you will get? You will get your spider leg appearance because of the stretching of the pelvic calyceal system. Right? Now, if I talk about the most common cause of death, it is mainly because of the rupture of the berry aneurysms, and that can lead to a massive subarachnoid bleed. Right? That is about ADPKD. Now, what about the second image? Now, I will give you a history that the patient is presenting as a newborn, presenting with a flank mass. And if you see this probes in the kidney, you are seeing multiple cysts of varying sizes with no normal renal tissue that is left. So, this is your characteristic multicystic dysplastic kidney. Okay, so two cysts we have covered. We have covered ADPKD, multicystic dysplastic kidney. Now, how can you forget this one? You can see over here, what is this particular? You can see that there is a cystic lesion. Now, can you tell me the Bosniak grade of this particular cyst? Okay, can you see? There is a solid enhancing nodule that is also present in the cyst. So what is this category of Bosniak classification? This is your fourth category. Okay, this is your fourth category. What will be the next step? If you see a solid nodule, you have to definitely operate this particular patient surgically. You have to remove this particular lesion because of its potential to be an RCC. Right? So that is about your Bosniak classification. Just a quick revision. So when I talk about Bosniak 1, again, this is a very potential question. That is why I have included Bosniak 1, no septa will be seen. If I talk about Bosniak grade 2, you will see 1 to 3 septas that can be present. You can see this particular septa, but they will be all less than that of 2 mm width. If I talk about 2F, which is Bosniak grade 2 with a follow-up, that will be more than that of 3 septa, or they can be more than 4 septa that can be present. But I would say that see, the septa can be 4, but the thickness is 3. See, it's very easy to remember. When I talk about 2, it is 2 mm in width. When I talk about 2F, it will be 3. If I talk about Bosniak 3 category, it will be 4. So 2, 3 and 4 rule is present, right? And if I talk about Bosniak 4 that we have already discussed, in Bosniak 4, you will get enhancing nodules. In Bosniak 3, you will get irregular type of septa. In 2F, 3 and 4, always remember you get enhancing septa on a CT image. Right? So that is about this Bosniak classification. Remember, for 3 and 4, they usually ask you what is the next step. The next step is surgical removal. You have to remove them because there is a potential of them to be malignant. Right, now let's move towards this particular pathology. So this is not a cyst, but I would say a solid enhancing mass. Again, this was previously asked, and they may give you a patient history again of smoking, and patient is presenting with hematuria. So what is this? This is your RCC, an enhancing mass that you are seeing in the kid, a heterogeneously enhancing mass in the lower pole of the kidney. This is your RCC. Right, now let's move towards our next pathologies. So again, this is very classical spotter images. What are you seeing over here? Okay, so you are able to see that there is a kidney, 2 kidneys that are fused like a pancake. So this is your pancake kidney. The entire kidney is fused. In horseshoe, only the isthmus is collected. Pancake, the entire kidney will be fused. So that is your pancake kidney. Usually it is ectopic. Ascent is not there. So it is usually located in the pelvis. That is your pancake kidney. If I talk about this, a single kidney that is lying in the pelvis, I would say that this is an ectopic kidney. This is an ectopic kidney. Okay, either right or left, we don't know, but this is an ectopic single kidney over here, right? Maybe a normal kidney is present in the right and the left fossa, and this is one of the kidneys that is present in the pelvis. So they can ask you to identify. Yes, Xavier, it is right. It's pancake kidney. Now, what about this particular image? It's IVP we have already discussed. So this is your cross-fused ectopic. Okay, this is your cross-fused ectopic kidney that is present on one particular side only. Okay, the left kidney is ectopically fused to the right side. Okay, I hope there is no confusion with them. Now, what about this particular pathology? You are seeing that there are multiple fat-containing lesions. Fat ka HU minus 80. We have discussed this as the first slide. So, this is about your multiple angiomyolipomas. Kisme dikhenge? You will see this in multiple tube. You can see this with tuberous sclerosis. Again, that we have discussed, right? More than that of 4 centimeter, I have to embolize that particular lesion because of the chances of retroperitoneal hemorrhage, and that can lead to what? Wunderlich syndrome. I hope this is clear. Right, now what about this? The bare paw appearance. You are seeing this characteristic kidney, a non-functioning kidney, a chronically obstructed kidney, a large stagon calculus can be shown to you in non-functioning kidney. And because your calyces are severely dilated over here, what is going to, it looks like that of a bare paw, right? So this is your xanthogranulomatous pyelonephritis. I'm not writing the full name, we don't have time. So this is xanthogranulomatous pyelonephritis that you will see with the bare paw appearance, right? Yes, Nikki, good going, good going. You are also going for the third hour straight, right? Now moving towards our third image, what you are seeing over here, you are seeing that there is air that is present in the right kidney, right? So this is nothing but your emphysematous pyelonephritis, okay? This is a life-threatening condition, emphysematous pyelonephritis. Immediately you have to do a urgent percutaneous drainage over here, and the investigation of choice. What is the investigation of choice? Past, it is always NCCT. Whenever there is an abnormal air, I will always go for an NCCT. Perfect, right? Now moving towards our next investigation. What is this investigation? Look at the first image. Is it normal? Is it abnormal? You are able to see that I have injected a dye over here. I have injected it retrograde. So this is nothing but your retrograde urethrogram. Okay, this is your retrograde urethrogram. Okay, so remember that there is a normal constriction that is present in the membranous urethra. This is absolutely normal because it is the narrowest part. And in the prostatic urethra, what happens is sometimes you can also see a verumontanum, right? That is a small filling defect that you can see. So that is all normal. Don't get confused with a normal RGU. But what about this particular pathology? I will give you that the patient is having an STD. This is a multiple strictures you are getting over here. So multiple strictures that you are getting in the, especially in the anterior urethra, these are gonococcal strictures. So identify the strictures versus the normal pathology on an RGU, right? So that is about these particular pathology. Now what about this particular image? So you can see the first image, black contrast. What is this? This is your DSA image. You are able to see again a string of bead appearance, especially in the mid and the distal part of the renal artery. This is your string of bead appearance that you will see in the fibromuscular dysplasia. The investigation of choice, as I already said, it is CT angio. But if there will be a renal failure, then I will be going for an MR angio. Particularly, I would say I will go for a TOF angio. I will go for a TOF angio. right? Now, what about this particular investigation? We have already seen this case initially also, proximal renal artery. This is actually an MR angiogram. There is a proximal stenosis in the renal artery. What we are talking about? We are talking about renal artery stenosis, right? We are talking about the renal artery stenosis, more commonly at it is involving the proximal part, renal artery stenosis. Whereas if I talk about FMD, it is more commonly seen in the medial and the distal part. What type of FMD I'm talking about? I'm talking about medial fibroplasia. That is the most common type, and the patient will be presenting in either of the cases will present with resistant hypertension, right? So that is all about these particular imaging pathologies of the genitourinary system. Quickly, we'll revise about your trauma as well as the emergency radiograph also. So the first image you can see, you cannot afford to get this one wrong. This is the most classical one. You are able to see the white pleura sign, right? And you are able to see that there is a absolute translucency with no bronchovascular markings over here. This is your pneumothorax. The classical and the best X-ray that you will do will be a chest X-ray PA view. The best investigation to see any particular air will be your NCCT. And if I talk about the tension pneumothorax, so remember that tension pneumothorax is a clinical diagnosis. If I am giving you the questions, the clinical history of hypotension, of tachycardia, or if there will be distended neck veins, I will not go for any imaging. I will immediately, on as per the current ATLS guidelines, if I am suspecting tension pneumothorax, you have to immediately, okay, so current guidelines is needle thoracostomy you have to do, not thoracostomy, needle decompression. I would use the word needle decompression. Earlier it was second intercostal space in the mid clavicular line, but now they say it's the fourth or the fifth intercostal space anterior to the mid axillary line. Okay, so that is the current ATLS guideline for tension pneumothorax. And then of course you have to manage them later. Once the patient becomes stable, you have to drain through an ICD. Okay, on the supine X-ray, what sign you will get? You will also get a deep sulcus sign. Okay, so because of the air that will be present in the interior costophrenic space, you will get a very deep sulcus. Right, now if I talk about the best investigation, I have already told. Now what about the ultrasound? So on ultrasound and the M mode, okay, I'm not going into the details, I'm sure everyone knows this, but you are going to get your barcode and the stratosphere sign, okay, because of course there is no lung sliding because there is air that is present in the pleura, and you will get this characteristic barcode sign because the granular appearance, the seizure appearance of the normal lung movement will be completely lost whenever there is a pneumothorax. Okay, so quick revision, a barcode and a stratosphere sign you are going to get on a pneumothorax. Okay, so this is not a lecture to explain you, this is just a quick revision so that we cover almost all the points before your exam. Okay, so this is one question is fixed on ADH, SDH, SAH, right? So again, you guys know everything, I have written everything. Okay, so if I talk about the EDH, so EDH you will be getting what? You will get a convex. So this is mainly having a convex appearance, right? A convex appearance, it is associated with fractures, commonly associated with middle meningeal artery rupture, when the parietal temporal bone are fractured, and of course it is not going to cross the sutures. Whereas if I talk about SDH, classical history in the old age patient or associated with battered baby syndrome, again you will see that there will be rupture of the bridging veins that you can see, right? And it is going to cross the sutures. Right, now if I talk about the subarachnoid hemorrhage, the most common cause of subarachnoid, what are you seeing on the, see here you will get a concave appearance, convex appearance on the EDH, concave appearance or convex appearance you will get on the SDH. Now what about the SH? You will get this multiple hyperdensity along all the sulci and along the basal systems, right? Yes, they are ridley shaped. Okay, so SH which is there, it is most commonly, I would say, trauma. So the most common which is there, it is trauma. And if I talk about the overall, see most common traumatic in general, but most common I would say non-traumatic cause. Non-traumatic cause, it will be the berry aneurysm rupture. Now to see the berry aneurysm, what I will do, I'll do a CT angio. Gold standard to see any vascular pathology, kya hoga? It will be DSA, right? So I hope the general concept of your vascular imaging is clear, because we have discussed this multiple times, right? What will happen on flare imaging? So flare imaging mein you will get hyper intense sulci you will get whenever there is a blood that will be present. Yes, of course there is star shape. Yes, star shape appearance of subarachnoid hemorrhage along the basal systems, right? Now let's talk about the this we have already discussed when we discussed about the SWI sequence. You are seeing this multiple foci, especially at the gray white matter junction. This is your diffuse axonal injury. Okay, remember that the CT which is there, it will be absolutely normal over here. Classification system which we use for diffuse axonal injury, an extra H point for you. You use Adams classification on MRI. Grade 1 will be blooming foci that are present on. So these blooming foci, these are microhemorrhages normal on CT, right? So grade 1 may you will see gray white matter junction that will be involved. Yes, Xavier, ACOM, that is the most common site of rupture. Yes. Now, if I talk about your second most common site, that will be your corpus callosum. The third most common site is brain, not the common site. The third will be the grading. So, stage 3 will be when the brainstem will be also involved. Remember, then when I talk about grade 2, it is grade 1 plus 2. So, gray white matter junction plus corpus callosum, that is 2. If I talk about grade 3, it will be 1 plus 2 plus there will be involvement of brainstem, right? So that is about your diffuse axonal injury. Sequence of choice will be SWI. Also, you may see diffusion restriction on the DWI images. What about this particular pathology? This is your pneumocephalus, especially if you can see over here, there is an extension that you can see along the falx. This is Mount Fuji sign for tension pneumocephalus. Again, an emergency. You have to immediately drain this, right? So let's talk about the other signs. What are you seeing over here? This is your pneumomediastinum. Again, they can give you this. What? So this is not pneumomediastinum. See what? Just a minute. First of all, see this particular image. Let's focus on this image. Okay, this is not pneumomediastinum. Carefully look at this particular image. Where is the air that is present over here? It is present in the subcutaneous tissue. This is giving rise to a ginkgo leaf appearance. So this is characteristically seen with the subcutaneous emphysema. This is seen with the subcutaneous emphysema. Okay, so this is looking like that of a ginkgo leaf because the air is going to get collected in the pectoralis major. So this is your subcutaneous emphysema. It is commonly associated with pneumomediastinum, right? So that is about this particular thing. So, okay, so Xavier, this is your ginkgo leaf sign. I'll just write it down for you. It's a ginkgo leaf sign. Now, if you talk about this particular sign, you are seeing a continuous diaphragm sign, right? The air you can see over here, trap between the heart and the diaphragm. So this is giving rise to continuous diaphragm sign, that is in pneumomediastinum. What other sign you get in pneumomediastinum? You will also get what other sign? You will get the Neclarios V sign, especially with Bohr-Harvey syndrome, right? You will get a collection of air somewhere over here between the dome of the diaphragm and between the descending aorta. So that is your Neclario V sign that you can get with pneumomediastinum. What other sign you can get on the CT? You will get the ring around the artery sign, a rounded lucency that you can see around the artery, right? Now, what about, see, most sensitive investigation, anywhere I want to see air, pneumomediastinum, pneumoperitoneum, anything, my answer will be always NCCT. My answer will be always NCCT. Okay, look at the first sign. What are you seeing over here? So you are able to see that there is a massive collection of the air. Patient presenting with abdominal pain, especially in a supine X-ray, in a pediatric patient, you will get this particular sign. This is, you can see free air, lots and lots of free air, massive amount of free air. Yes, spin maker sale sign also you get, Xavier, right? Perfect. Right. So when I talk about the football sign, this is again indicating a massive pneumoperitoneum that is especially seen in supine patient. Now you can see over here, you can see that the falciform ligament over here, you can see very well the air is defining my falciform ligament. Sometimes the bowel ball can also be seen. So that is the regular sign. This particularly is your falciform ligament sign. This particularly is your falciform ligament sign. Okay, now what about this? This is simple, free air under diaphragm. Always whenever a chest x-ray is given, never forget to look beneath the dome of the diaphragm. See, this is normal gas shadow. Here there is an abnormality. This is free gas that is present under the diaphragm. The best x-ray to see free gas under the diaphragm is definitely your chest x-ray PA view. What about if the patient cannot stand? If the patient cannot stand, what I am going to do? I am going to provide a left lateral decubitus. So whatever the option is given, if cross-stable abdomen is given, then please choose your answer as cross-stable abdomen. Here I am going to pass an horizontal X-ray beam. So you will particularly see a very good level with the free air, right? So that is about these two important X-rays. If the patient cannot stand, either you do a decubitus or either you opt in a cross-stable abdomen view. Now I am giving you a clinical hint that, again, this is very important from your FMGE exam point of view. A 6-month-old infant is brought with excessively crying and parents give a vague history of fall from bed. And you're getting this characteristic X-ray. Please think, please answer this particular thing. Okay, so what are you going to see over here? This is your metaphyseal corner fracture. What is this classically seen with battered baby syndrome or the non-accidental injury? This is a deliberating hurting of the small children, right? And you will see this false history or some gaps in the history you will always see. Like for an example, a fracture that is present in the leg of an 8-month-old who is absolutely non-mobile. He is not walking also. So some vague history they will give you. You will get this classical fractures of metaphyseal corner fractures you can get, which are also called as a bucket handle fractures. What other fractures you will get? Start thinking, give me all the findings of battered baby syndrome. All the findings, metaphyseal corner, bucket handle we have discussed, but other findings you will get posterior rib fractures. You can get retinal hemorrhages and subdural bleeds, right? What else you will get? you will get green stick fractures, only the outer cortex, because of this bending forces, right? You will get this particular type of fractures. So main thing is bending and twisting and squeezing that will give rise to all these particular complex pathologies, right? So this is the green stick fractures. You can get the posterior rib fractures. You can get multiple fractures in different stages of healing. What is the important differential? Osteogenesis imperfecta. But over there, the bones are also osteopenic. Plus, you will get this classical history of blue sclera, right? Dentigerous imperfecta in osteogenesis imperfecta. Spiral fractures you can get in non-ambulatory child, and SDH and retinal bleeds you can get, right? So that is all about this important pathologies regarding your battered baby syndrome. Now, a quick word on the fast and the e-fast. So now we are using e-fast, which is an extended fast. So any unstable patient is coming to you, the first investigation which you are going to do is an e-fast, right? E-fast is what? It is an ultrasound, right? It's an absolutely fast method. You can do it in unstable patients, no radiation, no contrast. The probe will be put in the right upper quadrant, the left upper quadrant, in the midline, in the pelvis and the subxiphoid region, and along the interior and the left side of the chest. So that is about a quick word on the e-fast. Now, if I talk about a patient who is coming to you with major trauma and is unstable, first step I will always do is resuscitate the patient. I will always do resuscitation and volume replacement of this particular patient, right? And another thing is you will also do volume after this. You will do the e-fast, right? If the e-fast is positive, what does a positive e-fast means? That there is hemoperitoneum or there is presence of the fluid. In that cases, I will proceed with an exploratory laparotomy. But suppose if the e-fast is also negative, after my patient is stabilized, I will go for a whole body CT. I would all go for the whole body CT, which is CCT, abdomen, head, spine, abdomen, to rule out the other pathologies, right? So that is about your approach to the major trauma, right? Now let's talk about the stroke imaging. The first investigation which you are going to do in the stroke is always an NCCT. Okay, so don't get confused. First investigation, if my patient is coming to me for the stroke, I will always do an NCCT to rule out bleed. To rule out bleed, I don't want to thrombolize the patient if there is presence of a bleed, right? Now, what are the signs which you will see on a CT, especially in early sign? The most early sign you can see over here. What is this particular sign? This is your hyperdense MCA sign. Okay, this will be seen in less than 6 hours, even before the hypodensity is going to appear, even before there is loss of gray white matter differentiation, and this actually indicates that there is presence of thrombus, that is in the MCA. So this is the sign that you can get. Now what about if they ask you that the most sensitive investigation in less than 6 hours, CT is absolutely normal, and you are still suspecting that there is a stroke, less than 6 hours, my most sensitive investigation will be DWI. Okay, we have already discussed the DWI in detail. DWI pe you will be seeing this. Best investigation is MRI. Yes, I will say definitely most sensitive investigation which is there, it is definitely your DWI. But for your exam point of view, remember that the first investigation you will always do an NCCT if you are suspecting a stroke. Okay, if they are still asking you that most sensitive less than that or 6 or something like that, if they are giving in the clinical question, then mark your answer as DWI. Right now, if I talk about what about the penumbra and infarct? So we are talking about your perfusion imaging, right? So if in the perfusion imaging, I want to differentiate between penumbra and infarct. So what is infarct? Infarct is the dead core, right? And penumbra, which is there, it is still, I would say, that we can revitalize that particular area. The blood flow which is there, it has decreased over here, but still there are collaterals. And if I do a thrombolysis, I can actually save this particular area because it is not completely dead. So I want to differentiate between penumbra and infarct so that I can decide whether I can thrombolyze this patient or not. And for that, I will be using a CT perfusion. So quickly we will discuss that whenever I talk about a penumbra, remember that, see, if I talk about infarct as well as in penumbra, your cerebral blood flow is going to decrease, which is the flow of the blood per unit time, the mean transit time, the time that will be taken for the blood to move into that particular area, right? In the area of the infarct, that is definitely going to increase in both infarct and penumbra. The time to peak, that will be also increase in both infarct and penumbra. But the main differentiating point, and this could be tested, that is your cerebral blood volume. So cerebral blood volume, which is there, it will be normal. It will be normal if I talk about, or it will be rather increased if I talk about a penumbra because of the collaterals. Because the brain is still trying to preserve that area through the collaterals. That is your penumbra, that will have a normal cerebral blood volume, right? I hope this is clear to you. Right, now let's move towards this particular. So as I said, that the investigation of choice for an hyperacute stroke less than 6 hours, it is your DWI. Remember that in the early stage, even the abnormality is not seen on flare. It is only seen on DWI. ADC will be black. That is DWI flare mismatch less than 6 hours. It is an hyperacute stage. If I want to see a large vessel occlusion, again, I have told you many times, investigation of choice will be your CT angio. Right. Now let's talk about this particular pathology. So hematuria after an RTA, what is the investigation of choice? Hematuria after RTA? You will always do a CT cystogram. It will be a CT cystogram. Okay, what are you seeing over here? You are able to see a molar tooth sign. You are able to see that this is associated with extraperitoneal rupture of the bladder. So this is an extraperitoneal bladder rupture. What is going to happen? You will get the contrast. If I am retrogradely injecting my contrast in the bladder and I am obtaining a CT image, you are obtaining this large amount of the contrast in the perivesical spaces, right? So that is characteristic for extraperitoneal rupture. How will you manage? I will do an SPC, or I will do a conservative management. Remember, this is more commonly seen with blunt trauma and more commonly associated with your pelvic fractures, right? Now, if you can see the second image over here, you are seeing that the contrast is between the bowel loops. This is your intraperitoneal bladder rupture. The management over here will be surgery. You have to do an exploratory laparotomy if you see such a type of an image. Where else will you see a molar tooth sign? The molar tooth sign you will also see with the Jobart syndrome. Okay, on an MRI brain image, you will see on the axial section because of the elongated superior cerebellar peduncles. Right, now what about this image? You are able to see a pear-shaped bladder over here, right? So pear-shaped bladder, you will see if there is an extrinsic compression. So this is characteristically, or a teardrop also, right? One and the same. So this is mainly seen with pelvic hematoma, I would say. Pelvic hematoma, because it is compressing the bladder, right? It is going to compress the bladder. One more pathology will also give this pear shape, and that is your pelvic lipomatosis. Right? Now, another important point I want to, because we're talking about bladder trauma, if there is a question that is telling you that the patient is having blood at meatus, right? Or if there is a high riding or a floating prostate, okay, means they are pointing towards a urethral injury. In a urethral injury patient, I will never do Foley's. Okay, very important for your exam point of view. Never do Foley's whenever you are suspecting a urethral injury. Okay, I will always do an RGU first, and I will rule out a urethral injury followed by suprapubic cystostomy. Right? I hope this is clear. Okay, now very important part again I am coming over here is regarding your foreign bodies. So foreign bodies may, if you can see that, if you see a single radio opaque density over here, that is your coin. Right? Now if you see that there is a double appearance, or you can see on a lateral x-ray if there is a step appearance, right? What I am talking about? I am talking about a button battery. Remember that the more dangerous one which is there, it is button battery, because it is alkaline and it can lead to perforation. So it is very important to identify both coin as well as the button battery in a esophagus, right? Now, if you can see the second image over here, how will I identify whether my body, foreign body, is present in the esophagus or it is present in the trachea? So remember, in the esophagus, because esophagus is distensible, it will be appearing end face. It will be appearing like a round on an AP view. If I'm talking about a esophageal foreign body. Apart from this, can you see the trachea which is there? It is pushed aside. This means that my foreign body is actually present in the esophagus. Now, if you can see the second image over here, this is again the same image, and this is actually a lateral view, and you can see that how well it has accommodated into the esophagus. Now, if you see this particular image, you can see that over here the foreign body which is there, it is actually present like a ring, like a slit, like it is present into a structure. So this is mainly, it is present in the trachea, because what happens is trachea which is there, it is relatively rigid, right? It has to pass through the larynx, through the vocal cords, so it has to adjust itself, right? The trachea is not allowing itself to adjust. The coin has to adjust, and so that is why the coin which is there, it will appear like a slit on a PA view. So this is how you will differentiate between the coin that will be present on a esophagus or whether it is present in the trachea. Right? I hope this is clear to you. Now, I am giving you some important x-rays. I will tell you that the patient is a 2-year-old child who is present with a sudden respiratory distress. Okay, so not seen very nicely. This is patient who is present with a sudden respiratory distress, a 2-year-old child. And you are seeing this particular x-ray. Again, you can see that there is a foreign body that is present over here. You can see that there is a foreign body that is present. But apart from this, you are also able to see that this is a unilateral translucency that you are seeing in the right lung. Okay, a unilateral translucency you are seeing. This is hyper expansion that is seen. This is mainly because of the air trapping that you will see. So what happens if there is a foreign body that is only partially obstructing, that will lead to a bowel wall mechanism, in which what happens is that the air is going to pass. Okay, the air is going to pass through the bronchus, but what happens, it is not going to exhale out. It will not be able to come out, right? And that is why it will lead to this expiratory air trapping. The best x-ray will be chest x-ray, PA view, and I would say the best X-ray would be the best phase would be an expiratory phase. Okay, to see this air trapping, the best phase will be an expiratory phase. Yes, ball and valve effect, Xavier. Yes, I'm talking about the ball and valve effect. Now, if you see this particular X-ray, what is happening? Again, the same history. Patient presenting with sudden respiratory distress, but here you are seeing a complete collapse has happened. This is what, because of the tracheal, there is a complete collapse. You can also see there is a volume loss. There is a ipsilateral tracheal shift. Here the foreign body has completely obstructed the lumen, right? A complete obstruction of the bronchus has taken place, and that is why it has led to complex. So look at the question. If they are giving you a 2-year-old child with sudden respiratory distress, they are particularly talking about foreign body. Both the images, okay, maybe partial obstruction, maybe a complete obstruction. It can present as any of these X-rays to you on the question. Right now, if I talk about this particular X-ray, a 54-year-old, I'll just mark it for you, 54-year-old patient who is presenting with severe respiratory distress in the ICU. And what are you seeing over here? You are seeing that there is a complete whiteout lung again. Okay, a complete whiteout lung. What is the main problem? Can you look it very carefully? There is a problem over here. You can see that this endotracheal tube which is there is a faulty aeration of the right bronchus. There is a faulty aeration of the right bronchus. Normally, the ideal position of the ET tube, it should be 5 centimeter above the carina, but if it is present in the right bronchus, can you see? So there is a aeration of the right lung, but a complete collapse of the left lung. Okay, so I hope this X-ray is also clear to you. Again, very important from your exam point of view. Now, this particular X-ray, again, sudden onset respiratory distress in a child. Again, think about foreign body. Where is the pathology? Right side or left side? Which part is abnormal? I'm not even able to see any foreign body, but I'm telling you that there is a foreign body. So this is actually, I would say, a peanut that the patient has ingested. If there is a peanut ingested, will it look hyper? No, it will not be seen on the X-ray. It is not radio opaque, right? So the pathology which is there, it is over here. This is relatively translucent as compared to the right side. Again, because of the air trapping and ball valve mechanism, right? So look at the clinical hints that are given to the question with the foreign body. I hope everything is clear regarding all the foreign bodies and the collapse which we have discussed. Right now we are short on 20 minutes only. What can we cover? So should we cover nuclear medicine or should we cover radiotherapy? Whatever you say. I think nuclear is more important. So let's cover nuclear only. So when I talk about nuclear medicine, just a quick revision. When I talk about radio tracer, it is a combination of radioisotope plus a ligand, right? So radioisotope, which is there, it is mainly technetium-99m and iodine-131. These are more commonly used agents, as well as the F18. These are your radioisotopes that are going to emit gamma rays or either the positrons, and that we are going to pick up with the either our PET imaging or the gamma camera, right? And if I talk about the ligand, that is one that will be going towards a particular tissue, right? For an example, if I talk about DMSA, it is going to bind to the renal cortex, right? So that is the main funda regarding this thing. Now, if I talk about the nuclear pathologies, the modalities, the first modality which was there, it was scintigraphy or nuclear scan or radioisotope scan. So it was a 2D scan. Then we modified it to SPECT scan, which is single photon emission computed tomography. This was a 3D scan, right? Both will be basically detecting your gamma rays. Main radioisotope which we use will be technetium-99m. What is the half-life? 6 hours. What is it going to emit? It is going to emit your gamma rays. What you will be picking up with? Picking up with the gamma camera or the Anger camera. Remember, nuclear imaging is nothing but your functional imaging. It will give you an idea about the function of that particular pathology also. If I talk about the PET scan, it is your positron emission tomography. Okay. What happens over here? The radioisotope which you are using is mainly your 18F, right? That is going to emit the positrons. Ligand we use is the deoxyglucose because of the principle of the Warburg effects. What is going to happen? It is the mainly aerobic glycolysis because the cancer cells are very glucose hungry, and so because they will be taking up all the glucose whenever we give the FDG, and that will be appearing as bright. Right, the half-life of F18 is 110 minutes. Of course, the test that you will be doing before the PET, that will be your glucose. So you have to basically see the blood glucose, right? Now, if I, yes, Xavier, radiation exposure in PET CT is highest. It is approximately, say, 20 to 25 millisieverts. So that is really high if I talk about PET CT. Now, what are the PET negative tumors? So it is mainly your carcinoid tumors, the bronchoalveolar tumors, as well as your mucinous adenocarcinomas, okay? All of you will be getting the PDF. So we are going little quick. We only have few minutes left. So you will get the PDF and you can just revise all these things, right? Now, what about the importance of nuclear images? So you can see over here that here you can see that there is no uptake that is present in the kidneys, but there is a massive uptake that is present into the bones. Okay, so this is what this particularly is your super scan. This is your super scan. So what happens in a technetium 99 MDP scan, if there is a diffuse bone metastasis or say hyperparathyroidism or Paget's disease, what is going to happen? What will happen over here? That will lead to this super scan type of an appearance in which the kidneys normally appear on MDB scan, but if the no contrast is left, okay, no tracer is left for the kidneys to be taken up, so that will give rise to the super scan appearance in which kidneys will not be seen. What about this? This is your characteristic Honda sign or the sacral insufficiency fractures that you will see. Right now, what about this particular sign? So very favorite panda sign you can see in sarcoidosis because of the uptake in the lacrimal glands, parotid gland and the nasopharynx. What about the lambda sign? Lambda sign you will see, this is all gallium 67 scan which we are doing. You will see it in the right paratracheal and bilateral hilar lymph nodes, right? So that is your sarcoidosis that you will get. What about this? So elderly smoker history I am giving, and you are seeing that there is an hot uptake that is present in bilateral parotid glands. So hot uptake, bilateral parotid glands, what I am talking about? This is again with the technetium per technetiate scan which I am talking about. So this is Warthin tumors. These are your Warthin tumors. Remember, pleomorphic adenoma, they will be cold. They will be cold, right? Now let's talk about these particular signs. So when I talk about the iodine, Graves disease, you will see a diffusely increased uptake. Toxic multinodular goiter, what you will see that there is usually, again, multiple nodules can be seen or sometimes single nodule that will be suppressing rest of the thyroid, right? Especially you can see this particular case, toxic adenoma, a single nodule suppressing rest of the thyroid gland. So these are your characteristic diagnostic iodine 123 scans. Again, remember iodine 123, the half-life is what? 13 hours. What are the agent we are using? We are using technetium 99M per technetiate scan. Iodine 125, what is the half-life? It is 60 days. And what is it going to emit? It is going to emit the gamma rays. We use it in characteristic brachytherapy. You must have seen the interstitial seeds in the prostate cancer. There is where we are using iodine 125. Whereas iodine 131, it is mainly emitting both the beta and the gamma rays. It is mainly used for the treatment as well as the whole body scan, right? It is particularly used in the papillary and the follicular cancers. Now remember that which are the carcinomas which are non-avid, which are not going to take these particular scans, that is your anaplastic and your medullary carcinomas. They are not going to show any particular uptake, right? If I want to see any metastasis, any residual lesions, I am going to use iodine 131. Okay, so all the three agents, they have all three different roles. And about the half-life of iodine 131, that is 8 days. That is 8 days, right? So let's talk about an important table for the nuclear. So almost all of your nuclear scans we have covered in this particular image. So let's talk about renal. So remember that static. I'm going to quickly read this for you. We are going to say, yes, Xavier, iodine 123 is mainly for diagnosis and iodine 131 is also used in diagnosis, plus it is used in treatment. Iodine 125 is mainly used for the prostate brachytherapy. Now talking about the renal scan, the static scan, DMSA scan, which is there, it is mainly a cortical scan, mainly used for pyelonephritis scars and vesico-ureteric reflux. Okay, it's a static scan. If I talk about DTPA, we will use it for GFR. If I talk about the MAG3 scan, it is particularly used for renal function, renal plasma flow and the tubular function. Okay, cardiac, again, it is important when I talk about perfusion. If I want to see the blood flow, I can use Sesetamobi scan, tetrophosphine or N13 ammonium. Thallium was used earlier, but for your MCQ point of view, you can remember thallium will also will be under the perfusion category. Myocardial viability. Okay, I want to see whether the tissue is dead or not. For viability, I will do a FDG PET scan. Right, that is an important question asked in INI-CET also. FDG PET you will do for myocardial viability. Dead tissue will be appearing as a cold spot. If I talk about myocardial infarction and hot spot imaging, okay, dead tissue appearing hot, that will be on a pyrophosphate scale. Whereas if I want to see the ejection fraction, if I want to see the MUGA, if I want to see the LV ejection, I will do a MUGA scan. That is nothing but technetium 99M labeled RBC. Right? Yes. Now, if I talk about the skeletal findings, again, bone scan, the hot spots, osteoblastic mets, fracture infection, technetium 99 MDP is the agent of choice. Multiple myeloma will be appearing as cold spot. Biliary tract, we have already discussed in detail. HIDA scan for biliary atresia, acute cholecystitis, no visualization of gallbladder on 4 hours. If I give morphine, then it will be 1 hour. And if I want to see bile leak, more sensitive investigation to see the bile leak. Thyroid scan we have discussed in detail. For parathyroid adenoma, we use the technetium Sesetamobi scan. Right? Meckel's diverticulum, we use the technetium 99M per technetiate scan if I want to see the ectopic gastric mucosa. Okay, if I want to see the neuroendocrine tumors, earlier we used to use the octreotide scan or the somatostatin receptor scintigraphy. But nowadays we are using gallium-68 DOTATOC or DOTANOC scan, right? So if both the options are given, mark your answer as gallium-68 DOTATOC, DOTANOC. Similarly, for pheochromocytoma, F-DOPA PET will be a better answer as compared to MIBG. If I talk about a prostate cancer, PSMA PET is mainly used nowadays to see the metastasis. That is a better answer, PSMA PET scan. Okay, and if I talk about Parkinson's imaging, this is again a high edge, and I feel that this is a little extra edge for you. So that scan which we are using, dopamine transporter scan, we use iodine 123 ioflupine scan to see the nigrostriatal dopaminergic neurons, right? So normally kya hoga? This is going to show an increased uptake in caudate and putamen, right? What happens in the Parkinson's disease? Earlier there will be, what happens? There will be loss of uptake in the posterior putamen. Okay, so normally this is going to show a coma appearance. Okay, you can just see this image. I have not included it because of the shortage of time, but in my lectures you can see this. So in coma scan, you will be basically seeing whenever there is a normal uptake in caudate and the putamen. But if there will be a decreased uptake, what happens? Eventually this comma is going to get converted into a dot sign. So dot sign on an ioflupine scan is characteristically for Parkinson's disease, right? And first, the uptake which is there, it is going to go in the posterior putamen, followed by anterior putamen, and then followed by caudate, right? So that is about this particular things. Okay, radiotherapy, I don't think so we have that sort of time to cover radiotherapy. I will just cover few important points. So we have two types, teletherapy, brachytherapy. Brachytherapy means we are putting the main radiation source will be very closely in contact with the patient's cancer. Like for an example, intracavitary or interstitial type or mold type of brachytherapy, and teletherapy will be from a distance, right? So two important sources are there. One is a cobalt-60 source that will be emitting your gamma rays. LINAC will be emitting your X-rays, which are linear accelerators. Which is the better one, which we are using nowadays? We are mainly using your LINAC ones, right? Now remember, so these are all theoretical points. I think the PDF will be shared with you, so you can just revise them. Okay, I have made some small mnemonics also that you can use. Two important points I wanted to cover is regarding this temporary implants. Okay, the choice agent for the cervical cancer, this was asked, so that is why I'm covering. Choice agent for cervical cancer brachytherapy is your iridium 192. Is your iridium 192. Earlier we used to use cesium 137, that was low dose radiotherapy, but nowadays the choice agent high dose is iridium 192. Okay, now if I talk about what about this particular image, so this image which is there, it is the Lexel frame. This is the stereotactic radiosurgery, okay, also called as your gamma knife surgery. Lexel frame, why we use this Lexel frame? Because of the 3D coordinate system, and that is going to target your brain tumors very excellently with very good precision and accuracy. It is mainly used in brain AVM tumors and the acoustic neuromas. Right, so that is about, yes, they were correct, iridium 192. Now if I talk about this particular image, this is your LINAC, this is your cyber knife. Okay, why cyber knife? Why it is called cyber knife? This is mainly because it is using LINAC, or it is mainly using your X-rays. This is mainly targeting your body tumors. For brain tumors we use gamma knife surgery. Okay, and that will be using what? That will be using cobalt-60 as the source. Okay, but for the body we are using LINAC or the X-rays. That is for the body tumors. Okay, what about proton beam radiotherapy? If I talk about proton beam radiotherapy, again it's a type of teletherapy only. You will get this characteristic Bragg peak. So whenever the X-rays are emitted, what is going to happen? With increasing distance in the body, their intensity will decrease. But for protons, as it will be coming to a stop, before just coming to a stop, there will be a rapid peak in its intensity, that is called as the Bragg peak. And because of this, what is going to happen? It is going to spare your normal tissue, all this particular part. Okay, the normal tissues could be spared, and it is going to target your bone, your particular tumor that is present deep. Okay, so particularly used in skull base chordomas, head and neck tumors, and uveal melanomas. If I talk about the boron neutron chemotherapy, so just remember that it is particularly used for brain tumors. Okay, BNCT is particularly used for brain tumors. Particularly it is used in GBM, and it is also used in melanoma. I give an IV boron. Boron has this characteristic point that it goes to the tumor cells. I will be bombarding it with the neutrons, and then borons and neutrons together will be giving this alpha attack. This alpha particles, okay, this alpha particles will be having a very high linear energy transfer, and it is going to destroy your tumor cells. So that is about your boron neutron capture therapy. Okay, so we are just towards the end. Remember that if I talk about the self most radiosensitive phase, it is your G2M phase. The radio resistant which is there, it is your S phase. The most sensitive organs will be your gonads. The most resistant one will be your vagina in the organs. Tissue most sensitive will be bone marrow. Most radio resistant will be nervous tissue. If I talk about the blood cell, particularly most radiosensitive is lymphocyte, but the most radio resistant will be your platelet. Right? Now about the radiation protection. So radiation protection, we have two important things, that is your lead apron and your TLD batch. TLD batch you need to remember that it is mainly that it is going to record the radiation that is received by the radiographer or any worker associated with radiation. Remember that this is reusable. Okay, don't get confused. This is reusable. What does TLD stand for? Thermoluminescent dosimetry. We have a TLD reader. It is going to emit the light in proportion to the amount of the X-rays that are being present, right? And that will give rise to this characteristic. It can measure the radiation. So it is sent to AERB every 3 months. Every 3 months, right? Now let us talk about lead apron. So lead apron, of course, it is going to absorb your scatter radiation. It's very heavy, right? So we have got better lead-free alternatives also that are made up of antimony, bismuth, tungsten, and tin. Okay, so that is all about this. Okay, now if I talk about the thickness, it is made up of 0.5 mm lead equivalent. This much amount of lead is required to absorb these 98 to 99% of the scatter radiation. Okay, so these are all radio sensitivity. I think I will not be able to cover these particular points. You can just see through the PDF. This is the important one-liners. Chest X-ray, it is 0.02 millisievert. It could be tested. CT head is 2 millisievert. Chest is 6 to 8 and abdomen is still more, 12. And PET CT, as Xavier has told us, it is 25. The highest of all is PET CT, right? Radiation effects could be deterministic and stochastic ones. So deterministic, as the name said, you can determine it. A threshold is present, right? And again, it's an all or none phenomena. It will be skin erythema, cataract, infertility, and alopecia. All these will be direct effects that you can see on the skin or on the hair. So that is the deterministic one. Stochastic one are more like somatic mutations and cancers. So there is no threshold that you will need in that, right? And what about the limit of the doses? So effective dose, the limit for the occupational workers, it is 20 millisievert per year. For public, it is 1 millisievert in a year. This is averaged over a defined period of 5 years. Okay, so that is about this particular effective dose. Now annual equivalent dose for the lens of the eye, it is 150 millisievert. Okay, and it is for the public, it is 1 millisievert. For the skin and the hands and the feet, it is 500 millisievert, and it will be reduced to 50 millisievert. 10 you have to remove for the public. Okay, what about pregnant patient? Once a worker has declared herself as pregnant, okay, in that particular case, the dose should never exceed more than that of 1 millisievert. Okay, this is again an important question that could be tested. Right, I hope this is clear. Image contrast is predominantly determined by. So again, just try to answer if any one of you are there. Image contrast is predominantly determined by KVP, MAS, exposure time, and tube current. If you want to choose one single best answer over here, please answer this question for me. So the answer over here is KVP. Okay, the answer is KVP. Remember that the KVP, the concept is that low will be the KVP, lower will be the KVP, higher will be the photoelectric effect, and higher will be the contrast. Okay, so if the question is given to you that there are 2 KVP, 70 KVP, 140 KVP, what will you mark? For a better contrast, you will mark your answer as 70 KVP. Okay, so the answer is KVP. Very important. Lesser will be the KVP, more will be the photoelectric effect, and better will be the contrast. Right, now let's talk about the contrast medium. I think so. So we have already discussed about the sonoview. So ultrasound contrast agents, the inner part that is made up of 1 to 10 micrometers, right? That is sulfur hexafluoride, that is surrounded by a phospholipid layer for the stability. You all know that this will be eliminated by the liver. The gas will be eliminated by the lungs. So it is absolutely safe in what? It is absolutely safe in your renal failure patients. So safe in renal failure, not to be given in cardiopulmonary. Contraindication is not to be given in cardiopulmonary instability and pregnant and pediatric patient, especially if there is also right to left shunt. I will never give an ultrasound contrast agent. What about the barium? So barium, again, we have discussed contraindication. You will not give it in perforation, TE fistulas, again because of peritonitis and per se because of risk of aspiration pneumonitis. What is the double contrast barium? So double contrast is if I will be giving air plus barium. Okay, if I want to see my mucosal pathologies, my better image which is there, it will be obtained with a double contrast agent, right? Yes, Xavier, perfect. Safe in renal failure. Now, what about the iodinated contrast agent? So, iodinated, two important ones you have to remember. We have a complete classification, but now for the revision point, I think it's okay if you remember these two. Iohexol osmolarity, it's in the low osmolar category of 600 to 800. Whereas if I talk about iodixanol, it is 280 to 300 milliosmoles per kg. Remember that iohexol is a non-ionic monomer, whereas if I talk about iodixanol, it's a non-ionic dimer. Ratio is 3 is to 1, 6 is to 1. Remember 6 is to 1, definitely it's a better ratio. How did I obtain the 6 is to 1 ratio? Non-ionic, so definitely they are not going to ionize, so there will be only one particle. If I talk about dimer, so 2 rings, so that is why 6 iodine rings will be 6 iodine atoms will be there. In monomer there will be only 3 iodine atoms because of a single ring. Okay, remember we give this always as, we can give IV, we can also give it orally, but preferably we give it as IV. And remember that investigation before CECT and CEMRI could be tested. It is always serum creatinine or RFT, whatever is given in the question. Right? Right, perfect, Xavier, right. And if I talk about Magnevist is basically a gadolinium contrast agent. What is the main funda? We have already discussed in the beginning also. It is going to decrease your T1 time, so that is why it is going to appear bright on the MRI images. We will be obtaining a post-contrast T1 weighted image. The eGFR which is there, it should be less than that. If the eGFR is less than 30 ml per minute, it's an absolute contraindication because of increased risk of nephrogenic systemic fibrosis. We never want nephrogenic systemic fibrosis because it cannot be even treated with dialysis, right? So it's a very life-threatening condition resembling that of a scleroderma, right? So eGFR should never be less than that of 30 ml Ag. Okay, so that is about your various gadolinium contrast agent. What is contrast-induced nephropathy? Especially if I talk about, if within 48 hours of the administration of the iodinated contrast, if the serum creatinine it increases more than that of 0.5 milligram per deciliter or more than that of 25% from the baseline, then that is your contrast induced nephropathy, right? So this is again an important definition, could be tested in your examinations. So I'm glad that I have covered almost 158 slides in a span of 40 hours. I'm really glad, and we have covered almost all the high yield images before your exam. So go quickly revise. I will be uploading the PDF very soon on the app and also in the comment section. We'll make sure that everyone gets the PDF, whoever has attended the lecture. And the star was definitely Xavier, was very good in answering today. Nikki was also extremely, she answered almost every question. I don't know she is here right now or not, but yes. So we have also started a series on Instagram, and we are covering some very high yield images every day. So do follow me on Radiology World on Instagram, and we will definitely connect over there, right? So this was all about today's class, and I hope that you like the section. Yes, Nikki is here, and Dr. Khan is also here. So I really enjoyed the session. Hope you like the session as well. And we have tried to cover really everything, right? So, but you have to revise, right? So all the best for your exam. I'm sure everyone is going to do very good. And thank you so much. Good night.